এসে গেছে, শুরু হয়ে যাচ্ছে। Good morning, everyone. We start our program today. How do you feel? Good? Good. Okay. So, in the month of August, we start a live demonstration of hemodynamic workshop from our esteemed institute, Desun Hospital. The first speaker is none other the most stalwart in our city, so as to say, he brought the critical care department to the eastern region of India. Our teacher, our guide, our philosopher. The name is Dr. Subhash Todi. A big clap for him. Dr. Todi has done his MBBS and further done his MD from MD Medicine. Thereafter, he did his MRCP and went on for the Emergency Medicine Director, Critical Care, AMRI Hospital, Dhakuria. The next stalwart, Dr. Anupam Goswami, has come and they are actually meeting each other. Thank you, sir, for coming. So we now start the program with Dr. Todi to lead us from the first. Sir, on stage.
Okay, thank you, Paramita. Now, how long do I have, Paramita? How long do I have? Lecture time? Half an hour. Okay. So basic physiology. Physiology is always basic. So within basic, I'm going to talk just basic of basic physiology. So it is going to be interactive. So please participate. Very simple questions I will put to you. And let's see how you evolve the physiology. These are the terms we use on our daily practice. Not very clear about these terminologies. How do they apply to an individual patient? Preload, volume status, preload responsiveness. How do we apply this to a particular patient? So let me ask you, a lot of you young intensive care aspirants and intensivists, if I put a central line in you now, what will be your CVP? How many would you say 0? 4? 8? 10? So in a sitting position, what will be your CVP? So what is a normal CVP? We talk about CVP usually in a supine position. Even in a supine position, a normal CVP or even right atrial pressure is somewhere between 0 to 4. So in a normal person, in a sitting position, it will be 0, even be minus if you take a deep breath. So normal CVP is 0, right? So what is your volume status? I hope you had some breakfast this morning. So what is your volume status? Are you all euvolemic? I hope your volume status should be normal. So you can have a 0 CVP and have a normal volume. So this will apply to our patients as well. So just don't look at CVP of 0 and give volume. We all are here with euvolemia with CVP of 0. Just because if I get an influenza, that doesn't change anything. It will remain the same. So my CVP, if it is 0, irrespective of the CVP value, I do not require a volume. So that's the first message. Don't write a direction, give volume for a CVP till 5 or 10, 0, don't get panicked. So there are other ways to know the volume status. So CVP is not the way. So that's the first message. We all have 0 CVP today and we have normal volume status. If I infuse a liter of normal saline, I'm not asking you to drink a liter of water. If I infuse a liter of normal saline in you now, what will be your CVP? Will it be same, 0? Will it rise? Will it fall? How many would you say it will rise? You have to be interactive. একটা হাত তুলতেই হবে, তিনটে অপশনের ভিতরে হাত না তোলার অপশন নেই। Rise, how many would you say rise? Fall? No, you will remain the same. 1 liter of normal saline. কি কিছু একটা কমিট করো, আরে কমিট করতে কি আছে? দিস ইজ নট অ্যান এক্সাম। এখানে যদি কমিট না করো তাহলে এক্সামে কি করবে? সো রাইজ, সো নোবডি ইজ শিওর লুকস লাইক। What will be your cardiac output? If I give you a liter of normal saline, will it increase? Somebody would say it will increase, but your CVP won't increase. Your cardiac output will increase, sure. So if you drink a liter of normal saline, you start pumping more blood. If you drink, so every morning when we drink, say 2 glasses of water, we start pumping more. So your cardiac output doesn't increase by a liter of saline, right? Just think about it, okay? So just by giving fluid, you might not increase your output. What will be your volume status? If you are infused a liter of normal saline and say, I presume you have not diuresed or have not passed urine, what will be your volume status? Will you be hypervolemic by a liter? Sure. Normovolemic. Just think about, these are very pertinent basic questions at the bedside. If I give a 500 cc of fluid, what happens to my CVP? What happens to my cardiac output? What happens? It doesn't matter if we get, we get influenza or some other disease, these things won't change. The basic physiology remains the same. So think about this. Say if you are exercising, what will be your cardiac output? Will increase. Everybody agrees on that. Once you exercise, your cardiac output increases. What will be your CVP once you start exercising? You have increased cardiac output, remember. Will your CVP increase while exercising in order to increase the cardiac output? As per Frank Starling law, that should happen, right? The more preload, the more increased cardiac output. So will your CVP increase when you exercise? You see, most of our patients are exercising. They are under stress. So it's some form of an exercise. Would your cardiac output increase if you CVP? Any idea? Again, a very basic question. So the reason of asking these questions is how to correlate CVP with stroke volume and things like that. In this patient, I've given you 2 hearts. One is normal, one is LVH. What will be the CVP? If I put a central line in this patient or say PA catheter in this patient, what will be the wedge pressure or a CVP on hypertrophied heart? Huge thick heart, very small lumen, will be high, right? Hopefully. And what will be the preload? What will be the volume status? You see the volume, the chink, hole in this patient. Severely hypovolemic, most likely. Doesn't have any volume at all. But your CVP can be very high. So the other opposite, you can have a very high CVP and look at the volume of this patient. Probably doesn't have any volume at all. So those are the questions that now I would address by certain basic physiology. and we'll readdress what we just discussed so that your concepts are clear. Is venous return equal to cardiac output? Let me put you a very basic question. Does venous return equals cardiac output? Somebody says no. You see, a venous return has to be right ventricular stroke volume, right? Whatever comes in the right atrium needs to go to right ventricle and needs to come out. What goes out of right ventricle needs to come out of left ventricle. It has to. The reason is, even if there is 1 cc difference, 1 cc between RV and SV, RV pumping 101, LV pumping 100, 1 cc per stroke, 72 beats per minute, the entire volume of the blood will come into the lung. Person will die. So just 1 cc. Remember, RV output has to equal the LV output. There is no way about it. And RV output is venous return. Anything which comes into the right atrium has to go to right ventricle, has to come out of right ventricle. So you see the pivotal question. So venous return has to equal to cardiac output. You know, we talk so much about cardiac outputs, but at the end of the day, whether you give volume, whether you raise the legs, norepinephrine, at the end of the day, we increase the venous return. Dobutamine we hardly use nowadays. So everything goes towards increasing venous return. The venous return will have an effect on cardiac output based on certain circumstances. So remember, venous return is the key. We'll come to more about it. Now, the veins, you know, we concentrate on arteries, but just concentrate on veins. There are two kinds of venous reservoirs. One is called stressed volume, which goes into the circulation, and one is unstressed volume. There is a huge venous reservoir of liters of blood, which does not come into the circulation. It is there as a reserve. If you give norepinephrine, some of it might come into the circulation, but most of it doesn't. It is the stressed venous volume which comes into the circulation that generates the pressure. And if I say here, say this is the right atrial central venous pressure, right atrial pressure. This is what is called mean systemic filling pressure. Very difficult to measure in a live person. A mean systemic filling pressure is if there is no circulation, no arterial, no venous, and our vasculature will generate a pressure. So that pressure minus the CVP is the driving pressure for venous return. So this is the pressure which will decide on cardiac output. Mean systemic filling pressure, which is difficult to, so there might be a surrogate of mean arterial pressure, and CVP. A difference between these two will decide whether what will be the venous return. So this is the schema. You see, unstressed volume does not play a role in circulation, does not play a role in generation of pressure. So there has to be a stressed venous volume and there has to be a right atrial pressure. The difference of these two will drive the blood into the right atrium, and as we just mentioned, this blood will cause venous return, will cause increased RV stroke volume and increased LV stroke volume. This is a very elegant experiment done by Cizzoni and others. You see, what they had shown is if there is a rise, this is a difference between mean systolic pressure, mean systemic pressure and CVP. If this difference increases, then they are responders. That means their cardiac output would increase. If there is no increase, they are non-responders. So if I give a volume to somebody, my mean arterial pressure goes up by say 5. His CVP goes up by 5. There is not going to be any change in cardiac output. Remember that. So nowadays it is a comeback of CVP. We have stopped measuring CVP nowadays. You see, it has a very important potential value. It is the difference between the mean arterial pressure or mean systemic filling pressure and CVP that will decide on your venous return. And as we just mentioned, the venous return will decide on stroke volume, the LV stroke volume. That's what we are after. So you see, if you look at this schema, as the right atrial pressure comes down, the venous return will increase. You see, it's very paradoxical. The lower is the right atrial pressure, the more will be the venous return, right? Because say, depending upon your different mean systemic filling pressure, at a given mean arterial pressure, the lower you make the CVP, the more will be the venous return, the more will be the cardiac output, right? And what about the Frank Starling? Frank Starling was completely different. The more is the right atrial pressure, the more is the cardiac output. So it is actually not the right atrial pressure. The x-axis in the Frank Starling should be venous return. The more is the venous return, the more will be the cardiac output. At particular juncture, there might not be any further. This is called the steep part, this is the flat part. And this can be superimposed on the venous return curve. So every individual will have these two curves. This is depending upon the myocardial performance, and this is the venous return. So just remember these concepts of venous return and cardiac output. You see, this is something where if you give a preload, that means you have challenged a volume. Look at the red one. If the CVP goes suddenly very high, there's not going to be much change in stroke volume. On the other hand, the stroke volume will be very little changed. On the other hand, if your CVP does not go too high after giving volume, you will have a huge stroke volume. So you see, the change in CVP will tell you whether your stroke volume is increasing or not. So let us come back to our questions. Okay, before that, now, during this workshop, you will have a lot of lectures and demonstration that somebody is volume responsive by a lot of gadgets we do nowadays. This is very basic. If somebody is volume responsive, say a patient, should we give him volume? By all our PPVs and all those gadgets are telling us the person is volume responsive. Should we give volume to that patient? You see, we all are volume responsive. We are on the steep part. So if a venous return increases, our cardiac output would increase. So in a patient, by giving volume, if a cardiac output increases, does not mean that the patient will require volume. This is normal. You have to look for features of hypoperfusion. Then only you decide on this volume response. Just don't go by volume responsiveness and give volume. The first tier should be, does this patient is hypoperfused by some way? Then only you interpret. Otherwise, whatever is the PPV or SVV and so many other gadgets, do not give volume just because patient is volume responsive. This is Arthur Guyton. He is the person, I don't know whether you still in medical school, they read Guyton's physiology, we did. He's the one who decided, who kind of conceptualized this venous return. And this is Frank Starling that we all kind of grew up with. So basic difference between Starling and Guyton is, as per Starling, heart is the center. It is the heart which pumps, and after pumping it will decrease the return, will increase the venous return. As per Guyton, is not the heart. Heart is an innocent bystander. It is the venous return, which is the difference between the pressure and the CVP, will guide the venous return, which ultimately will decide the cardiac output. You might have some functionality of the heart involved, but heart is not the central. So this is the basic difference. And by this Guytonian theory, I think you can answer lot of these questions that we just asked. If I infuse a liter of saline in you, would your CVP increase? It will all go into a unstressed volume. That is, unless you are stressed, it will go into unstressed volume. It will not change your CVP at all. Second, your cardiac output, your mean systemic filling pressure will remain the same because all the blood has gone into your liter into unstressed volume. If you are stressed, if you start exercising while having a liter of saline, it will come into stressed volume. Then your cardiac output would increase. So your cardiac output is not going to increase. Your CVP is not going to increase. Your volume status, it depends how you define. If you define the volume status just on the basis of active volume, then it is not going to increase. But active plus passive, yes, it is going to increase. And if you are exercising, yes, your cardiac output will increase, but your CVP will remain the same or even lower. Why is that? What decides the venous return, the passive versus active venous volume? You know, we talked about two kind of volume, unstressed and stressed volume. What decides the stressed volume and unstressed volume? It is the metabolic demand of the body. The more metabolic demand of the body is there, like if you exercise, the unstressed volume will come into the stressed volume. So there will be more venous return, there will be more cardiac output. So remember, it is the stress as like exercise. The metabolic demand will decide on the venous return. So basically the three messages I have for this part of my talk is, CVP is not an indicator of volume status. As I just mentioned, you can have low CVP with high volume, high CVP with low volume, or a preload or even preload responsiveness. And we always aim for a map of 65. If there is one message that you can take from this Guytonian principle, if you have a central line, we do it all the time. If you have a central line, measure CVP, and your goal should be map minus CVP should be 65. If your CVP is 10, don't go by 65 of map. You will be under perfusing your patients. It has to be at least 75. Your CVP is 0, you can go ahead with map of 65. And it is the change of map and change of CVP with whatever challenges we give, whether it is a volume challenge, vasopressor challenge, that will tell us whether the patient will respond to volume or not. Okay, so this part of my talk I will finish. We'll have question and answers after my talk rather than from each segment. So the next segment, you know, we talked about this preload and volume response, is afterload. Afterload, cardiac output, vascular resistance. Tell me, is there a cardiac output during diastole? Is there a cardiac output during diastole? Simple, huh? No, right? Is there a blood flow during diastole? There is zero cardiac output, remember. Is there a blood flow? Obviously, otherwise people would die. Huh? So if you have a blood flow during diastole, but no cardiac output, why? How can you have a blood flow without any cardiac output? Just remember, this is basic physiology. This is called Wind-Kessel effect. What happens is, whenever we generate a cardiac output, their blood pumps, the aorta gets distended, and during diastole, this aorta contracts, and that propels the blood forward for the diastolic blood flow, right? So the more rigid is the aorta, the more systolic pressure would be there. So remember, that is why there is diastolic blood flow. It is the aortic compliance decides on the diastolic flow. This is systole. We all know this is arterial pressure. This is diastole. Why there is an increase of blood pressure during diastole? You know, this is very odd. In diastole, pressure should come down. But here we see there is an increase of pressure during diastole. Now, why is that? This is because of this. Whenever a blood strikes any of these bifurcating arteries, it is reverberated back, and that causes an upstroke in the diastole. As we said, in diastole, the blood will flow from the aorta to the periphery, but it will reflect back from periphery, just like this. You see, you have a blood, water coming out of here, it strikes these stones, some of it will come back. And as it comes back, it causes a bump in diastole. So the arterial compliance, you see, the more constricted the artery is, the more proximal will be this anacrotic notch, as we call it. So very important, like patients with obesity, elderly, hypertensive, atherosclerotic will have a very high dicrotic notch because their circulation constriction is there. So the reverberated blood will come back much earlier than later. We put arterial lines into different channels like, you know, radial artery, brachial sometimes, arterial dorsalis. Remember, there is a change in systolic pressure as we go more periphery. Systolic pressure increases as we go more periphery, and this notch comes down as we go more periphery. So radial artery will never equate to your blood pressure in the brachial artery. So remember that there is always a brachial artery pressures are usually lower than the radial artery pressure. So sometimes the nurses double check, but remember, this is the normal physiology. Coming to the same as the afterload, now you have two patients. A patient A have got a heart rate of 140, blood pressure 90/40. Next patient has a heart rate of 70 with a blood pressure of 90/40. Which has got a better arterial, have got a lower arterial tone? Both have diastolic pressure of 40. So it depends upon the pulse rate. Whenever we look at the diastolic pressure, do not have an impression of diastolic pressure. You always look at the pulse rate. For example, if somebody is severely tachycardic, they won't get time for decreasing the diastolic pressure. So their diastolic pressure might be high even if they are severely vasodilated. So somebody having a diastolic pressure of 70 and somebody having a diastolic pressure of 40. If somebody having a diastolic pressure of 40 and beating at a rate of 50 per minute, that might be normal. Somebody having a diastolic pressure of 70 and beating at a rate of 120, that's severe vasodilatation. So remember that. Always take into account the patient's heart rate while you interpret the diastolic blood pressure. The reason is you can try norepinephrine if you are vasodilated. We won't go into this. Low systolic pressure in sepsis. Hypoperfusion. What are the features of hypoperfusion? Hypotension, tachycardia, low urine output, skin mottling, acidosis. There are a lot of lectures during this conference on these. It is very difficult to see skin mottling in our color. So I have not found it to be very, very important. Rather, the warmth is more important. Next is capillary refill. We always talk about capillary refill as one of the best way to know clinically hypoperfusion. Have you, tell me honestly, how many of you have done capillary refill time in your patient? Okay. So how do you do that? But how do you do that? So you are looking at the finger, right? Right. And you are looking at the watch?
Yes, sir.
Both at the same time?
Sir, yes, sir.
Is it possible? I doubt. 3 seconds. Remember, normal is less than 3 seconds. Can you do it? Looking at your watch for 3 seconds and looking at capillary perfusion coming back at the same time. Practical is very difficult, let me tell you. Very difficult. Then how do you do it? You see, when we do CPR, we are supposed to time the CPR, right? Like we have to do 100 times per minute. So how do? You count a minute. So you count 1 and 2 and 3 and 4 and 5, and by this count, that means 100 you have to 1 and 2 and 3, this will take a minute. So you have to time yourself while you do this. You remove it, 1 in 100, 2 in 100, 3 in 100. This is 3 seconds, right? So that's how you time yourself. You don't look at the watch. It's just not possible to do capillary refill time by looking at your watches. So just practice that. Just want to finish. What is difference between these are the monitoring principles which will come into basic physiology. If you have a manual blood pressure, NIBP, which says this 110/70 all the time, whereas the true is 130/80, and you have another one, NIBP, sometimes 130/80, which is true, but it is different in different times. So one is accuracy, one is precision. This is what is, this might not be accurate, but this is very precise. In monitoring physiology, it is better to be precise. If you are inaccurate, it's very problematic. Okay, this is very important. Spot 2 errors in this chart. Okay, it's a prize. You have a quiz now. Let's see how many of them can spot 2 errors in this chart. Quickly, my time is almost over. 2 errors. You see, this patient cannot have a pressure of 150, then 110, then 120. It's all over the place, right? So what's the difference between these two pressures? Have you noticed the difference between these two pressures? There is one very important difference. The pen has changed. You see, the nurse have changed. When the nursing changes, most of these manual recordings change. This is called a pen sign. In ICU with manual recording, still most of our ICUs are manual recording. Before taking into cognizance any sudden change of values which are manually recorded, look at the chart. You might not find the right nurse, but the way it is written and the pen in which it is written, it will tell you. So that's the first error. Second, this is very important error, and because of this, the sepsis definition, the Q SOFA definition, the sepsis definition have changed. Do you know why? This is the error. You see the respiratory rate. Is it possible to be 20 throughout the day? It's just not possible. Usually it is not counted. You see, if you look at the definition of Q SOFA, the respiratory rate is 22 all over the world. This is the current international definition of diagnosing sepsis. You have to have a respiratory rate of 22. So why 22? Because of this. It is not only specific to us, it's all over the world. 20 is written. So if you write 20, everybody will say it's 20. If you write 22, then they have to count whether it is 22 or not. So always take into account, the respiratory rate. So that's another fallacy. So pen sign and respiratory rate. And where would you, this is a CVP tracing. Where would you take the CVP? Here or here or here or here? It's all over the place. So that becomes very important. That will bring us to this concept of transmural pressure. Now what is transmural pressure? This is a blood vessel which has got a pressure of 10. If I put a catheter here, I will find 10. That is my true pressure. But our blood vessels are inside a chest wall. You know, the CVP, the SVCs and all. So if it is -5 outside, so my transmural pressure, if I put a catheter inside my blood vessel, it will be 5, because the transmural pressure is 5 minus 5, that is 10. Here it is 10. On the other hand, if I have a positive pressure outside and I have a catheter inside my lumen, it will be positive pressure of 5, my pressure would show 15. So until and unless you have an idea of what is the pressure outside, you cannot interpret the pressure inside the lumen. So how do we know the pressure outside? You have to put a catheter in the pleura or esophageal pressure. We don't do that. So that's why end of expiration, we assume that the outside pressure would be 0. So by convention, all these respiratory variations and CVP and all should be taken at the end of expiration. And you know, how do you know end of expiration will be different in mechanically ventilated and spontaneously breathing patient? It is positive in spontaneously breathing, it will be lower in the mechanically ventilated patient. So just to conclude, you know, we measure a lot of pressure, but we are interested in flow, which is cardiac output. But what we do, we give volume. So you see, these are 3 completely different entities. We are measuring pressure in order to generate a flow, and for which we have to give a volume. So these 3 are different concepts. And lastly, you know, lot of thing in physiology, in this monitoring, you will be hearing throughout this workshop. But there are many things which are not mentioned, which are not counted. Just looking at the patient might be sometimes even more important than any particular number. So always remember that. And whatever monitoring we do, whatever numbers we generate, until and unless we act on it, and by that action the patient has got some clinical improvement, just monitoring is not going to help my patient. Getting a Litco or a Vigilio or a volume view or a PA catheter, that's why PA catheter was withdrawn. It is a very nice tool. It's one of the best tool to physiological monitoring. People were not using it properly to implement what has come out of this and how to direct that into therapy and into the patient outcome. So that is how, what will be my last message is, use the monitors wisely. They say a fool with a tool is always still remains a fool. So always use your tools very wisely. So you will be listening to a lot of tools during this workshop. Use it very, very wisely, and don't go on numbers. Always, there are so many fallacies. Numbers are important, but you have to be very judicious. You cannot do intensive care over phone, right? You have to be there at the bedside, see the patient. Numbers are there. You can tell numbers over phone, but you should not act on it. Okay? Thank you. Thank you.
Thank you so much, Dr. Todi. We would like to give you a little memento from us. Dr. Anupam Goswami will do the honors of honoring Dr. Todi. Thank you so much.
Okay.
Ranjan? Dr. Jyoti has enlightened us, so we would not like to be fools with tools, right? Our next speaker, Dr. Anupam Goswami.
Thank you, ma'am. আচ্ছা এই কোথায় গেল এই যে ডিশন ফাইনাল এই যে এইটা এটা এটা
On করেছি, on করেছি। স্যার, আমি Good morning. Our next speaker is Dr. Anupam Goswami. Actually, whenever I think of SSKM, যাকে বলে PG হাসপাতাল, I cannot think of anything beyond Anupam Goswami. He has actually tutored us, যাকে বলে মানুষ করেছে। তখনকার দিনে আমরা যখন পড়তাম তখন তো ডিএম ছিল না, তো স্যারই আমাদের টিচার ছিল, স্যার সবাইকে পড়াতেন আর স্যার নিজেও খুব পড়তেন। তো এত অমায়িক একটা মানুষ আমাদের মধ্যে এসছেন, তার জন্য আমার শতসহ্র প্রণাম। স্যার এমবিবিএস পাস করার পর হি ডিড হিজ এমডি অ্যানেস্থেশিয়া অ্যান্ড ভেরি ইন্টারেস্টিংলি হি ইজ অ্যাকচুয়ালি আ ডিপ্লোমা ইন কার্ডিওলজি. So he's a cardiologist along with us who's an anesthetist as well. He has been an HOD of SSKM hospital for quite some years. Sir, কত বছর?
from my 2011 of cardiac anesthesia, not of
Okay. From 2011, he has been the head of the department cardiac anesthesia. So we know that we have a stalwart with us who will deliver the lecture, a quite complicated lecture, heart-lung interaction. Sir, the podium please.
Thank you, ma'am, for nice introduction, and I'm really grateful to be here to talk about this heart-lung interaction, which is a very tricky subject, I think, and maybe confusing at some point of time. Now, talking about heart-lung interaction, এই পেজ ডাউনটা কোথায়? তো এই নামছে না কেন গো? থ্যাংক ইউ। First, we should talk about spontaneous inspiration, the effect of spontaneous inspiration on circulation, and the effect of controlled ventilation on circulation, because these two things will be coming very repetitively during our discussion, and if we have a good understanding of it, it will be easier for them to follow. Now, in spontaneous inspiration, the increases in RV stroke volume is due to a transient increase in the venous pressure, and there is a decrease in the LV stroke volume because the negative pleural pressure that is surrounding the LV is equivalent to an increase in the aortic pressure and impedes emptying of the left ventricle, much like an increase in afterload. So the intrathoracic part of the aorta is subjected to the negative pressure, and when we are breathing in, there will be a negative pressure, the aorta will yield, and the pressure inside the aorta will actually increase. So what is happening, as the pressure in the aorta increases, the afterload to the left ventricular outflow is also increasing. So there is a fall in cardiac output. So distension of then again there is interaction between the right ventricle and the left ventricle, and distension of the right ventricle due to the transient increase in venous return elevates the left ventricular diastolic pressure. I am coming to it soon, due to ventricular interdependence, and that impedes your LV filling. Now this is the left ventricle, and this is the left ventricle. This is the septum and right ventricle. Right ventricle is crescentic in shape on cross section, and if there is a distension of the right ventricle during inspiration, it will push the left ventricle, so the volume of the left ventricle will decrease, and that will cause lesser filling and lesser cardiac output. So reduction of stroke volume during inspiration is accentuated in pleural pressure swings and pericardial disease. This is normal. So when we are breathing in, we are having a reduction in stroke volume, so reduction in pulse volume also, and when during the expiration it increases. Now when there is a huge swing, like in obstruction in the upper airway or severe bronchial asthma, then we have to generate a very high negative pressure to breathe in. So this change, this so what is happening, this swing will increase this gap, and now this is called pulsus paradoxus. Pulsus paradoxus is seen in huge swing in the negativity of the interpleural pressure and also in pericardial disease like constrictive pericarditis or your pericardial effusion, that is tamponade. So pulsus paradoxus is an exaggerated normal response. Now negative pleural pressure after load causing pulsus paradoxus is predominant in pleural pressure swings like in obstructive diseases, airway obstructions, and ventricular interdependence causing pulsus paradoxus predominant in pericardial disease. Now coming to the effects of positive pressure ventilation and circulation. In positive pressure ventilation, the intrathoracic pressure increases. On one side, this causes a reduced venous return. That also increases the pulmonary vascular resistance because of distension of the lung, and that also decreases the afterload. Why? Because now this pressure is a positive pressure is acting on the aorta, and the aorta is not yielding, so the actual internal pressure in the aorta actually reduces. So there is a decrease in the afterload. On the other hand, what is happening? This positive pressure is also acting on the left ventricle from outside. Now this pressure is going towards the left ventricular cavity, and within the cavity there is a blood which is exerting a pressure in the opposite direction. So this will to some extent neutralize that, and left ventricular end-diastolic pressure will decrease. So for that reason also, as left ventricular end-diastolic pressure causes the stress on that is within the inside the endocardium. So this is the afterload, actual afterload. So afterload decreases. So what is happening? The left ventricular work is actually decreasing because a decrease in the afterload. But whether so during positive pressure ventilation, the cardiac output decreases. This will cause a decrease in the stroke volume. On the other hand, as the afterload decreases, this to some extent can compensate for that. This is particularly useful when the patient is having a heart failure like dilated cardiomyopathy or ischemic cardiomyopathy, where the heart is hugely enlarged. There, this reduction in afterload can improve the cardiac output. So positive pressure ventilation has got some role in treating your heart failure due to a diseased myocardium. In a normal healthy myocardium, this actually may cause a fall in the pressure because of less cardiac output, which is much more pronounced when the patient is suffering from hypovolemia. So we see that both during inspiration, spontaneous breathing, and your positive pressure breathing, there is always a possibility of having a lowering of cardiac output during the inspiration. So we should stop breathing to survive, isn't it? It is not. Now coming to the hemodynamic effects of ventilation, which can be grouped into three concepts. One is spontaneous ventilation is exercise. This requires oxygen and blood flow, placing demands on the cardiac output. So some part of the cardiac output will be useful for the muscles which are taking part in the breathing process. This spontaneous ventilation also produces carbon dioxide and adds additional ventilative stress on gas exchange. Now inspiration increases lung volume above resting expiratory volume. Some of the hemodynamic effects of ventilation are due to the changes in lung volume and chest wall expansion, and changes in lung volume alter autonomic tone and pulmonary vascular resistance and compress the heart in the cardiac fossa. Now the third concept is spontaneous inspiratory efforts decrease intrathoracic pressure, and that increases venous return and impedes left ventricular ejection. And positive pressure ventilation increases intrathoracic pressure, that decreases venous return, unloads the left ventricular ejection, and whether the cardiac output will increase or not will depend on the quantum of your decrease in the venous return and the quantum of the fall in the cardiac output, and also on the state of the myocardium, which is whether it is healthy or a diseased with less contractility. Thus, the difference between spontaneous ventilation and positive pressure ventilation primarily reflect the differences in ITP swings, that is intrathoracic pressure swings, and the energy necessary to produce them. Now, the effects of intrathoracic pressure on cardiac function. The heart is a pressure chamber within the thoracic pressure chamber. So, changes in ITP affect the pressure gradients for systemic venous return to the RV and systemic outflow from the LV. Now, increase in intrathoracic pressure increases the right atrial pressure and decreases LV transmural pressure, because the pressure outside the LV is increasing and is acting opposite to the direction of the pressure exerted by the blood within the cavity. So this minus that is the transmural pressure that decreases. This reduces the pressure gradient for venous return and LV ejection, decreasing intrathoracic blood volume. So if the ITP increases, the blood volume within the lung is decreased. This is somewhat useful in the treatment of pulmonary edema when there is an increase in the pulmonary blood volume or pulmonary water. Now, decrease in ITP augments venous return and impedes left ventricular ejection, increasing intrathoracic blood volume. That means on the input side there is more blood, but on output side there is less blood is coming out. So the lung volume is actually lung water is actually increasing, and this may be detrimental in the presence of your pulmonary edema. Now, blood flows back from the systemic venous reservoirs. Dr. Todi had mentioned about all this in detail, into the right atrium through low pressure, low resistance venous conduits. Right atrial pressure is the back pressure for venous return, and ventilation alters both right atrial pressure and venous reserve pressure. Changes in right atrial pressure and venous capacitance vessel pressure create most of the observed cardiovascular effects of the ventilation. Now, pressure in the upstream venous reservoirs, that is away from the heart, is the mean systemic venous pressure. We are having some of the veins from the outside, from above the heart, which are bringing back blood to the heart, and from the upper part of our body, and most of the venous return is from the lower part of the body. So this is the venous reserve. Now, mean systemic venous pressure is a function of blood volume. If there is hypovolemia bleeding, this pressure drops. Peripheral vasomotor tone. If there is a huge venodilatation, particularly with the use of nitrate, this pressure drops. And blood flow distribution. That means the venous return, which is coming from the more distant part to the heart, may not be equal, may be affected by different venous return from different organ systems. Now, mean systemic venous pressure is usually constant over a breath. Variation in right atrial pressure determines the fluctuation in pressure gradient, causing cyclic changes in venous return. Now, positive pressure inspiration increases right atrial pressure and causes venous return to decrease during inspiration. Spontaneous ventilation has the opposite effect. So, in spontaneous inspiratory effort, usually increase in venous return because of the combined decrease in right atrial pressure. In spontaneous inspiration, the right atrial pressure decreases, but the diaphragm descends, increasing the abdominal pressure, so the gradient improves. So, blood from the abdominal, particularly abdominal cavity, which is returning through the venous system, will flow more towards the right atrium. This is a compensatory mechanism there. Right atrial pressure falls and the abdominal venous pressure increases. The detrimental effect of PPV, by the positive pressure ventilation on cardiac output, can be minimized by that. We know that in positive pressure ventilation there is a fall in cardiac output because there is less blood fluid return to the right atrium. But on the other side, the afterload decreases and there is a scope for increase in the cardiac output. but this is predominant. That is right atrial venous return is less, and that is the predominant thing. And this, particularly in the presence of hypovolemia, will be exaggerated. So in a patient who has fluid loss or who had blood loss, the effect of positive pressure ventilation on the fall in cardiac output will be more pronounced, and this can be actually compensated by increasing the mean systemic pressure, or also by keeping the intrathoracic pressure low, which can that is the swing in the lung volume is to be kept as low as possible. And how can I achieve? Can we achieve that? We can prolong the expiratory time. If prolongation of the expiratory time means the mean pressure here, intrathoracic pressure is decreased, and decreasing tidal volume, this will also be having a less rise of intrathoracic pressure. And if we avoid PIP, to minimize the decrease in systemic venous return. So either we have to give fluid, or we have to increase the expiratory volume, expiratory timing, or we have to decrease the tidal volume as low as possible, and we have to avoid a PIP to minimize the fall in cardiac output associated with positive pressure ventilation. However, as positive pressure ventilation increases lung volume, the diaphragm descends against and compressing the abdominal compartment, increasing intra-abdominal pressure and venous return. That is the same as with your spontaneous inspiration. If arterial pressure remains constant as ITP increases, transmural LV pressure and thus LV afterload would decrease. So, with your rise in the intrathoracic pressure, the afterload again decreases. The same thing I am repeating everywhere. Similarly, if arterial pressure remains constant as ITP decreases, intrathoracic pressure decreases, then LV wall tension, that is the afterload, will increase. That is the most tricky part of this distinction, of this discussion, and we should remember that. So under steady state conditions, that is the final thing. Increase in ITP decreases LV afterload, and decrease in ITP increases LV afterload. The spontaneous ventilation not only increases global oxygen demand by its exercise component, but also increases myocardial oxygen consumption by increasing afterload. Okay, so when we are allowing spontaneous ventilation, we are allowing the respiratory muscles to use some of the cardiac output for oxygen and carbon dioxide, oxygen intake and carbon dioxide removal, and at the same time, as the afterload to the left ventricle is increased, there is more myocardial work and myocardial oxygen consumption that has to be added. Profound negative swings in ITP commonly occurs during forced spontaneous inspiratory efforts in patients with bronchospasm and obstructive breathing. So we can see when there is a choking, there is some obstruction at the laryngeal level, laryngeal paralysis or a foreign body, the patient tries to breathe in with a very huge negativity in the pressure they want to make, and this will cause a fall in the pulse volume because of the decrease in the stroke volume. Similarly, in severe bronchospasm, though this is a lower respiratory problem, airway obstruction, but still with very huge, this is basically an expiratory problem, not an inspiratory one, but with very severe bronchial spasm in severe bronchial asthma, the patient has to generate a very huge negative intrapleural pressure for the air to be drawn in. So that will also cause this kind of fall in the cardiac output during your inspiration. And this is pulsus paradoxus. So presence of pulsus paradoxus in bronchial asthma is an indication for hospitalization. This negative swing may rapidly deteriorate into acute heart failure and pulmonary edema as seen in patients with airway obstruction. The examples are asthma, upper airway obstruction and vocal cord paralysis, or in case of restrictive lung disease, stiff lung, in interstitial lung disease, so the patient who are already having some kind of pulmonary edema and in acute lung injury. So the negative swing actually precipitates pulmonary edema. Why pulmonary edema? Because more blood is coming to the right atrium, but because of the increase in the afterload, less blood is going out of the. So what I have talked about earlier, the total lung water will increase. So this will cause pulmonary edema. The negative ITP swings may selectively increase left ventricular afterload, causing left ventricular failure, pulmonary edema, especially if the left ventricular systolic function is already impaired. This may be compensated to some extent by a normal heart, but if the patient is already having ischemic heart disease or some kind of cardiomyopathy, this will be very much pronounced. That is the patient with a negative pressure breathing, that is the normal breathing which is exaggerated, and we are allowing a spontaneous breathing, the pulmonary edema will deteriorate. Thus, weaning from mechanical ventilation is a selective left ventricular stress test. Now, when we see a left ventricular function is improving with positive pressure ventilation, classical positive pressure ventilation through a ventilator after intubation, this is a self-limited management because the venous return also decreases because of positive pressure ventilation. So what is happening? Our idea is to increase the cardiac output. We have put the patient on positive pressure ventilation, and this will decrease the, in this case, this will decrease the afterload. This is a failing heart. Most likely the intracavitary diameter is very high, and this, according to Laplace law, as the intracavitary diameter increases, the that is the stress on the inside the myocardium will be more, and the afterload will increase. So this afterload increase will be more prominent, and lung water will increase, and heart failure, the cardiac output, the cardiac output may actually fall. So we have to do something where we can have some of the advantages of your positive pressure ventilation, but which is actually decreasing the swing in the negativity during spontaneous ventilation, but not actually decreasing the venous return to the right heart. And this process improves LV function patients with heart failure treated with continuous positive airway pressure. This is the example. In continuous positive airway, it's a non-invasive method. We are creating an atmosphere where the atmospheric pressure is somewhat more than the normal atmospheric pressure, and the patient is breathing in from that pressure. So the swing, which was without this CPAP, the negative swing in the pleural space was much more, but after this CPAP, this is decreased. So what is happening? The venous return is decreased, and the afterload is increased. Afterload is decreased also. So this is causing the pulmonary edema to disappear. So what is the point, that instead of your conventional IPPV, intermittent positive pressure ventilation through a ventilator, if we apply just a CPAP to the patient with a pulmonary edema, the pulmonary edema will improve. Prolonged nighttime nasal CPAP can selectively improve respiratory muscle strength as well as LV contractile function if the patients have pre-existing heart failure. These benefits are associated with reduction in the serum catecholamine levels also. So these are all applications of your heart-lung interaction. CPAP therapy now forms the fundamental first step in the management of acute cardiogenic pulmonary edema because it abolishes the negative swing in the ITP during inspiration and sustains alveolar oxygenation. It does this from the very first breath it delivers. So CPAP is the first therapy in pulmonary edema, mind that. Now using this heart-lung interaction, we can diagnose some of the cardiovascular results, because particularly the reserve, whether the patient will require a fluid for improving the cardiac output or not. A patient who is in heart failure, he is having a low cardiac output. A patient who is not in heart failure, who is hypovolemic, this patient will also be having a low cardiac output. So a low cardiac output state may be due to hypovolemia or maybe due to heart failure. Heart failure is a relative hypervolemia. So whether we should give fluid or not, that is very challenging. If we give fluid to a patient who is having heart failure and low cardiac output, this will complicate the matter. The problem will not be improved, it will deteriorate. But if the patient is hypovolemic, the patient will improve. So that can be actually diagnosed in the bedside by using these heart-lung interactions. Now, how do we do that? There is obligatory changes in venous return induced by positive pressure ventilation. This can help to quantify the magnitude of associated decrease in venous flow and LV ejection using various parameters like vena cava diameter change, LV stroke volume variation and arterial pulse pressure variation. What is happening? A patient is hypovolemic. The patient is on a ventilator. So because of the ventilation, the cardiac output will further fall. Now the patient is hypovolemic, this will be exaggerated. So if we give fluid, if the patient is fluid responsive, this will improve and the cardiac output will improve. Now during your spontaneous breathing, there is a difference in the vena cava diameter that can be assessed through echocardiography. Okay. Now this is spontaneous breathing, that diameter falls. During expiration, the diameter decreases. In the presence of hypovolemia, when the patient is on a ventilator, this is exaggerated. So if we give fluid and see that the changes are decreasing, that the amplitude of your change is decreasing within a limit of say about 10 to 15%, then the patient is fluid responsive and you should give fluid to the patient. Similarly, stroke volume variation. More is the positive pressure, intrathoracic pressure, and more is the patient hypovolemic, the variation will be more. So if we just count, through an arterial catheter, we can see the flow track and all these, they do the same thing. We can see what is the stroke volume and we can calculate the stroke volume variation. So from there also, if there is a variation of more than 15%, the patient is hypovolemic, you can give fluid. Similarly, the arterial pulse pressure variation, arterial systolic blood pressure variation or pulse pressure variation. This will also give us an idea whether the patient is fluid responsive or not. Now these parameters vary in proportion to the level of cardiac preload reserve present, that is the fluid status. Common parameters include arterial pulse pressure variation and left ventricular stroke volume variation, and can accurately predict which critically ill patient will increase their cardiac output in response to fluid infusion and which will not. This approach has been termed functional hemodynamic monitoring because it uses a repetitive known physiologic perturbation to drive a readout physiologic signal defining cardiovascular reserve. This functional hemodynamic monitoring reflects a practical clinical application of heart-lung interaction. The problem is that to improve the sensitivity of this process, we have to keep the patient on PPV. The patient is during spontaneous breathing, the variation is less, so the sensitivity drops. During positive pressure ventilation, the variation is more and sensitivity is increased. Now with a positive pressure ventilation with a tidal volume of 8 milliliter per kg, this is actually operating. If we decrease the tidal volume to a lower level, the problem is that the variability will decrease and the sensitivity is lost. Nowadays we are using less tidal volume to improve to actually prevent lung injury, and with this method, if with a 8 milliliter volume on tidal volume only, we can have some assessment. If we continue with a 8 milliliter per kg of tidal volume for a long time, there will be problem with this. There will be mortality and morbidity will increase. So what is nowadays done? Intermittently, the patient is given a tidal volume of 8 milliliter per kg, and this is measured. Then again the tidal volume is brought down to 6 milliliter, which is normally used nowadays. So volume responsiveness does not equate with the needs for fluid. Again, it is a number. It only identifies the ability of the heart to increase stroke volume if given fluids. The decision to give fluid needs to be based on the presumption that cardiac output is inadequate to meet the metabolic demands of the body, not just on the fact that the cardiovascular system is volume responsive. So if there is there is no hypoperfusion, the numbers are showing that the patient requires volume, you should not give the volume. Dynamic venous flow changes during spontaneous and positive pressure ventilation identify right ventricular preload reserve indirectly by the dynamic changes in inferior vena cava, superior vena cava, and internal jugular venous diameters. Threshold values above a 10 to 15% change in diameter define volume responsiveness. Because both this SVV and PPV, these are incorrect things actually. Because both systolic pressure variation, SPV, and pulse pressure variation (PPV) sensitivity degrade during spontaneous ventilation, low tidal ventilation, severe core pulmonal, and other extremes of physiology. Alternate. Alter. Extremes of physiology, this functional hemodynamic monitoring tests are used. ওখানে একটু মিস হয়ে গেছে দুটো জিনিস. Specifically performing passive leg raising maneuvers that transiently increase venous return while concomitantly monitoring LV output is a very sensitive and specific predictor of volume responsiveness under most circumstances. So to summarize, understanding heart-lung interactions has led to the use of CPAP as primary therapy for acute cardiogenic pulmonary edema to support a failing left ventricle in patients with obstructive sleep apnea, and positive pressure ventilation induced changes in intrathoracic pressure to identify volume responsiveness in critically ill patients in need of resuscitative efforts. So thank you. If there is any question you can ask, I will try to answer. I don't know whether I will be able to do that. Still.
Any questions from the floor? Or no? Any question? Thank you, sir. Thank you very much for your beautiful lecture.
Yeah, beautiful,
We enjoyed
huh?
it. I would like to introduce Dr. Saptarshi Bhattacharya.
বার করে নিই, হ্যাঁ? কোথায় গেছে? বুঝতে পারছি না। হ্যাঁ।
I would like to introduce my co-consultant, Dr. Saptarshi Bhattacharya. He has gone a long way to help us out in this workshop. As you all know, Dr. Mohit is a bit ill, so Saptarshi has been really with me in this thing. And I would like Saptarshi to give sir this little moment. Oh no,
এই পাইটা হাত। হ্যাঁ?
Thank you so much, sir.
তাহলে আমি একটু আসছি।
একটু
আচ্ছা, ঠিক চা খাবো।
একটু চা খেয়ে নেব। Are we breaking for the tea break? A little bit of sandwiches and tea, or shall we continue with Sudipto? What do we do? You can have your food here as well. Ki chai bolo? Okay, so we continue. Our next speaker is Dr. Sudipto Bhattacharya. He has come a long way from Tata Medical Center. So when we have cancer, we think of Tata Medical Center. Sudipto, after completing his MBBS, has done MD in medicine, IDCCM, FNB critical care, EDIC, and he is a consultant of the critical care unit of Tata Medical Center. I would welcome on stage Dr. Mukherjee.
Thank you, everybody. Thank you, madam, for your nice words. Am I audible?
Probably not.
A little. Yes, yes. Only one correction. I did my MD in anesthesia. After that, I did my critical care training, and no problem. And how many of you are using ultrasound or echo in your practice? So I think I don't have to discuss much about the nobology or at the probe regarding the probe. But what we can do, as a continuation of the previous talk that sir mentioned regarding the heart-lung interaction, the main purpose of all hemodynamic modalities is to see if my patient need a higher cardiac output, how can I provide it? Whether fluid will work, or we need to give a vasopressor, or we need to give an ionotrope. Okay. Yeah, perfect. Sure. Okay. So in next 30 minutes or so, what we'll do, we will discuss regarding managing hemodynamics in a patient with the help of ultrasound and echocardiography. So in general, in critical care population, the transthoracic echocardiography identifies very odd. Okay. The great majority of the cardiac causes with shock. TT provides diagnostic images in nearly 90% cases in spontaneous breathing patients. But when the patient is on ventilator because of raised intrathoracic pressure, sometimes the quality of the images drops. Even then, in 80-85% cases, you will get a reasonably good picture. After TT examination, in around 30 to 50% cases, you will find that you are changing the treatment modality or the diagnosis of the patients. Even the patients who are on a pulmonary artery catheter, it shows that with the help of echocardiography, in 40 to 50% cases, probably you can change the diagnosis or add on to the diagnosis or change the patient's improvement in terms of outcome. In 50% cases of medical ICU patients who has a shock or admitted with a shock, if you do an echocardiography, you will find that you are getting some new information in terms of diagnosis or treatment. So does that helps if you do an early echo? There are times that you may not be able to get a definitive diagnosis, but definitely if you do an early echo while the patient is in shock and coming to the emergency or ICU, you will find that it helps you to narrow down a differential diagnosis. That's also helpful because it will guide us in the future investigations in the coming time. So can anybody like intensivist or a new doctor who is working in the emergency can do this baseline echocardiography? Compared to the common belief that the learning curve for echocardiography, specifically for the basic one, is very small. If you start practicing on a daily basis, you will be able to get the windows very, very fast. So these are studies when they compare the echocardiography done by an intensivist and compared it with a cardiologist, and they found that in terms of the LV systolic function, more or less they are comparable. That is, that an intensivist or the emergency physician is not missing the basic echocardiographic assessment in terms of the LV systolic function. Similarly, this had been compared with the non-cardiology residents also, and they've shown that after a small amount of training, probably 1 or 2 days of training, at least the trainee or the non-cardiology residents able to identify, able to diagnose the basic cardiological problem. So the first echo message that I want to give that it has a small learning curve. For the basic echo, I'm not talking about an advanced echo. For a basic echo, it's a small learning curve. Once you start using it, you will understand, you will be able to get the image better and try to able to interpret it. We all know that what we use a phased array probe with an around 4 to 8 megahertz frequency for the cardiac. It's a small square-shaped footprint to put in the intercostal space so that you can avoid the rib shadow. And ultrasound beams cannot pass through the bone, so we have to, and also to the air. So we have to avoid the lung, and also you have to avoid the rib shadow. Now this is in continuation with the previous talks that, as I mentioned, whenever we are looking at the hemodynamics, our main purpose is to increase the cardiac output. And even before that, we have to evaluate whether increase in the cardiac output is going to improve the tissue perfusion, which is the final target. So whenever we are talking about the cardiac output, we have 3 factors to play with. One is venous return, that will be influenced by the volemia, that is the volume status of the patient, and also by the venous capacitance. Now in sepsis, what happens? There is a vasodilatory state. As a result, there is a relative hypovolemia. So fluid is usually drawn into the capacitance vessel, so the fluid which participate in the cardiac output usually less. So there is a relative hypovolemia. That's why whenever we are assessing patients with sepsis, you will get a echocardiographic or clinical picture of hypovolemia. Along with next is the cardiac contractility, that is the heart's global function. It includes right systolic function, right ventricular systolic function, left ventricular systolic function, left ventricular diastolic function, which can contribute significantly to the tolerance. That means when you are giving fluid, that may help to increase the cardiac output, but at the same time, patient not able to tolerate that. There may be issues with the third spacing, and most important third spacing in the fluid is in the lung. Then the patient will become more hypoxic and may need a advanced organ support like ventilator. So along with fluid responsiveness, we have to monitor for the fluid tolerance also in our patients. Next is the ventricular interdependence. That's also very important because if the right ventricle enlarges or distended, obviously the interventricular shift will shift and there will be a decrease in the LV chamber filling, and as a result cardiac out decrease in the cardiac output. And along with that we have to see for the pericardium and the gross amount of the valvular function. And last is the cardiac, for the cardiac output is the afterload or the vascular tone. So what is the indication of doing echocardiography in critical care? So usually divided into circulatory failure or shock, maybe because of due to complicated AMI, because of acute aortic syndrome or massive pulmonary embolism, cardiac tamponade. Even in a cardiac arrest scenario, we can use echocardiography to diagnose the cause of cardiac arrest. So we know if we are able to identify the cause and can correct it, chance of reversal is much higher. Third will be in acute respiratory failure, as to differentiate between cardiogenic and non-cardiogenic pulmonary edema. Also, the role of right ventricle while we are weaning those patients is important. We'll see how we can differentiate it. And there are other conditions like blunt trauma chest or infective endocarditis where echo can help. So if I summarize this, it usually boils down to the fact that we need echocardiography in critical care for evaluation of shock. We know shock is of 4 types, that is hypovolemic shock, cardiogenic shock, obstructive shock and vasodilatory shock. And treatment is also very limited. What we have to do, we have to address the underlying pathology. Along with this, very minimum interventions like fluid. One option is fluid, second is vasopressor, third is anotrope. When the patient is not tolerating the fluid, you need to de-resuscitate, then probably you need a diuretics. So the intervention options are very limited. So what are the criteria of a focused echo? That is, when we say point of care echocardiography, what are the important criteria? It have to be an extension of the physical examination. As sir rightly mentioned in the previous talk, just because one patient is fluid responsive, we should not give fluid. We have to see whether increasing in the cardiac output is going to help this patient or not. TT usually has a very limited examination. We don't do the echo like a cardiologist. We do it as a bimodal technique or as a dichotomous, for a dichotomous question. That means the answers are either yes or no. We'll see whether LV function is normal or not. Answer is yes or no. Whether there is a pulmonary hypertension, yes or no. So our approach is like to give an answer for yes and no. And for ultrasound we mentioned, if you ask a very specific question to the machine, you will give a specific answer. If you ask a vague question, you will get a vague answer. So most of the assessments are by eyeballing, looking at the gross function. We usually avoid measurement in the early phase at least. And target is to diagnose the problem and intervene. I need to monitor this. And if you feel that you are not sure, the findings are borderline, don't hesitate to take help from a specialist. So suppose you get a patient with a hypotension, how are you going to approach this patient with an echocardiography? We'll do an echocardiography and we'll look at the RV function, whether RV systolic function is okay or not. If it is not, if it is okay, there is no abnormality, we look for the LV systolic function. So basically what we'll do with normal RV systolic function, we are ruling out the obstructive shock. So probably the chances of pulmonary embolism, severe pneumothorax or a pericardial tamponade will be ruled out because RV function is reasonably okay. Next we look at the left ventricular systolic function and the gross valvular dysfunction. We found the left ventricular systolic function is okay. So probably we are ruling out the cardiogenic shock. This is a very superficial, it's not like that, but you have to approach it in this way. Next we look at the preload. If the whether this patient is going to be preload responsive. If the patient is hypovolemic, is preload responsive, probably we are dealing with a hypovolemic shock or vasodilatory shock. And at the end, if no other findings is there, probably it's led to a vasodilatory shock. That means probably sepsis or maybe a neurogenic shock. So how echo is going to help us? So these are the primary indications for evaluation. That will be, we look at the global cardiac function, we'll estimate the intravascular volume status of the patient, detect the pericardial effusion and tamponade, right and left ventricular systolic function, evaluation for the wall motion, evaluation of the valve function. And if we extend it, we look at the IVC, and which will be probably guide us for the CVP, evaluation of the lower limb venous Doppler to rule out or diagnose a pulmonary embolism, and evaluation for the proximal aorta for dissection or any aneurysm. So let's start with a case. So this is a 70-year-old gentleman, non-diabetic, hypertensive, coronary artery disease, stented 2 years back, now admitted with a multiple episodes of watery diarrhea. On admission, blood pressure was low, has hypotensive, BP 80/50, have not passed urine over last 8 hours, is drowsy. So probably we'll start resuscitation in these patients. What do you think? What is the cause of hypotension or shock in this patient? Hypovolemia, right? So this is a hypovolemic shock. and probably you do not need an echocardiography to begin with, right? So this is a clinical assessment is enough to diagnose that this patient is hypovolemic, and probably that is the cause of shock. But important to remember that there may be a component of septic shock, because this patient has a gastroenteritis in appropriate scenario. Probably you can gram-negative enterobacterial infection, bloodstream infection. So along with that, what is the component of hypovolemic shock? What is the component of the septic shock or vasodilatory shock? Probably then your next evaluation will help. So these are the basic cardiac windows. Not working. Okay. So this is apical window. This is parasternal. Parasternal usually have parasternal long axis and parasternal short axis. Parasternal long axis means you can see the atrium and ventricle both. In short axis you can only see the ventricle. This is subxiphoid and this is suprasternal. Suprasternal has a very limited utilization in our daily practice. So these are the cardiac window. So we'll start with the apical fourth chamber. And you can see in the picture in the right or left of the screen that there is a RV dysfunction. There is an RV is distended and probably the septum is little pushed back. Next is the parasternal view. Parasternal can be long axis. Here we can see left atrium, left ventricular outflow tract and right ventricle, and parasternal short axis. So this is left ventricle and this is right ventricle. Next is substernal view, a subxiphoid view. Here, just below the probe, there will be liver, followed by right ventricle, followed by left ventricle. And so something opening into the left ventricle is the left atrium, and this is the right atrium. And once you rotate the probe, we will get this. This is called IVC view, because when the pointer usually turns towards the cephaloid direction. Okay, at least majority of us using it for the assessment of the IVC. So what are the associated ultrasound findings? We already discussed that along with fluid responsiveness, we have to look for the fluid tolerance. And to evaluate the tolerance, mostly we look at the lung, because this is easily measurable. So if you look at the picture and this is called A lines. These are horizontal lines, indicate normal aeration in the lung. And on the left, that is called B lines. These are vertical comet-shaped lines starting from the pleura, ending at the base, moving with respiration, and it is obliterating the A lines. So once we get this finding, only then you can say this is a B lines. And B lines means there is a de-aeration. De-aeration means there is less amount of air, there can be fluid, there can be interstitial thickening, there can be anything that you have to interpret in clinical ground. But it means there is a de-aeration. So suppose in a clinical context, we say this is a pulmonary edema. The sound is coming.
হ্যাং করে গেছে 50 খানা অ্যাডভাইস দিয়েছে একসাথে
Just what is this? So once you get a pulmonary edema, we have to say whether it is cardiogenic or non-cardiogenic, because our treatment will be different. So for cardiogenic, as the lung is normal, so the edema, pulmonary edema or the B line distribution will be homogeneous. It will be gravitational distribution because this hydrostatic edema. No, lung is normal, so it will be smooth pleural line and no subpleural consolidation. This is called subpleural consolidation. It indicates the underlying lung is pathological. There are small pneumonia or solid lung below the pleura. It is very common finding in extensive pneumonia and ARDS. That indicates there is an underlying lung pathology. And we can measure it also. That if
অনেক জ্বালাই
This is not from my presentation. I don't know where it's coming. So even if with the hydration you found that with fluid resuscitation that the number of B lines are increasing, that means there is a worsening in the pulmonary edema and probably this patient is not fluid responsive. So along with echocardiography, if you look at the lung, you will be able to see that whether this patient is tolerating your fluid resuscitation or not. And along with that, you also can measure the left ventricular filling pressure. So that means if the left ventricular is required filling at a very high pressure, then there is probably a component of cardiogenic pulmonary edema too. So you have to differentiate that whether this is a only non-cardiogenic pulmonary edema or there is a cardiogenic component. Because if there is a cardiogenic component, patient is severely hypoxic, probably you need to give some diuretics. So by measurement of the left ventricular filling pressure, you can say whether there is a contribution from cardiogenic pulmonary edema or not, along with non-cardiogenic one. Now we look at the anatomical evolution of the heart, how heart looks. So right ventricle is the only chamber that can have an acute dilatation. Left of the chambers, if dilated, it's chronic. There's no doubt about it. Left ventricle usually look conoid in shape with a pointed apex. Major axis and minor axis ratio I have seen. This is to background to mute korbe. Background sound as mute korte hobe. And the wall thickness is around 1 centimeter. And if you look at the chamber size, the diameter is usually less than 5 centimeter. So if the wall thickness is more than 1 centimeter and diameter is more than 5, probably there is a hypertrophy and dilatation. How is going to help? If we know that the heart is pathological, probably fluid resuscitation will be more judicious and more guided. For the right ventricle, it is usually 1/3 and 2/3 compared to the left ventricle, and diameter is usually less than 3 centimeter. It is normally triangular and crescent shaped. So when you get a triangular and crescent shaped right ventricle, probably there is a scope for fluid resuscitation. And left and right atrium chambers are usually small, and they are usually 1/3 of the left ventricle. Intraventricular septum, mostly the intraventricular septum is convex toward the right side, and intraatrial septum is either in the neutral position or convex, or mid-systole there is reversal. But why the intraventricular septum is important? Because there is an RV dysfunction, there is a pulmonary hypertension, you will get the septum is get flattened. We'll skip this. We look at the left ventricular systolic function. So does eyeballing is enough, or we need to do the measurements? Problem is that measurements need a lot of calculation if you go wrong, because those are only the Doppler principle. So if you go wrong by a small amount, eventually finally it can be multiplied in a great extent. So unless we understand the measurement principles, it is better to go with the eyeballing technique. And studies has shown that even if you regular practice, eyeballing is good enough for the intensivist. Whether your ejection fraction is 50% or 45% doesn't matter, basically. You have to see whether giving fluid, whether your cardiac output is going to increase or not. But there are techniques by which we can measure. One is called fractional shortening. When we measure in a one-dimensional way, we put a cursor and we'll measure the contractility of the heart. When you measure in a certain area, which is called fractional area changes. And if you measure the whole left ventricular chamber, that can be done by a called biplanar method or modified Simpson method. Here we measure the whole volume of the left ventricle, both in 4-chamber view and 2-chamber view. Okay, 4-chamber means in the apical region we are looking at the septum and the lateral wall. Here we turn the probe, look at the anterior and the inferior wall and the posterior wall. So if you measure in 2 plane, probably the volume of the left ventricle will be measured better, will be more accurate. Okay, and the normal value we all know that if it is more than 55 is normal, 45 to 55 mild dysfunction, 30 to 44 moderate dysfunction, less than 30% severe dysfunction. But again, in a given case of severe dysfunction, patient may be to some extent fluid responsive. So 30% ejection fraction does not mean you will not going to give fluid. You have to give fluid judiciously. And another important, if someone has a normal ejection fraction, that does not mean the patient has a normal stroke volume or cardiac output. For example, in the first case, even with because ejection fraction is 15%, but the endoscopic volume is high, the effective stroke volume is higher compared to when the patient has an endoscopic volume of 90% and ejection fraction is 40%. So this is very important in case of concentric LVH, because the endoscopic volume is so small, even with a normal ejection fraction, the cardiac output may be very less. Now if you look at the hypovolemia, as our patient started, initial anticipation was hypovolemia. So if we do an echocardiography, we will do the chambers are empty. So you can see that all the walls are coming close and the end systolic volume is literally 0, right? So this is called kissing sign, that left ventricular walls are coming and kissing each other. That means the patient is hypovolemic. And if you measure the left ventricular endostolic area less than 5.5 centimeter per meter square, that indicates hypovolemia. But by eyeballing, we are pretty sure that this is hypovolemic. Now we can use this understanding for our monitoring also. You start giving fluid and you look at the what is happening to the left ventricular chamber. So if you follow this, then you will find after the certain time left ventricles are apparently full. So probably now you cannot give more fluid blindly or empirically. Probably you need more detailed assessment to give more fluid, right? Inferior vena cava we have already discussed, but we have to understand inferior vena cava is measurements, absolute value, respiratory variation, everything is not very sensitive and specific. It works very well at two extremes. If it is absolutely collapsed or hugely distended, probably it is helpful. Otherwise, in between, it is not that specific. So probably in our patient, if we get an IVC like this, probably this patient is volume is full and probably fluid is not going to help. But you are not going to get much patients like this. Most of the time, probably 1.5 to 2 centimeter with a moderate respiratory variability. In that situation, inferior vena cava is not that helpful. But if you look at the dynamicity, what we can do, we can look for the respiratory variation. So it can be inferior vena cava distensibility index in case of positive pressure ventilation or collapsibility index in case of spontaneously breathing patients. And cutoff is around 15 to 18%. If the variability is more than 15 to 18%, probably this patient is fluid responsive. Now, if we are not able to identify the inferior vena cava because this patient has an upper abdominal surgery, we can extrapolate it from the assessment of the internal jugular vein also. If the internal jugular vein is collapsing, probably this patient is fluid responsive. But this is not that standardized. There is not huge data to say this should be the cutoff. More advanced technique is to look for left ventricular outflow tract velocimetry. Okay, where we can do, we look at the left ventricular outflow tract and look at the flow. And as sir mentioned, even with the respiratory variation, even with the fluid or other passive leg raising test, we can see with our intervention whether this left ventricular outflow tract flow is increasing or not. Eventually, the left ventricular outflow tract flow multiplied by the diameter of the left ventricular outflow tract is the cardiac output, right? So diameter is going to be constant. So if we just look at the flow and its variability with time or our intervention, we can see that whether this patient is going to be fluid responsive or not. So gradually, from measuring the pressure from the CVP, we are moving towards measuring the volume. Stroke volume is basically a volume, it's not a pressure. We extrapolate it because measurement of volume is challenging compared to pressure. So now if we can do this technique, we can see that this volume measurement will be more corroborative of change in cardiac output. And there are studies that shown if you do different interventions like tidal volume challenge, as sir mentioned in the previous talk, they will increase the tidal volume, so there is a change in intrathoracic pressure and it is going to influence your cardiac output either by tidal volume challenge or by passive leg raising test. There are multiple data in these two regards. Then you can see that with this intervention whether your cardiac output is increasing. Even if you can just measure the VTI or can just measure the peak velocity of the left ventricle, we can predict that whether this patient is going to be fluid responsive or not. So suppose the hypovolume part we have taken over. Next is suppose our patients, after that we did optimal fluid resuscitation. Apparently the septic component is there. We started on antibiotic. Blood pressure was stable with noradrenaline and vasopressin, and the supports are gradually decreasing trend. But on day 2, again the patient has a worsening hypoxia. We escalate antibiotic as our standard practice. There is also worsening acidosis with increasing lactate. So now what? We'll go back and do the echo again. There may be a new event. And what we find? We found there is a significant drop in the contractility. That may be as a part of stress cardiomyopathy or can be because of septic cardiomyopathy when there is a global hypokinesia. In stress cardiomyopathy, you can see the base is moving well, but there is apical ballooning which is not moving well. Now, if there is a regional wall motion abnormality, then what we have to do, because the treatment will be different. So, we have to identify which is the vessel. And mostly what we do, we can differentiate between this member, whether this is a problem of the left anterior descending or this is a circumflex problem or the right coronary artery. And it's for an intensivist, easiest option to go with the parasternal short axis. So here we can see, this is the anteroseptal wall, this is the infraseptal wall, this is inferior wall, inferior lateral, anterolateral and anterior. So by this, if you can identify that which part of the septum is not moving probably we can identify a culprit vessel, and it may help you in further treatment. Next, so from by the assessment till now, we can identify hypovolemic shock, we can identify cardiogenic shock. It can be regional abnormality in the myocardial contractility, or can be a global hypokinesia. So now after day 10, the patient is still on ventilator, is on weaning process. And now one episode of GI bleeds, the patient is on pantoprazole, new onset shock with worsening hypoxia, not tolerating pressure support anymore. Was on the verge of weaning, now again go back, hypotension, respiratory failure. Now what? We'll do an echocardiography and the other focus assessment. So what we found? We found this. So what we can see, there is a definite dilatation of the RA and RV. Septum is deviated, and the contractility is not that good. Compared to the left ventricle, RV contractility is little different. So the free wall usually contribute less, around 15-20%. The main contribution is by the movement of the annulus or the base. So RV contracts like this rather than LV, which contracts like this. Okay, so we measure the movement of the annulus to interpret the RV contractility. And also we can see there is a flattening of the septum here in the parasternal short axis. And the left ventricle is look like a D. So normally the RV-LV ratio is less than 0.6. If it is moderate dysfunction, it is 0.6 to 1. And severe dysfunction, right ventricular end-diastolic area is more than left ventricular end-diastolic area. So it indicates the severity of the RV dysfunction and the pulmonary hypertension. And at the same time, as we discussed, RV can get acutely dilated. And if we really want to measure the RV contractility, we can measure the movement of the annulus. We have to put a, we're not coming here, M mode here, and look at the movement. So you'll get a picture like this. This is called TAPSE, tricuspid annular plane systolic excursion. Normal value is around 1.3 to 1.6. So what happened in our patient? We found the TAPSE is significantly less, 0.8, 0.9. So there is an acute onset RV dysfunction. And if you want to measure what is the pulmonary hypertension, we can put a continuous Doppler here, and we can get the pulmonary systolic arterial pressure. That is the maximum pressure. And along with that, we have to add the value for CVP. Okay. We have to remember, in acute RV dysfunction, pulmonary pressure will not be that high. It will be around 40 to 50. As I mentioned, RV doesn't have a muscle, so they cannot generate a very huge pressure. And interventricular septum, because of the high pressure, will be deviated. In parasternal short axis, we will get a flattened septum. This is called D-shaped ventricle, D-shaped left ventricle. And if you want to confirm the source, we can do for lower limb venous Doppler. Mostly we go for 4-point compression ultrasonography. We look at the two femoral vein and the popliteal vein, because the veins distal to it usually does not embolize. Here we can easily identify the veins are not compressible and there is a soft thrombus developing into the femoral vein, right? Next, for the cause of obstructive shock along with pulmonary embolism is pericardial effusion and tamponade. So sometimes it can be very obvious that you can easily identify there is a diastolic collapse of the right ventricle and the systolic collapse of the right atrium. But sometimes the fluid volume may not be significant. But we need to remember, it is not the volume. It is not the volume, but the clinical implication of this, of the pericardial effusion. That helps us to diagnose tamponade. So these are the things we can measure. And there are multiple protocolized structured way to diagnose or proceed in case of shock in critically ill patient. One is called FATE, and this is called rush protocol, where you look at the pump, that is the heart, the tank, that is the fluid status, and the pipe, that is the vessel. And also we can utilize it or incorporate it into our CPR, that is ACLS protocol, to look for the 5T and 5H, which are the correctable factor. So to conclude, this is an excellent modality to review hemodynamic status. Mostly have to be goal directed, and comparatively for the basic echocardiography, it's a small learning curve. but it is user dependent. So daily time, if you use it, you will be more and more competent and more confident to use it. Cannot, only problem that it can be done only intermittent, it cannot does continuously. So in certain patients this may not be that helpful. You need a continuous hemodynamic monitoring, and for that you need to be well versed with other modalities also. And there are some inherent drawback of ultrasound, like if there is a pneumothorax, subcutaneous emphysema, this modality is not going to help. By this I like to conclude my presentation. I'm happy to take questions. Thank you.
Thank you, Dr. Sudipto Mukherjee. Thank you for a wonderful presentation. And our next speaker is Dr. Sanjeev Patra, who is the Director and HOD of Cardiology in Desun Hospital. He has done his MD in Medicine. After that, he has done MD in Cardiology from AIMS New Delhi.
Good evening, and welcome you all to our hemodynamic workshops. It's a opportunity to to learn for all of us something regarding how to manage our patient who is sick, asking for our help. So today my talk will be about to help them more, but that help will be costly for them, but often that help can be necessary.
নাম্বারটা বলুন দাদা 84 82 400 400 72 146 আমার দীপ কুমার
সাউন্ড এখানে বন্ধ করতে পারছি
Okay, I'm on.
না স্যার আপনি বলুন
কে 200
স্ক্রিনটা শেয়ার করুন
Okay. Okay, good morning. This is Sanjeev. So I will talk about
দুটো
How-
যেতে বাদিক দিয়ে বিজ্ঞান হসপিটাল এখান থেকে হ্যাঁ
Please unmute.
am I on? So I'll talk about the ventricular assist device. So we know that we have multiple modalities to treat heart failure, like to treat them with drugs, like to put them a cardiac resynchronization device, we call it CRTP or CRTD along with AICD sometimes. But often they need a short-term support when they crash and there's a hypotensive. So sometimes they put a intra-aortic balloon pump, which is a kind of a left ventricular assist device. And sometimes we need to go for ECMO for patients who requiring larger hemodynamic support. But still, many of the patients, they will have advanced heart failure and they need something more for their heart failure. So that is ventricular assist device. So we had tremendous progress in for last 20 years, and we have several generations developed over time, and thousands of patients are now had this ventricular assist device worldwide, and hundreds of centers worldwide. But it requires a proper infrastructure, a good transplant team, and good coordination between the clinician, physiotherapist, infectious disease team. So a little rather multidisciplinary approach is required for these patients. So what are the device? So basically we can classify this device regarding the location, where do we put them, regarding the ventricle they support, regarding the pumping mechanism, and the duration of the support. So if we put them outside the body, we call them extracorporeal, or paracorporeal if they are just adjacent to the body, intracorporeal when they are implanted inside body, sometimes in the tummy, or orthotopic, that is the normal position of the heart. And we can call them left ventricular assist device, right ventricular assist device, biventricular assist device, and ultimately total artificial heart. The picture is of a total artificial heart, and it's implanted orthotopic in the position of the heart. So we also classify them regarding the pumping mechanism, like pulsatile flow, or the continuous flow with axial design in one straight line, or continuous flow rotary pump with centrifugal design. So now the temporary devices, I can talk about these like little briefly. Like one is intra-aortic balloon pump, second is impeller device, we can put temporarily from the percutaneously, and the tandem heart, it's a kind of device we can put in the cath lab, and the VA ECMO. So to start with intra-aortic balloon pump, it basically is a counter pulsation, and it's a pneumatic with the helium gas rapidly going inside the balloon or coming out, and it supports the LV. How much is the support? Not much. Around cardiac output by 0.5 liter per minute, I can say increment. So it's a partial support. So what's the mechanism for intra-aortic balloon pump? So what they do, they inflate during diastole. So you can say, if you see the graph, it's diastole inflating, causing the increase in pressure in the diastole proximal to the balloon. So it basically increases the aortic diastolic pressure. So that helps. How? They improve the coronary flow, because coronary get blood only during diastole. Regarding brain, it's kind of a neutral effect, not much increment in the output to the brain. And when it depletes during systole, so what happens? There's a decreased resistance during systole, so it increases the blood flow below diaphragm. So it deflates just prior to the systole, it inflates at the diastole, so it increases the blood supply to the myocardium, and so it reduces the myocardial oxygen consumption and helps the myocardium for short time. So indication: cardiogenic shock complicating acute myocardial infarction, prior to high risk PCI, left main PCI, single cervical vessels, prior to high risk CABG, left main CABG, 99% lesions, patient having stable angina, rest pain. So surgeon tell, let us put the IBP for sometimes before surgery. Acute severe MR. After infrared MI, patient developed papillary muscle rupture, resulting in the acute MR. The patient is hemodynamically unstable. Let us put a IBP. Ventricular septal rupture. So need to stabilize before sending him to surgery. So need to put a IBP. And sometimes as a bridge to transplant in a patient where we don't have a proper ventricular assist device. So then we can poor man's ventricular assist device, intra-aortic balloon pump. We can put the balloon pump and then call, they can wait, tell the patients, wait, let us wait for if we can get any heart for you, or you can get any proper left ventricular assist device for you. What are the contraindications for AIBP? Severe AR. So if you put a AIBP, it will increase the diastolic blood pressure. So what will cause? It will produce more air. Air means the blood, that's the blood flow in LV during diastole. So it will increase the air. So in acute severe air, don't put AIBP. In aortic aneurysm, don't put AIBP because we put it in the aorta. If there is aneurysm, it can rupture the aorta. Aortic dissection, don't put AIBP, contraindication. Limb ischemia, don't put AIBP. Limb can be cut down and you can face medical-legal issues and thromboembolism because it's inside the aorta. So that if you don't anticoagulate properly, it can result in a clot and cause limb ischemia, stroke, many things. So like 5-6 years back, we used to put IBP. Hey, let us put IBP, let us put IBP. But nowadays, indication is not that compelling. The classification, they used to be class 1, now class 2A, B. With the Europe, they say not even class 2, class 2A, class 2B, and sometimes class 3. So, routine use of AIBP with cardiogenic shock is not recommended. We need to put only there is a mechanical complication like papillary muscle rupture, severe MR, or ventricular septal rupture. Routine cardiogenic shock doesn't help. So, we are not putting AIBP nowadays. In a routine blood pressure, we treat them with the inotrope and other therapy. So this study done in 2018 in acute MI with shock, the mortality in the AIBP and the control group, both high, is around 66%. So IBP didn't help them. So no difference in stroke, repeat revascularization, hospitalization. So almost equal. IBP, no IBP, almost equal. And mortality, which is a mortality, around 70%. So routine IBP use in acute MI with shock is not useful. Now next comes Impella. Impella is another device which is basically an axial pump. We put it in the left ventricle. It sucks blood from the left ventricle in the proximal part and release it in the ascending aorta. So it's basically a pump. It sucks and the blood from the left ventricle is in the ascending aorta, and it's a pump rotating in a high speed. And the percutaneous one where is to put is 2.5. It can increase the cardiac output by around 2.5 to 3 liters per minute. That's a larger device, but we need to take help of the surgeon because it requires large caliber sheath. That can Impella 5, that can increase the cardiac output to 5, almost full support. So Impella is put inside from the aorta, and it go retrogradely and from the aortic valve into the LV. So advantage, like AIBP, you need to have a ECG guideline because machine need to know when it's systole, when it's diastole, all those. But Impella, it does a pump, continuous, so ECG blood pressure doesn't matter. If there's no blood pressure, IBP won't help, but Impella will help because it doesn't detect IBP, it just sucks blood from the LV and producing the aorta. So, in case of arrhythmia, EMD, we can put a Impella device, but not AIBP. Problem, risk of device migration. The device can perforate the LV cavity. Device can malform, the pump can stop and there can be huge thrombosis inside the pump. There can be hemolysis because it's a high speed screw running inside the blood. It can cause hemolysis. It can cause bleeding in the femoral artery puncture site. Can cause arrhythmia when there's a pump is touching the LV myocardium. It can cause limb ischemia because sheath is larger in size. And if you perforate the LV, it can cause a tamponade. It can cause mitral valve injury or aortic valve injury when you are trying to put the Impella device. Next comes ECMO. ECMO, you'll know, I not talk about much. It's normally we do use a VA ECMO to support the ventricle. So it sucks blood from the IVC or SVC and oxygenate the blood and put it back in the femoral artery. So it basically it goes from below to up and some part of the blood will be come from the left ventricle. So it's a ECMO and support is almost full, 4 to 6 liter per minute. But problem is that complications are pretty high. This is a study done via ECMO for PCM, myocarditis, post-transplant. The in-hospital mortality is 58%, and long-term survival is only 34%. And majority of the patients, they had more than one ECMO-related complications. So ECMO carries a risk. So now people try to do how to do a better way, more comfortable to the patients. Patients can move. Patient don't need a large device beside him. So then came the left ventricular assist device, small. And the study shows that with the newer device, small, which can implant in the heart, we can find that there's a 48% reduction in mortality in those patients who are class 4 symptomatic. So there's an increase in the survival rate from 52% from 25%. But the definitive treatment for this patient, class 3, 4, is a cardiac transplantation. But donor heart is limited. So till that time, patient gets a transplant, LVAD are life savings. So time of implant, when all pharmacological and non-pharmacological means have been explored, and we need to put it before end organ damage and started. Can't put it like everything gone, kidney gone, liver gone. Need to put it early. So we have a small window of opportunity. So need to have a transplant assessment complete before that. So complete the transplant assessment, put the assist device, wait for the heart. So what are the evolution? We can see this journey started 1950, and D. Becker in Houston. Can you please mute some? So So journey started in 1950s. The D. Becker, you know, this pioneer in many things. He started one program in that Houston. So they started put a pump in successfully in a patient in 1954. So after that, many things happened. We had first generation device, second generation device, and now third generation device, which approved in 2017 by FDA. So the anatomy physiology basically similar. It's we put something in the LV ventricle. That's the inlet from the LV, and outlet goes to the aorta. Most commonly ascending aorta. So when they started manufacturing it, they thought we produce a latest natural way, pulsatile flow. So that's what to do. They put a piston there, like compressing the like goes this. So it's become a like they tried to mimic the normal physiology. So there is a motor there, and there's a housing, and it's like a piston going up and like down. So it's a large device and huge noise. You know, it's kind of, you can hear the pump is going on. Always something moving. Is something is like what I say, thumping inside your body. So and the infection rate was pretty high. So they thought no, that to mimic the natural way is not working. There's a lot of complications. They thought make it simple. Let us try not to mimic the heart. So those devices become continuous flow. No more pulsatile flow, continuous. So it won't get a proper blood pressure like systole diastole. So one blood pressure, mean arterial pressure. So what happens now, that is basically a rotor like impel ISO is basically rotates like this, and then sucks the blood from inflow and put it to the aorta. So that is HeartMate 2. And these are much smaller and easier to implant. We can see the picture. It's basically just put it in the LV apex and another to the aorta. And there is a spiral shaped pump which rotates and like screw mechanism, it sucks the blood and it supplies the blood to the ascending aorta. Quieter, not much noise because nothing is no piston like thing. So this is a magnified view. We can see that this is basically the screw there and rotor there, and it takes the blood from the ventricle and give it back to the aorta. So survival rate 75% at 6 months, 68% at 1 year. So now let us have an idea. So around 60-70% they are alive at 1 year with the second generation device. Good, and many of hundreds, thousands of HeartMate 2 implanted worldwide. Simpler to use, not much big, and it's a so no more pulsatile device. Now come to third generation device. So they found that if having a ball bearing, all those stuff gets problem. So they wanted something which doesn't pump, something moving, but it doesn't come in contact with the machines. So they use a magnet. So they're magnetically suspending the screw and rotating it. So that this is, you can see the picture. This rotor with magnet doesn't come contact with any surface. So no more squeezing of the RBC, not much of hemolysis. So machines activated, magnet activated, the rotor is rotating there and without touching anything, no ball bearing. So like we can say that bullet train. So elevates on the track and it runs. So like bullet train, it doesn't touch anything, so doesn't not much interfere with the blood particles. So lower shear stress. So this is a wonderful device. Now it's a more smaller device. You can see the picture, and this is called HeartMate 3 or hardware. Now in the trial, it started with the fully magnetically elevated these devices. The 2-year survival rate is 75%. 6 months is 68. So this third generation device, they can live to 75% of them. They can live to 2 years. And now next come total artificial heart. So what they do, they basically replace the heart with these 2 assist device. So it's a Syncardia total artificial heart. Around 2,000 patients implanted this device, and it's powered by air. So immediate safe blood flow, and this is the picture. You can see they cut down the ventricle both right and left, keep the atria there, and they suture the devices to the left and right atrium and pulmonary artery to and left and aorta respectively. So it's an orthotopic transplant. Result, so 1 year survival rate is 70%, and 5 year and survival to transplant is 80%. So they needed transplant, but people survived till transplant with this total artificial heart. So indication, now bridge to transplantation, we put the device, wait for the transplant, or sometimes when the surgeon said patient is not a candidate for heart transplant because of the kidney issues, lung issues, so that we can put as a destination therapy just to give them a few years of life, or bridge to decision. Surgeon not decided yet. Okay, we might give a transplant, might not, let us see how his kidney behaves, how other things behave. So that is the bridge to decision. You put the assist device and monitor him. Or bridge to recovery. When there's a myocarditis, post-COVID, we know that patient will recover, or peripartum cardiomyopathy. We can put those devices and wait till recovery. That is called bridge to recovery. So most of the devices put today is the bridge to transplant. And some patients where they're not a candidate for heart transplant because of the comorbidities, we can put a destination therapy so that they can live 2-3 years more. So this is the chart. You can see that's a classification as an intermax. The intermax 1 is like cardiogenic shock, critical, patient is going to die within hours. Despite patient is no hydros, NORAD, vasopressin, all those. There's a intermax 1. 2, progressively declining. Patient is going to 1, but this patient all anotrope, but is declining. 3. Stable but inotrope dependent. 4. Inotrope is often on inotropes, not dependent but sometimes requiring inotrope. 4. 5. It exertion intolerant, rest well at rest but minimal activity cause symptoms. So from 5 to 2, those are the patients we can put a left ventricular assist device. We generally not put a assist device who has class 3 symptoms but still can do some work like 7 or 6. So when they're walking, running, wait for the LV assist device, but as soon as they become inotrope dependent or requiring inotrope off and on, we need to think of LV assist device. So these are the mnemonics. The I need help means patient requiring IV inotrope, patient class 3 carport symptomatic, and end organ dysfunction settings in, ejection fraction less than 35%, better than less than 25%, patient having AICD shocks because of the heart failure, more than 2 or 3 hospitalization in because of heart failure. So those patients are asking for help and need to consider putting LV assist device in them. So this is a strong indication. NOHA class 4 for last 2 to 3 months. Maximally tolerated medical therapy. Already had an AICD. Chronic dependence on inotropes. LE function less than 25%. PCWP more than 20. Systolic blood pressure less than 90. And cardiac index less than 2 liters per minute. Evidence of declining renal right ventricular function. UC creatinine going up. So don't wait. Patient is class 4. Okay, these are the candidate. This patient is candidate for LV assist device. Contraindications: if there is a right ventricular dysfunction, don't either go for a biventricular or straight away a heart transplant. Single ventricular assist device doesn't help. It does a right ventricular dysfunction. Acute cardiogenic shock with neurological problems, stroke severe. Not very cost effective to put a LV assist device. It will only increase the cost and morbidity. Don't do anything. Neurological problem, do nothing. Severe other problem, kidney, pulmonary, liver, neuro issue, not a candidate for LV assist device. Platelet count less than 50,000, not a candidate. Active bleeding, not a candidate. Hypertrophic cardiomyopathy or large VSD, not a candidate. Hypertrophic cardiomyopathy, you don't have space to put a pump there. Body surface area less than 1.5 meter square, the problematic. And each machines require higher patient, family and patient compliance. If you think that they can't take care of themselves, don't put it. It's a costly device. So complications of LVAD, bleeding. So post a perioperative period, there's a bleeding because we need to give anticoagulation so that there's no clot there. So even because it's a pump rotating in a very high speed, it sometimes causes deficiency in the VW factor and causing better dysfunction. So bleeding is an issue, and bleeding can happen at any conduit like any anastomosis sites. Thrombosis, another issue that can develop pump thrombosis because of the less anticoagulation or atrial fibrillation or infection, and sometimes pump problem. Another problem is the hemolysis. So these are issues with them, and second, most important is right ventricular failure. Sometimes we put a LV assist device and patients can develop right ventricular failures after some time, because once the patients now there's a left ventricular unloading, septum shifts to the left. So the load increases to the right ventricle, because now right ventricle is getting blood around 4 to 6 liters per minute, which not accustomed to. We initially our LV used to pump a little less, 2 liters per minute. Now it's getting blood 6 liters per minute, high blood flow, continuous load on the RP. So that can cause right ventricular failure. And sometimes they need to have a ECMO or RV assist device to support the right heart. Infection, dreaded complications. Because so many things going out of the body, the infection bacteria can track inside the body, and that can cause long-term infection. So Staph aureus is the most common, but Enterococcus and other Pseudomonas can be there. And aggressive treatment is required. Sometimes you need to take out everything and wait for transplant. So infection control is a very big thing. So patient compliance is required. neurological stroke because of the issue with the both hemorrhagic and ischemic stroke can be there because of hemolysis or clot. And one of the devices withdrawn from the market by Medtronic because of the CNS event. So only Abbott is now supplying most of the HeartMate. So Medtronic device withdrawn, they're not going to manufacture anymore because they have increased neurological issues. So stroke. So optimum anticoagulation, INR monitoring is required. Arrhythmia, because sometimes this pump can touch the LV myocardium. If it takes too many blood from the LV, and thus the LV cavity can get squeezed. And if you touch the metallic thing touch the LV cavity, there can be arrhythmia. So what you need to do? Give fluid. Give fluid, dilate the LV, the arrhythmia will disappear sometimes. But sometimes it can due to scar formation that you need to tackle with either drug therapy or ablations. So most of the time, basically, it's a contact issue because of the irritable myocardium. So for a left ventricular assist device, you need a lot of people: surgeon, physician, perfusionist, physio, patients, VAD coordinator, EP people. So lot of people to take care of these patients. And teamwork is essential. So let's brief. What is the surgical procedure? Standard medial sternotomy. Open the pericardium, expose the LV apex, lift the LV apex, choose where you want to put that. Then sew the sewing ring in the myocardium with the 8 to 12 Dolber dump suture, and it's kind of reinforced with the felt strip. So make this, then you put it inside the apex like a plunger, and then fix it in that your ring, and then we attach the other part to the ascending aorta, and you take out the extension from the body, the epigastrium, and you are done. So this is the picture we can see now all in place. So thank you all. I conclude my talk.
Dr. Patro, thank you for your excellent presentation. After Dr. Patro, we will be welcoming Dr. Chandan. Dr. Chandan Kumar Mondol, after his MBBS, has done DNB anesthesia from RNT and thereafter continued as an FNB cardiac anesthetist, and he is also a FIACTA certified person. Recently, he does most of the congenital cardiac cases in RNT. So as to say, Chandan and me has worked for a long time in RNT, and we say that our consultant RNT now will tell us about the TE in critical care setting, the basic settings, right heart as well as left heart. On to Chandan.
That's fine, but এটাকে তুমি কানেক্ট করবে কি করে? আমার তো HDMI ক্যামেরা লাগবে না, এখানে যেটা দিয়েছো সেটা এখানে কেমন লাগবে? নিড দ্যাট ওয়ান স্যার, পিন তো ট্রান্সফার করে না, বাট এখানে HDMI ক্যামেরা কানেক্টর আছে তো? HDMI কানেক্টর তো আছে, হ্যাঁ, তো HDMI কানেক্টরের সঙ্গে কানেক্ট করতে হবে না? তুমি আইপি এটা করে দিচ্ছি স্যার, হ্যাঁ এটা করে দাও, এটার সঙ্গে এটা লাগবে। ভালো না, এটা কিভাবে কানেক্টেড আছে? এটা কার সঙ্গে কানেক্টেড? এটা স্যার এই এর সঙ্গে কানেক্টেড। হ্যাঁ, কিন্তু আমি এখান থেকে যদি নিতে চাই, এখান থেকে এটা শেখাও হবে না, এটা কী করতে হবে আমাকে? এটা ওখানে খোলাও যাবে না, না এটা খোলা যাবে না, আপনার যা নিচে আছে ওই মেলে আছে, নো এটা অনেক বড়। কত কত এই পারমিটার দিই, ইউ হ্যাভ এ প্রবলেম। সেটা হচ্ছে এটাতে এইচডিএমআই এরা বলছে এইচডিএমআই লাগানো যাবে না।
কানেক্টরটা আছে নিয়ে
কানেক্টরের কাজ এটা তো কানেক্ট এরকম কানেক্টর নিয়ে এসছে তো এতে এইচডিএমআই লাগলে মানে এটা তো কিভাবে কানেক্টেড হচ্ছে এটাতে এটা জুম
হ্যাঁ তো এটাই তো এখানে
না ও হচ্ছে তাহলে এখানে দেখতে পাবে
এটা করে দিলে তো দেখতে পারবে না
তুই পেন ড্রাইভে পাঠিয়ে দিন না
আরে পেন ড্রাইভ তো নেই আমি তো মেলও যাবে ইয়ার হ্যাঁ এটা তো পেন ড্রাইভ যায় না ইয়ার
মেলও নেই
আরে মেলে আছে কিন্তু মেলেটা বড় মেলাতে যাবে না
ঠিক আছে এখন মেলে
আচ্ছা
পাঠাচ্ছি
আমি বলছি এখানে লোকের কাছাকাছি বসে বললে হবে না
ইউটিউবে লাইভ করছিস তুই ইউটিউবে লাইভ করছিস
তাহলে কি করা যায় তোমাদের আইটি লোক কাউকে নেই আরে কি
রঞ্জন বল
হয় না স্যার
হ্যাঁ
সাধারণত হয় না এটা তিনটে একসঙ্গে চলে
তুই আই
আরে এটা বন্ধ করে দিলে হবে
ম্যাকবুকের ট্রান্সফার হবে তোর এটা আমার ম্যাকবুক আছে
আমার ঘুম থেকে ম্যাকবুকটা নিয়েছি ম্যাকবুক নিলে আমি এয়ারড্রপ দিয়ে ট্রান্সফার করব
হ্যাঁ সেটাই
সেটাই ভালো হবে
আচ্ছা এটা আমার না তো
ওই এসে গেছে আইসি ওটা
আচ্ছা ভাই
এইটা তিনটে একসঙ্গে চলবে
আমার এইচডিএমআই কানেক্টর দিয়ে এটাকে নিয়ে আসতে হবে এখানে
এটা এখানে যাবে
হ্যাঁ আমার এইচডিএমআই কানেক্টর মানে আমি নরমালি যে কোনো প্রেজেন্টেশনে হয় নিশ্চয়ই বুঝতে পারছো এই
এখানে কানেকশন নেই ভিজে কানেকশন এখানে এইচডিএমআই আছে
আমারও তো ম্যাকবুক মানে এই ড্রপ করবে
আমি এয়ারড্রপ করে তোমার এতে নিয়ে যাবো
তিনটে একসঙ্গে কানেক্টিং তো হয় না
ঠিক আছে এটাকে বন্ধ করে দিয়ে আমি এটা
ওই হেড এই হেড স্যার
এই হেড
আপনি একটা কাজ করতে পারেন স্যার জুমের লিঙ্কটা পাঠাচ্ছি আপনি জুমের লিঙ্ক দিয়ে বসে
জুমের লিঙ্কে পাঠাও না সেটা তো বেস্ট জুমের লিঙ্ক হলে আমাকে এটাকে কানেক্ট করতে বেশ সঙ্গে আইফোনের সঙ্গে রাখতে হবে না কানেক্ট বেশ সঙ্গে দেখি
সেটা তো হবে
হ্যাঁ সেটা তো হ্যাঁ আচ্ছা আচ্ছা
Only the host can see. It's only অনেক done. It's okay. Thank you. Done. আচ্ছা এটাকে আমি আমার বসে দরকার হয়ে গেছে ডান এটা বন্ধ করে Sorry for the technical issues. Good morning, everybody. I'll be talking on transesophageal echocardiography in critical care setting. Transesophageal echocardiography in critical care setting. So. In the previous talk, Dr. Mukherjee has nicely explained the different type of shock, how to diagnose by transthoracic echocardiography, and how to manage. And I want to stress upon particularly in this talk, what are the different information or assessment we can get from transesophageal echocardiography. So the indication of key in critical care in acute respiratory distress syndrome, acute coronary syndrome, failure to wean from the mechanical ventilation, hemodynamic instability, mechanical circulatory support, need for identification of a source of embolus, suspected endocarditis, suspected pulmonary embolism, thoracic trauma, unexplained hypoxemia, and upcoming cardioversion. So, being cardiac anesthetist, normally we manage our IQ along our OTs. So, our main concern after the post-cardiac surgery patient is mainly the hemodynamic instability. So, normally before OT, after OT, and in the IQ, we extensively evaluate the cardiac function of the by transesophageal echocardiography. But when there is some hemodynamic instability in the IQ, or either in the cardiac IQ or non-cardiac IQ, we need not to focus, everything like 28 views of SSH pattern according to SSH pattern, 28 views, extensively evaluate what the heart is doing, what are the problems. We just need to concentrate some basic views so that we can gather the information to manage the particular problem of the patient. Okay. And it hardly takes 5 to 10 minutes, maximum 5 to 10 minutes. You need not to give your valuable time just focusing non-productive information. So, better than other hemodynamic parameters because it is a minimally invasive. Still invasive. It is not non-invasive like transthoracic echocardiography, but it is a minimally invasive. Can be performed rapidly and repeated by the bedside to predict the fluid responsiveness, obviating the need for fluid challenge. 10 or 20 years back, we used to see the fluid responsiveness of the patient by giving some fluid. This is not the era of that disease thing. Characterizing hemodynamic state like low cardiac output, high LV pressure, low LV afterload, and causes the abnormality like LV systolic dysfunction, acute pulmonary or mitral reservation. So, whenever there is some hemodynamic instability, we ask ourselves some questions. What are the basic questions? Is the intravascular volume adequate? Second, the cardiac function, whether it is impaired or not? If yes, then why? Third is the valvular dysfunction is a cause or the contributor to the hemodynamic state. And the fourth is there any vasoplegia? So we need to ask these questions to ourselves to manage the patient, and it should not take more than 10 minutes. So toolkit is 3 imaging plane, combination of the 2D and Doppler imaging. It requires 10 minutes and may be repeated a couple of times in unstable patients. Whenever you are doing something, you want to reevaluate the patient after doing your management, do another TE. So step 1, mid-esophageal 4-chamber view. Out of 3 views, step 1 is the basic view, mid-esophageal 4-chamber view. We can get the ventricular size, left atrial pressure, and valvular regurgitation. Dr. Mukherjee nicely explained in the previous that by seeing method, how can we measure the left ventricular volume by doing the left ventricular area measurement. So in the ventricular side, by seeing the mid-esophageal full chamber view, we need to know the left ventricular end-diastolic area, the right ventricular end-diastolic area during the trace function. And if the LVEDA, left ventricular end-diastolic area, is dilated, so sign of pre-existing heart disease, and we need to measure the right ventricular end-diastolic area by left ventricular end-diastolic area. If it is more than 0.6, that means RV it's dilated. And if it is more than 1, severe RV dilatation. It could be due to RV systolic failure or acute or pulmonary. And on that stage, it is contraindicates further fluid therapy. Then comes the motion of the interarterial septum. See, the normal simple things gives some so important clinical judgment that sometimes we wonder that how can we miss that simple this interarterial septum. In the previous talk, Dr. Patro was saying that the LVAD. So, in the LVAD, we are running 1 centimeter now, and in the previous we have done one HeartMate 3. Simple, the volume status of a patient having HeartMate 2 or 3, we have to measure the interarterial position. We have to see the position of the interarterial septum. It is so important. Simple thing, but it is so important. So the position of the interarterial septum, it gives tremendous information. The volume status of the RA, volume status of the LA, the compliance of the RV, compliance of the LV. So in the midline, you see in the first thing, the normal atrial pressure, the septum goes rightward with brief reversal in the mid systole. Can I have that one?
Pointer.
It is a pointer. You're not? Actually, I am using the iPad, so no. In the first part, the normal atrial pressure, septum goes rightward with a brief reversal in the mid systole. During the mid systole, it goes towards the left. But in the low LA pressure, it buckling of the septum, there is the mid systole here. When there is a LA pressure is high, the septum goes rightward throughout the cardiac septum. Both this is systole, this is diastole, both sides. And in the right RA pressure, septum goes leftward throughout the cardiac septum. So by seeing the position of the interarterial septum, we can assess the volume status of the patient. Some minute information regarding this transmitral E and A wave. Pulse wave Doppler with a sample volume positioned at the tip of the mitral leaf at diastole, because we need to know the EA ratio. Okay, and if the EA ratio is greater than the 2 in combination with a short deceleration time, there is then that means it is a high LA pressure. And if you saw in the previous slide, This is the E and this is the A. Here the E is more than the A. And EA ratio below 1 with long deceleration time, normal or low elevation. The E is here and A is here. And ratio of the transmittal E wave to mitral annular E wave, sometimes we measure the E by E prime. If it is more than 7.5 elevated airway pressure, need for diuretics and therapy. So this is the ventricular by seeing the mid-esophageal four-chamber view. Now, giving the color flow Doppler, we use sometimes to assess the presence of a several mitral, aortic, tricuspid, and tricuspid regeneration. But the goal is not to quantify the grade, but to establish whether the regeneration is responsible for or the contributes to the circulatory or respiratory failure. We need not to assess, the grading of the mitral, cause of the mitral, and all these things. Just you have to assess whether there is some regeneration is there or not. Step 2, mid-esophageal short axis ventricular views at mid-capillary view. It assesses the ventricular function. It also says whether the patient is vasoplegic or not, or it sometimes tells about the acute coronary or coronally. So ventricular function, LVEDA, left ventricular endostolic area, and the left ventricular end systolic area. FSC is calculated using the trace function. If the FSC is more than 50%, is a normal function. If it is between 40 to 50%, moderately decreased function. If it is less than 40%, severely decreased function. And need for ionotropes, either adrenaline, noradrenaline, dobutamine, milrinone, depending upon the situation. This is SCCHA guideline because a guideline for this 17 segment where we can assess where the segmental wall abnormality, either it is the base level or mid level or the apical level, what coronary artery is responsible for that particular segmental problem, whether coronary LAD or circumflex or RCA. And during the assessment of the left of the ventricle, we have to assess both the endocardial movement and also the thickness. Because sometimes, when some segment is working and some segment is not working, it drags some movement of the partially partially scar tissues. But there will be no thickening. So we need to assess both the movement and also the thickening. Normal endocardial movement and endocardial thickening should be more than 30. Mild hypokinesia, the endocardial movement will be decreased and there will be 10 to 30% of the thickening. Severe hypokinesia, slight movement will be there and less than thickening will be less than 10%. Akinesia, both the movement and the thickening will be none. And dyskinesia, endocardium moves outward during the systole and thickening, endocardium this during the systole. Thins during the systole. So by this AIM method, we can assess which wall is not moving, which wall is not thickening, and which wall is doing really well. So there is two walls. It is a mid-capillary view. We have one M1. Okay. In the trans-esophageal echocardiography, this is the inferior wall. This is the anterior wall. This is the septal wall. This is the lateral wall. This is the posterior. So when the beam is going from this part to this part, first comes the inferior wall. The second part from the anterior. Here, see, there is no movement. So we can assess the inferior wall, most of this hypokinetic. But in the anterior wall, see, even systole there is thickening. In the last one, there is a thickening. So thickening is there. So we can assume the anterior wall is unaffected, but the inferior wall is affected. We need to just assess which wall is affected. Causes of segmental wall motion abnormalities. I am not going to details. Myocardial ischemia, stunning, fibrinating myocardium, myocardial infarction. Just we have to DD all these causes for these segmental wall motion abnormalities. Now, then comes the vasoplegia. Normal left ventricular endostolic area with reduced left ventricular end systolic area. Okay, that means heart is pumping well, but there is low BP. high FAC, fractional area change, but the BP is low. So we could assess, probably it might be due to the hepatoplasia. So in this scenario, need for the vasopressure for the therapy. Sometimes we need to assess the LV diastolic dysfunction. Normal FAC in presence of raised LV pressure. So in the diastolic dysfunction, because in the LV there will be systolic dysfunction, diastolic dysfunction, acute dysfunction, chronic dysfunction. In the diastolic dysfunction, normal FAC, normal fractional area change, but will be raised LV pressure. So treatment depends on the clinical manifestation. If the primary problem is pulmonary edema, reduced LV pressure. If the primary problem is pulmonary edema, reduce LV pressure by using diuretics and vasodilator. And if the primary problem is low cardiac output, judicious fluid administration to optimize cardiac output. Okay. Now, motion of the interventricular septum. This information, piece of information is also very important. At the end of the systole, just starting the diastole. Okay. So if the ECG, if we correlate with the ECG, if we see that at the end of the systole, the position of the IVS is like that, that means RV is getting dilated. And with the combination of the RV dilatation, if it is more than 0.6, indicates a acute core pulmonary. Okay, that means it's the acute RV pressure overload. So step 3, vena cava views, volume responsiveness, collapsibility index of the SVC, because by transthoracic TTE we see the IVC distensibility, and through TEE we see the collapsibility of the SVC. So SVC max minus SVC min divided by SVC max into 100. Partial or total collapse of the SVC during inspiratory accurately predicts fluid responsiveness, and more than 36% identifies the fluid responders versus not responders with a sensitivity of 90% and specificity of 100%. Okay. In this view, see, this is a bicameral view. It is a bicameral view. And if you put the A mode here in the SVC, it will give the movement of the SVC during the respiration. This is the ventilator parameter. This is the starting of the inspiration. So in the first picture, you see during the inspiration, the two parts of the SVC, the upper part and the lower part, two wall of the SVC. The upper part is not moving, but the lower part is moving. So during the inspiration, there is a widening of the gap, and during the expiration, it is shortening. So we can assume that there is a scope for volume, but after giving volume, you see there is no change. So the patient was volume responders. So just putting the P probe, putting by seeing the bicameral view and putting the A mode in the SVC, we can assess whether the patient is volume responders or not. So then I wanted to focus some of these day-to-day life our clinical parameters to assess whether the patient, and when we are assessing that patient, whether the patient is septic shock or not. What the T can give us some information. What are the important information? So to determine the fluid responsiveness and to assess the ventricular function. After initial resuscitation, 30 to 50% of the patients with septic shock remains fluid responsive. Okay, so sometimes when say, oh, we have given volume, that's now it's okay. No, 30 to 50% of the patient with septic shock remains, after giving the initial resuscitation, remains a fluid responsive. LV dysfunction is a common accompaniment to the septic shock. RV dysfunction occurs in approximately 30% of the patient with septic shock. So we normally assume that during septic shock there will be some kind of LV dysfunction, but sometimes we have to particularly see whether the RV is okay or not. May be related to acute core pulmonary or RV systolic dysfunction. Distinction between these two means that acute core pulmonary versus RV systolic dysfunction, because we have to choose the vasoactive drugs. So TE in septic shock, what is the role? To determine the appropriate fluid management, choice of vasoactive agent, and optimal ventilator setting. Now coming to the ARDS, optimal fluid management is essential. Fluid overload increases the extravascular lung water and worsens the gas exchange and the lung compliance. Hypovolemia reduces the mixed venous oxygen saturation and worsens the effect of intrapulmonary shunting on oxygenation. So even in the ARDS, we need to perform the TE. So need for fluid loading or determine the tolerance for diuretic therapy. Here, you see there is a graph. It is a relationship between the cardiac output and the alveolar arterial oxygen tension gradient in presence of various levels of intrapulmonary shunting. Okay, you see, this is the cardiac output, and this is the pulmonary end capillary by arterial oxygen content difference. Okay. When the cardiac output is low, the difference is high. When the cardiac output is high, the difference is high. So the effect is mediated by the reduced mixed risk of, in particular, there is risk of acute pulmonary is there due to the combined effect of elevated PVR, pulmonary venous resistance, and raised intrathoracic pressure, secondary to the mechanical ventilation with high infiltration pressure and high PEEP. So there is a chance of acute core pulmonary. And in ERDS, RV failure is strongly predictive of mortality in ERDS. So lung protective ventilation has reduced the incidence of core pulmonary, but still occurs in 30% of the cases. So we have to be very careful about the RV dysfunction or acute core pulmonary. Two potential adverse effects of core pulmonary. One, RV dysfunction can reduce the cardiac output, which adversely reduce the oxygenation. The second, elevated RA pressure can lead to opening of the PO4 and causing the right to left intracardiac shunting, because we normally deal with the two types of shunting, one the intrapulmonary shunting, other in the intracardiac shunting. So that part we have to take care. So treatment, need for vasopressor and inotrope therapy to support the RV function. PVR reduction, pulmonary hospital resistance, what we need to do, correct the acidosis, hypoxia, sometimes inhaled nitric oxide, and reduction of the airway pressure. There is a controversy regarding the prone positioning during the ARDS management, and removal of the pleural fluid to improve the gas exchange and lung compliance. So whether there is any pleural fluid is there or not, we can assess by TE. And there is a graph. You see, there is no acute core pulmonary, that is the blue, and the acute core pulmonary in the red. So the mortality increases when there is acute core pulmonary. So next thing is a suspected pulmonary embolism. It causes shock due to the acute RV failure. In context of unexplained shock, RV dilatation and paradoxical motion of the IVS are strongly suggestive of massive pulmonary embolism. Thrombus may be identified in the RA, RV, or PA. And study suggests chance to identify the chambers is more by TE. So whether there is some embolus or thrombus is more, the chance of detection is more by the TE. Here, in a red vessel, this is the HVC, this is the P. Okay, right? There is a thrombus. Normally, we miss all these things by TTE. Now, coming to the thoracic trauma, how TE helps. Myocardial contusion, pericardial tamponade, aortic rupture, aortic hematoma, hemothorax, traumatic mitral, and tricuspid revision. Aortic rupture. See, by TE, there is a rupture. This is the main aorta, this is the false. Okay, and this is the hematoma. And gradually, this part is gradually increasing. Okay, it is compressing the main. And they have put on stent. After putting the stent, see, the area of this false area is now decreased. It's now decreased. So by T, we can assess just quickly whether the stent has in right place or not. pedicular tamponade. Okay. In pedicular tamponade here, this is the aorta, this is the artery, okay, and this is the artery, and the pedicular thrombus is there. It is almost compressing the artery. Okay. Here it is a bipedal view. This is the LA, this is RA, and you can see the pedicular cavity is full of blood, and this is a fibrin strand. This fibrin strand is there, and you see the mid-papillary view, LV is almost collapsed. RV is compressed by the huge blood. There is a thrombus also. So just putting the T, we can assess the pedicular tamponade. Through effusion, we can assess also how much fluid is there, whether it is exudative or whether it is conjunctive. In the conjunctive fluid will be dark red, and there is a lung tissue. Okay. But in the exudative fluid, there will be some sign of the white dots. So by seeing that part, we can assess whether it is the exudative fluid or conjunctive fluid. And coming to unexplained hypoxemia, causes of or contributors to unexplained hypoxemia, it could be intrapulmonary shunting or low cardiac output or right to bed intracardiac shunting. So intrapulmonary shunting, what are the causes? Pulmonary edema, atelectasis, large pleural fluid collection, pulmonary embolism. T can help to differentiate normal lung tissue from the pleural fluid and atelectatic lung. Evaluation of the LA pressure to differentiate between the cardiogenic from the non-cardiogenic pulmonary edema is also very important. And if asymmetrical pulmonary edema in the chest X-ray, TE has to be done to rule out any pulmonary venous obstruction. Now, coming to the intracardiac shunt, sometimes we get patients with adult congenital heart disease, Okay, VSD after long VSD after at the age of 20 years, normally that time the patient has become, patient has that Hemodynamic syndrome because normally in the VSD there is a left to right shunt, but as age progresses, it causes a permanent increase in the PVR and then the shunt gets reversed. Now it is a right to left shunt. So by seeing the T, you can assess the flow of the shunt. So Hemodynamic syndrome, uncorrected right to left shunt up to top in the adult, a more common flow across the PO4 due to acutely raised cardiac pressure. Causes of acutely raised cardiac pressure could be raised intrathoracic pressure due to patient ventilator desynchrony, dynamic pulmonary hyperinflation or tension pneumothorax. It could be due to acute core pulmonary, ERDS or pulmonary embolism, or could be due to severe RV systolic dysfunction, inferior myocardial infarction or myocardial stenting following a cardiac surgery. Sometimes T helps us to identify the source of the systemic embolus. It could be thrombus or vegetation. The thrombus could be in the LA or LA appendage, particularly a very important point. We need to see the LA appendage to see the thrombus. Sometimes LV apex and ventricular aneurysm. Prosthetic valve, mitral valve or aortic valve, ESD or VSD closure devices. Sometimes device closure, they migrate and cause the embolus. Mechanical cardiac support like LVAD or ECMO. Vegetation, aortic valve or mitral valve, intracardiac wires, mechanical cardiac support, and there are other lots of thousands of these causes of the systemic embolus. But doing T, we can just pinpoint the source of the embolus. Failure to wean from the mechanical ventilation. Positive pressure ventilation and PEEP the reduce the LV afterload and augment the LV systolic function. To rule out LV systolic dysfunction or LV diastolic dysfunction or mitral MR or pedicular tamponade, atalaxis or pleural effusion, we need to do the T. Upcoming cardioversion. Suppose a patient with A for longer than 48 hours who are not anticoagulated should undergo TE to rule out a thrombus in the LA appendage before elective cardioversion to reduce the risk of systemic embolization. Because by TT, we sometimes miss the thrombus in the LA appendage. Thank you.
your lucid explanation of a complicated subject. We will miss you and we will now start a live demonstration from the OT. All right. How will you the live demonstration from Dr. Shukla? This is my card. And when are you there? Okay. And program of this live where you will see certain later
ওর সিস্টারটার নাম কি জানো?
we shall be starting in a minute or so. I'm sorry for the delay.
সিস্টারের নাম টেকনিশিয়ানটার নাম শিবু সিস্টারের নাম টেকনিশিয়ান নাম
পারমিতা দিয়ে শুনতে পাচ্ছ? পারমিতা দিয়ে শুনতে পাচ্ছ?
You are audible.
Can you hear me?
You are audible.
So this is our cardiac OT.
হ্যাঁ আমি হল থেকে একটা রেসিপ্রোকেশন চাইছি পারমিতা দি
This is our cardiothoracic OT on the second floor. We shall be shortly starting our lines.
পারমিতা দি can you hear me? Can you hear my voice?
Let me introduce Dr. Shubhendu Sarkar. In fact, it is a pleasure to introduce him. He has a long list of qualifications. So after doing his MBBS, Shubhendu has done his MD in anesthesia, in which he was a gold medalist of the Kolkata University. He has done his DNB, PDCC, FNB cardiac anesthesia, MNMS, PGD, fellowship in ECMO, consultant cardiac anesthesiologist and intensivist, senior consultant, Desun Hospital, cardiac anesthesia, Kolkata. A long list. Shubhendu, welcome. Can you hear me?
Yeah, hi Paramita di I can hear you. Can you hear me?
Can you hear me, Shubhendu?
Yes. Hear you. ওখান থেকে কমিউনিকেশন প্রবলেম হচ্ছে মানে ওরা আমার শুনতে পাচ্ছে না হলটা আমি শুনতে পাচ্ছি না আমারটা হলতে পাচ্ছে না আমি বারবার বলছি হ্যাঁ বল হ্যাঁ আমি শুনতে পাচ্ছি না 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 আমি পারমিতাদির ভয়েস আমি শুনতে পাচ্ছি কিন্তু আমার ভয়েস পারমিতাদি শুনতে পাচ্ছে না
Shubhendu, can you hear me?
Yes, I can hear you. তুমি আমাকে শুনতে পাচ্ছো? আমার ভয়েস যাচ্ছে তোমার কাছে?
এই প্রথম শুনতে পেলাম।
এবারে শোনা যাচ্ছে ক্লিয়ারলি?
হ্যাঁ। Okay, so you will continue from here?
না হ্যাঁ দুটো জিনিস শুধু আমার একটু জানা সেটা হচ্ছে যে আমার ভয়েসটা ক্লিয়ারলি শোনা যাচ্ছে কিনা
অডিয়েন্স প্লিজ স্পিক আপ
ওটি দেখতে পাচ্ছি
অডিয়েন্স ইয়েস স্যার বলেছে অডিয়েন্স
আচ্ছা ফাইন ঠিক আছে অডিয়েন্সকে এভাবে জাগিও না শুধু শুধু বেচারি রেস্ট নিচ্ছে সবাই আর বলছিলাম যে দেখা যাচ্ছে তো পরিষ্কার ভিডিও ক্লিয়ার আসছে তো
হ্যাঁ
হ্যাঁ ফাইন আচ্ছা তাহলে we are starting right now 12:05 we have already wasted 5 minutes time তাহলে আমরা এক এক করে জিনিসগুলোকে সাজিয়েছি আমাদের জাস্ট একটু এজেন্ডাটা বলে দিই we'll first spare around 8 to 10 minutes not even 10 minutes maximum 5 to 8 minutes for describing the basics of the transducer component কারণ probably I have seen couple of junior people who are sitting over there যারা ইন্টেনসিভ কেয়ারে কাজ করে বা ওটিতে কাজ করে তাদের জন্য এই জিনিসটা খুব দরকার যে at least for setup of every type of monitor what are the basic things needed this is number 1 number 2 is we'll demonstrate the radial arterial cannulation I hope I'll be and then we'll induce our patient and we'll go for a femoral arterial cannulation then followed by central venous catheterization pulmonary artery catheterization we'll show you the PCO combo also and then we'll go to the flow track and lastly the Pico technology followed by a bit of views of the transesophageal echo. So we will definitely go one after another. আমাদের probably 1.5 ঘন্টা 1 ঘন্টা 40 মিনিটের মধ্যে সবগুলো হয়ে যাওয়া উচিত যদি সব আনইভেন্টফুল থাকে একটা শুধু সমস্যা পিকো টেকনোলজি আমাদের পিকোর কিছু জিনিসপত্র অন দা ওয়ে ওই জন্য পিকোটাকে লাস্টে রেখেছি তো আর কোশ্চেন্স প্রচুর থাকবে প্রত্যেককে রিকোয়েস্ট করব সেগুলো নোট ডাউন করতে যখন প্রসিডিউর চলবে ডেফিনেটলি ইউ ক্যান আস্ক মি কোশ্চেন কোনো অসুবিধা নেই আমি উত্তর দিতে থাকবো যেগুলো থাকছে বা এগুলো পারছি না দিস আর দ্য থিংস টু বি আনসার ইন দ্য ওয়ার্ক স্টেশন তাহলে উইদাউট এনি ফার্দার ডিলে রঞ্জন জাস্ট আমাদের আইটি থেকে রঞ্জন আছে রঞ্জনের হাতে মেন ক্যামেরাটা জাস্ট ফোকাস দিস এরিয়া রাইট ওকে So we'll start with the transducer demonstration. for any pressure monitoring, it can be a whatever pressure monitoring, it can be even a CSF pressure monitoring, we need basically the three components. One is, Ranjan, amar hattake follow koro. One is the flush system, which contains the heparinized flush. এবং দেখতে পাচ্ছ যে এখানে we are keeping the pressure something around 250. This pressure is actually needed. This is the flush system. This is called the transducer system. And ultimately, the transducer system is being connected in the backward level. That is called the coupling system. তাহলে ultimately জিনিসটা কি হয়, whenever we are putting this catheter, we connecting this line to any arterial line or a central venous or a pulmonary artery catheter, it actually reflects the pressure resonance to this transducer system. So once this transducer system is been there, it is been coupled to give a rise of a electronic signal, and that you actually see in the monitor in the form of the waveform and from a digital configuration. So this, for any dam pressure monitoring system, this integration is extremely important. You need a solid flush system, you need a proper transducer system, and you need a coupling system that is actually coupled and connected with the monitor. For any monitoring, this is the standard. This is where we selected the patient. The patient what you are going to see, Mr. Abdul Samad, is a 59 years old male patient. Mr. Abdul has an ejection fraction something around 30%. It was around 33%. With the anti-cellular management, it's 30%. He is being posted today for the coronary artery bypass surgery. Will demonstrate all the monitoring things on him. We took a valid consent, obviously, from Mr. Abdul Samad before proceeding. These are the all basic norms and other. So now, coming back to the transducer system, here actually in a protocol, I usually put the radial and the femoral arterial both for all the patients. So here you can see our technician has very nicely pointed out, this is a radial arterial line. This line is going to come connected with the radial cannula, and this is going to connect with the femoral one. So this is the entire arterial mount system. And for the juniors and others, even if you are being a bit confused, even the labels and other things are not there, at least by this color coding, these are the all universal color coding. This red for the artery. Ranjan, এখানে একটু focus করা যাবে কিনা দেখো. This is for the blue for the venous connections. Even by the seeing the color, you can easily identify which tubings or which coupling system is actually connected to the which side. So this is more or less over, and rest of the questions regarding this transducer, how to flush, how to connect and others, we need to answer in the work session. Another small thing before I leave, because it's already 5 minutes over. Hello.
নীলাদ্রি সাউন্ড বন্ধ করো।
Okay. Now, রঞ্জন, আমি তোমাকে বলবো তুমি মনিটরটা ফোকাস করো, আমাদের স্লেভ মনিটরটা একটু ফোকাস করো ওখানে। রাইট, একটু কাছে নিয়ে যাও স্লেভ মনিটরে। রাইট, এখানে দেখো আমি আর্টেরিয়াল লাইনটাকে শেপ করছি। ইউ ক্যান সি দ্য থিং চেঞ্জিং, ইউ ক্যান সি ইটস চেঞ্জিং। আই থিঙ্ক এভরিবডি ক্যান অ্যাপ্রিশিয়েট। পারমিতাদি একটু রেসিপ্রোকেশন হলে ভালো হয়, যে মানে আমার কথাটা শুনতে পাচ্ছে কিনা, বা অ্যাটলিস্ট তুমি যদি একটু কমিউনিকেট করে দাও।
Yes, we can hear you at times.
Everybody appreciate it. Yeah.
We can hear you, but at times.
Okay, fine. And please, this vibration in the screen that actually shows. Hello.
Yeah.
Yeah. ফাইন। বলছিলাম যে যেটা দেখাচ্ছি সেটা দেখা যাচ্ছে তো, তাহলেই হলো আর কি।
হ্যাঁ, দেখা যাচ্ছে।
বাস, ঠিক আছে। ওকে, সো নাও ফর অল দ্য ডেলিগেটস হু আর ওয়াচিং, এই যে ভাইব্রেশনটা আপনারা দেখতে পাচ্ছেন, this actually shows and proves the integrity of the system. So the entire your transducer, flux system and the coupling system is actually in one go. It's properly zeroed, and it's all properly, all the things and other noises and other things is properly buffered out. So now this line is actually ready to connect with any of the devices. It can be an artery, CVP, pulmonary artery pressure, CSF. What are the things we want to monitor in your OT as well as your intensive care area? So my first portion is done. We'll go to the next phase, that is the radial arterial cannulations. Right. Ranjan, এদিকে চলে এসো। We'll put the radial artery on cannula on the left side. And obviously we all know that before putting an radial arterial line, you need to go for an Allen's test and evaluation that has already been done for both the hands. And once it is done, we selected that this patient is a fit candidate for a radial arterial cannulation. So never jump on putting a radial arterial line until and unless you do an Allen's test. So I am asking Mr. Samad, সন্দবাবু হাতটাকে একদম ঢিলে ছেড়ে দিন, ঠিক আছে? ওকে, আপনি আমার থেকে বিখ্যাত হয়ে গেলেন, সারা ভারতবর্ষ দেখছি আপনাকে। বেশ, হাতটাকে একদম রিল্যাক্স রাখুন, ঠিক আছে? না এখানে, হ্যাঁ, রাইট, ওকে। সো initially we'll start with the aseptic procedures and others.
Ranjan, you need to focus. It's coming a bit dark. আলো, আরো আলো লাগবে।
আলোটা এই আলোটা অফ করে দিয়ে একবার দেখো তো, ওটি লাইটটা যদি অফ করা যায়, সরিয়ে দে। অটোমেটিক্যালি এখন ভিজিবিলিটি বেটার, ফাইন। ওটা অনেক সময় ক্রস রিফ্লেকশন হয় আর কি, ওই জন্য। ঠিক আছে, রাইট। রঞ্জন, আমরা এই জায়গাটাকে ফোকাস করব, ঠিক আছে? রাইট, বেশ। So we are already prepared. We'll start with the painting procedures and others. Painting. ঠিক আছেন? কমফোর্টেবল? এবার ভালো, এবার ঠিক আছেন তো? বেশ বেশ, ঠিক আছে। Okay, we'll give a bit of local anesthesia. হাসি হচ্ছে কেন? একটু একটু হাতটা বড্ড নড়ছে, এত কাশবে না। ব্যাস হয়ে গেছে। So now this area is ready for radial artery cannulation. So we already positioned the hand. Okay. So Ranjan, তুমি আমার হাতটাকে যদি একটু ফোকাস করতে পারো। We all know this radial artery cannula, এটা নিয়ে আলাদা করে বলার কিছু নেই এবং অলমোস্ট প্রত্যেকেই করেছেন এবং করছেন রেগুলারলি। তো আমার একটু লাইট হলে আসলে সুবিধা to puncture the radial arterial line. এটা কি? So we can thread it. এবার আমাদের দেখা যায় থ্রেডিংটা আসছে কিনা। So Ranjan, you can focus on the monitor also. Get a fresh one. ঠিক আছে। আসলে লাইটটা হয়ে রঞ্জন একটু এদিকে ফোকাস করো প্লিজ। দেখানো যাচ্ছে, জুম হচ্ছে? তাহলে আমরা এখান থেকে থ্রেডিংটা কমপ্লিট করছি। So we completed the radial artery cannulation. Just want to show the flow. এই জায়গাটা একটু জুম করতে হবে রঞ্জন যদি পসিবল হয়। You can see the radial artery line. Cannulation has been done. So
Okay, so
what I actually give a bit stress on ACT and
so
we'll
Shubhendu,
send the sample for
Shubhendu, you wanted to show the pulsatile flow, right?
Yes, obviously.
Okay.
This is a pulsatile flow, and obviously we need another 2-3 minutes time to complete this phase. আমার আরেকটা জিনিস একটু দেখানোর আছে, সেটা হচ্ছে যে the way I fix, this is a very important thing, what I particularly feel in an intensive care. If you want to maintain a proper radial arterial line in an intensive care, the most important thing is the way you fix it, right? So I'll ask for a dry gauge piece, and now we'll start fixing. You just follow. I'll request all the delegate just to follow the way I fix. It's a very simple way of fixation, but it's actually give a bit of stability. You can see it's very nicely put the radial arterial cannulations. So this is first stage fixation. And this is the final stage fixation. Okay, so now the first phase is over, that we put the radial artery cannulation has been done. The fixation has been done perfectly. We send the sample for the blood gas analysis because we usually put one room air arterial blood gas as a reference for post-operative management, and then we will fix it up. And then the next one is we will connect the entire system with the catheter. I will request our technician, Noyon, to aspirate the line and get it zero and to show the waveform in the monitor. রঞ্জন, তুমি এদিকটাতে চলে এসো, মানে ওখানে নয়নের কাছে থাকবো, মনিটরটা পরে দেখাবে যখন। নয়ন, প্লিজ অ্যাসপিরেট দ্য লাইন। Yeah, Noyon is aspirating. Noyon is smooth. Yeah. So it's a smooth. That's the most important thing. Until and unless the things are smooth, so don't jump around and don't give any pressure for putting any lines until and unless it's a smooth like anything. Okay. So you can see it's very nicely put. It's very nicely fixed also. And Ranjan, এবার তুমি মনিটরে ফোকাস করো। Now Noyan will do the zeroing another. আপনি একটু সরে আসুন সামান্য আমার দিকে। বেশ, ঠিক আছে। Fine. সোজা করে। Very good. Okay. So, পারমিতা দি শুনতে পাচ্ছ তো? Can you hear me?
হ্যাঁ।
Yeah. Hello. হ্যাঁ, আচ্ছা। এবারে we'll need a break of around 5 minutes because I want to induce the patient before I show you the next of the rest of the procedures. So now you can see the zeroing of the line. Now you've done the zero. Okay. So you can see it's a I must say it's a good radial arterial line because it's been able to show you almost all the notches and all the curves, because we all know for a radial arterial line, the most important thing is an anacrotic and the dicrotic notch. আমার আঙুলটা follow করছো তো, রঞ্জন? So you can see the dicrotic notches. And another thing, small thing I wanted to show to our delegates and other. আব্দুস বাবু, একটু কাশুন তো, জোরে কাশুন. You can see. Bas, ঠিক আছে, ঠিক আছে. So you can see with the curve procedure how actually the dynamics of the arterial line changes. এটা দেখানোর উদ্দেশ্যটা হচ্ছে, this is actually the nutshell of whenever we'll be able to discuss the pulse pressure variation and the stroke volume variation in an APCO algorithm in the flow track and the Pico technology. Okay, রঞ্জন, এখন আমরা কিছুক্ষণ একটু হোল্ডে রাখছি, ঠিক আছে? তুমি ওই মনিটরটাকে ফোকাস করতে পারো, আমরা ইন্ডিউস করে নিয়ে আমরা নেক্সটে যাব, রাইট? কোনটা আছে?
Ranjan, at times your focus is not proper.
প্রোট্রাক্টটা ওদিকে এক্সামিন করতে শুরু করছি, ঠিক আছে, ঠিক আছে, একটু স্টেবল হয়ে যায়, তাহলে আমাদের আরো তাড়াতাড়ি হয়ে যাবে ব্যাপারটা। হ্যাঁ 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 হ্যাঁ, রঞ্জন হাত ব্যথা হচ্ছে না তো?
We should thank Ranjan for letting us in.
ধরে রেখেছি তো,
Quite a tedious task for us.
হোল্ড কর না, তারপর আবার মেন প্রসিডিউর। Yeah, so we need at least 5 minutes time or something. Just focus on the monitor, that's it, till we go for the next procedure. We are absolutely in time, so I don't think we won't have much delay.
Shubhendu, you could show us induction and intubation as well?
If you want, I can.
Yeah, that would be good.
Okay. Yeah. Sure, why not? So
you have a CABG patient, right?
Yeah. It's a poor LV function around 30%. So we selected this patient for the workshop. The only thing is so that we can show you a bit more expected value for the invasive monitorings and other. Ankita, can you focus here? Ranjan, okay thing, you know? You can focus. আমাকে ফোকাস করো না, পেশেন্টকে ফোকাস করো, right? So the patient is induced already, so we are continuing with the control ventilation. চল একটু গাইড করবি। So it's from the very beginning, it's an anticipated difficult airway. You can see the neck is not that long and other. Patient is also having a bit of pulmonary problems with this. So as because we are using rocuronium bromide, so I usually don't ventilate the patient more than 1.5 minutes or so. So it's almost 1 minute over.
So, since you have a short neck, not only will that be a difficult intubation, your
Yeah.
lines will be also difficult, right?
Yeah. We need to get. Yes. So now ready? Yeah. So. So you can see that we need to give firm pressure for visualizing the trachea. So technician has to give a bit of pressure. So we have been able to see the trachea. So I negotiated the tube. And you also need to take care, as you all know, that we need to take care of the hemodynamics because we cannot allow a sudden rise or the sudden sympathetic overdrive. We simultaneously cannot use much of beta blocker in the patient because it's a poor LV function, it's a dilated heart. So there is some things that has to be neutralized. So we are fixing, this is the way I usually fix the tube. I usually don't use Dynaplast or anything because it actually creates some bad impressions and other can some skin feeling and other. And simultaneously, we are actually practicing from ultra short acting extubation and ultra fast tracking for all the patients, almost all definitely. So we don't want such a long level of fixation for.
Okay, Shubhendu, I would like to put in a question. What is fast tracking in cardiac anesthesia? How many hours? And what is ultra fast tracking in cardiac anesthesia? That is how many hours?
How many hours is actually fast tracking is anything in between 8 to 12 hours. And ultra fast tracking is, time is concerned, is within 6 hours. And obviously, we have some fixed up criteria. We cannot put all the patients for the fast tracking because the patients, depending upon the intraoperative sequences, what are the actually patients' background regarding the history is concerned. There are peripheral things, if there is any surgical bleeding or anything is there. So these are the all things that we need to take care whenever we decide this patient will go for fast tracking or the ultra fast tracking. So in general, like an ASD patient or single or the double grafting patients and other having the good ejection fraction, we can put. This patient is actually till now is behaving quite good. So I think we can put it in on the fast tracking, but obviously we can come to a conclusion after the entire procedure is over. So there are all different parameters, ABG parameters, intraoperative parameters, preoperative parameters, bleeding concern, patient hemodynamics, echo findings, everything is there just to put whether we can put this patient on the fast tracking or the ultra fast tracking. So you can, Roger, do we monitor the dekhate paro একবার? So the patient is been intubated and induced in a stable hemodynamics with everything. With an acceptable hemodynamics, saturations, and other things. You are seeing a bit of high rise of the end-tidal carbon dioxide because usually these short neck individual have a bit of hypoventilation that will get corrected within a few minutes. So it doesn't produce much of effect regarding the hemodynamics is concerned.
Dr.
So
Shubhendu?
Within 2 to 3 minutes, yeah.
I would like to know what did you use for induction of this patient? What agents do you use?
I use Etomidate.
Yeah, for those who right for those with low EF, Etomidate is a good option.
I use Etomidate, yeah.
Which we can practice in the intensive care as well.
I regarding the intubation in the critical care area is concerned, I am very much fond of using ketamine and simultaneously detomine on the patient's hemodynamics. Right. So we will. Okay. রঞ্জন এবার তুমি চলে এসো আমাদের নেক্সট ওয়ান উইল গো ফর আ ফিমোরাল আর্টেরিয়াল ক্যানুলেশনস আমি গ্লাভসটাকে অফ করছি যাতে একটু ল্যান্ডমার্কটা দেখাতে সুবিধা হয় as in a protocol we are putting the radial and the femoral arterial line both, so I am not doing anything extra for the patient for the workshop. তো আমি বাঁ দিকটা চয়েস করেছি তার একটা কারণ হচ্ছে আমি ডান দিকটা রেখেছি পিকো টেকনোলজি দেখানোর জন্য, কারণ পিকো আমাদের যে ক্যাথেটারটা সেটা পেডিয়াট্রিক থার্মিস্টার ক্যাথেটার, রাইট সাইডের ক্ষেত্রে আমার থার্মিস্টার অ্যানালিসিসটা একটু বেটার হয়। আচ্ছা, femoral arterial line, we can palpate the femoral artery very nicely here. So we'll start with the painting and draping, and then we'll go the Seldinger technique. We have 3-4 methods of putting an arterial cannulation, but here we'll go for a Seldinger technique for putting the femoral arterial cannulation. Okay, রঞ্জন তুমি এই জায়গাটাকেই ফোকাস করো, ওরা পেন্টিং ড্রেপিং কমপ্লিট হোক, তারপর আমি স্ক্রাব করে এসে আই ডু দ্য প্রসিডিউর, রাইট? ওকে। আচ্ছা পারমিতাদি, আমার কিন্তু এইবারে প্রসিডিউর গুলো করার জন্য একটু লাইট লাগবে, ঠিক আছে? আমি জানি না তোমাদের ওখানে কতটা রিফ্লেকশন হচ্ছে।
No, it's fine. We are happy with it. You can continue.
Okay, fine. Thank you. So now you start painting, right? Yeah. আমরা একটু টাইমটা সেভ করার জন্য আরেকটা জিনিস একটু দেখিয়ে দিই অঙ্কিতা সরে। রঞ্জন তুমি এই দিকটাতে একটু নিয়ে এসো তো আমার পেছনে। I actually simultaneously position the neck also. Okay. So you can see actually anybody can ask neck-এর অনেক রকম পজিশনই হয়, but I personally from my almost 19 years plus practice and other, I usually don't put a shoulder roll until and unless it's a 10 kg below baby and other. তো এক্ষেত্রে আমাদের পজিশনটা এরকমই থাকে, যদি খুব দরকার হয় তখন আমরা শোল্ডার রোল দেবো, আদারওয়াইজ নয়। নেক যে খুব বড় আছে না, আমি প্রথমেই বললাম it's almost, I should not say it's a short neck, but it's about to be a short neck. So this is the position of the neck. দেখিয়ে দিলাম এই কারণ আমার ওটা হতে হতে our technician Noyan will start also making a painting and draping in this area. তা নাহলে আমাদের সময়টা অনেকটাই লেগে যাবে। ওকে, তো So now draping is ready? Yeah, fine. Yeah. So the most important thing for any femoral arterial cannulation, it is my advice to all the intensivists who are practicing. See, we had a bit of controversy with the cardiologists regarding this femoral arterial cannulation is concerned, regarding the puncture site. We usually try to puncture in a place where we can have a strategic point. After removing the catheter, we can give a bit of pressure. So it's better to avoid directly puncturing on the inguinal ligament. This is not a very acceptable one practice, right? So you can see the area is very nicely draped. So let's hope for the best. This is I'm trying to palpate the femoral arterial line. So the right now the blood pressure is quite stable, 126. So it's a bit heavy individual. So this is more or less the femoral arterial line pulsation. So it's better to avoid the inguinal ligament. Follow করা যাচ্ছে তো রঞ্জন? Okay. So we try to puncture from a bit below. You can see the pulsation nicely. So I'm trying to thread the guide wire. Another important thing to all the delegates, until and unless your guide wire goes smooth like anything, don't force it to negotiate. This is one of the most important tricks for any invasive monitoring line. Don't force. Just put it as gently as possible. If it goes smooth like anything, you are actually in the space. So pressure, I'm taking this cannula with the feeder out. This is the arterial catheter for the adult. So I am threading. So you can see the tip of the guide wire is here. So there is no miss. This is one of the most very important step. And another thing is, if you can negotiate the guide wire smooth like anything, if you can negotiate the entire procedure, puncture procedure, actually you no need to dilate. And my suggestion is, please don't dilate the artery during the cannulations. It creates a huge problem after the procedure, even after taking out the lines, right? So now the next one is try to fix it up. So this is the fixing up of a femoral arterial line. We are using monofilament because to avoid the infection. And you can see I am almost 2 fingers below the inguinal ligament. That actually helps in the post-operative phase whenever I'll advise to take this femoral arterial line out for our bedside staff to give a firm pressure on that. So I am fixing it up. Right. Now, can we have a 3-way with 10 centimeter extension? Because we are not going to connect it with the transducer. We'll connect it after the demonstration is over. So we'll ask for a 3 with 10 centimeter extension, and we'll gradually take this guide wire out. You can see one thing, a small stay, you can see the clot formation. Be very much careful about all these things. So never put an ASD and other thing unnecessary on that. Try to do the procedure as fast you can. So it should not produces any thrombosis and other things. And I usually allow a 2 or 3 ml blood to go out, so there should not be any residual thrombus or anything, okay? Okay. So you can see the arterial line is flushing. I want to flush it once again. Now this is fine. So I'll take a gauge piece and I'll ask any of our staff to fix the arterial line. You can see this is put in a very clean cut way. There should not be any unnecessary hematoma, hassle-free. So whenever you will put in an intensive care in an OT, your arterial line placement should be exactly like this. So there should not be now our staff Patrika is fixing up the arterial catheter. Now see how she fixes. This is the only thing I actually don't know. They know better than me. Yeah, fine. So now the femoral arterial cannulation is done. So our third phase is over. Monitor focus. ওটা পরে দেখিয়ে দেবো হয়ে যাওয়ার পরে তুই আমাকে এটা গ্লাভসটা দে
শেষ হয়ে গেল আমার আন্ডারে হ্যাঁ কিন্তু আমার আন্ডারে তো ওয়ার্ড থাকার কথা না ওয়ার্ডে পেশেন্ট কেন ভর্তি করছে ইন্টেনসিভ টেস্ট আমরা দেখিয়ে দিচ্ছি তো ওয়ার্ডে পেশেন্ট কেন ভর্তি করছে সেটা তো আমার দেখার কথা না ঠিক ঠিক সরি সরি এই রঞ্জন নিয়ে এসো ভুলে গেলাম সরি পারমিতারি এদিক থেকে দেখাতে পারবে আচ্ছা এদিক থেকে এসো তো আচ্ছা একদম চলে এসো সামনে চলে এসো এই জায়গাটাকে ফোকাস করো আচ্ছা সরি আমরা will now go to the central venous catheter and other and central venous catheter with pulmonary artery catheterization. Usually whenever we put the arterial pulmonary artery catheter, I usually put a central venous catheter triple lumen and simultaneously I usually put the swan gauge catheter. এখানে the first you can see this is the triangle and একটা নিডল হবে তাহলে রাইট ফার্স্টটা হলে বেটার পজিশনটা তো আমি আগেই দেখিয়েছি দিস ইজ দ্য অ্যাডামস অ্যাপল দিস ইজ দ্য ক্যারোটিড পালসেশন and from this laterally I am approaching we usually prefer the jugular cannulations so our so we'll ask for the guide wire. We are trying to threading the guide wire. You can see the guide wire is going smooth like anything. This is the most important. Zero karo. Okay, so we'll take this cannula out, puncture needle.
We'll put simultaneously the Swan-Ganj catheter also. I mean, Swan-Ganj catheter guide wire also. So usually if we go a bit parallelly, so we no need to go for that much of landmark. It's all your practice and other. You can have the thing and other. So you can see this is for the second guide wire I am pushing. So you can see we have now both the guide wire in place in the right internal jugular vein. One will be used for a central venous catheter, another used for an introflex, through which we will introduce the PA. Okay. So I am dilating. Another thing people can ask me regarding the knife use and other. রঞ্জন তুমি কি দেখাতে পারছো দিকটা আর হাতটা? See, যদি ঠিক মতো ভাবে করা যায় না, actually we need a knife and don't experiment. Just leave it. 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 Just make it a mainstream. Leave it. It's there. Did you just scale to 150? Yeah, main screen. Just leave it. Fine. So you can see the dilator has been done, given. So I usually don't use the knife because you can see a bit of fear of the heparinization, and simultaneously, if you can manipulate it nicely. So can you take this fear out? Yeah, thank you. Fine. You can see the central line will go smooth like anything. And honestly speaking, you should not have that much of the blood loss. I think this amount of blood loss is quite acceptable. Here with 10 centimeter extension. Can I have a PO with 10 centimeter extension, please? So our central venous catheterization is over. Now I have a bit of demonstrations, introflex sheath for a PA catheter. Can you put a 3-way over there? Okay, now you can see this is an introflex sheath. This is almost 9 frames, and through this, the pulmonary artery catheter will be given. You can see this is the dilators and others. So I have to use knife for make a small nick for putting this introflex done. রঞ্জন তুমি কি দেখতে পাচ্ছ, মানে দেখাতে যাচ্ছে আমার হাতের এদিকটা? ওকে ফাইন, যখন পারবে না প্লিজ আমাকে একটু বলো। So I made a very small nick, as small as possible. So we'll try to introduce introflex through this. যদি অসুবিধা হয় অনেক সময় আমাদের হয়তো একটু নিক বাড়াতে হতে পারে। Okay, so it's went very nicely. You can see the entire introflex sheet is in. I'm taking the entire thing out. Okay, so our entire introflex and the central venous catheter is in place properly. Now we need to flush and then need to fix it up. All right. So you can see the level of the venous pressure with these patients. Because it is a poor LV function, you are getting so much of the high venous pressure. You can see the venous pressure is pretty high because of the right ventricle. So introflex is flushed. So you can see the way I flush to completely dear. কালকেও কেবিলটা চেঞ্জ করছিল না না হ্যাঁ? So flushing is complete. Now I need to stitch it up and fix it up. Usually, this is the best way of fixation. I usually put the lines a bit high up. This is the clavicle. So many areas has been I picked up because it helps in post-operative neck movement for all the patients. So I'll advise to practice all the intensivist, all this. So let's fix the line. Keep the knot a bit more so that it will be easier for the people who are going to remove the line so that don't have any problem during cutting the stitches and others. So don't keep the stitches so small and other because, right. Right. Now you see how I fix the sheath over this. This is one of the important thing. It's better to fix it like this. So it lies. So no problem with the neck movements and other. Chanchal, how far? Ready, fine. Okay, excellent. Chanchal, can you check this? The arterial line is not coming. Suddenly it got vanished. Any problem is not getting zeroed and if you can change the cable a bit. Fine. So fixation is over. Now, Ranjan, come here. We will demonstrate the PA catheter nicely and also as a combo. Yeah. Yes, sir. Yeah, focus on my hand. So this is a Swan-Ganj catheter, right? This is Swan-Ganj catheter, and this is the simplest variety of the Swan-Ganj catheter. I will end of my presentation how the CCO combo, that is the of the Swan-Ganj catheter. Okay, so this Swan-Ganj catheter has a few components. One, the first component is it's called the flow direct catheter. Can you focus me to it? Yeah, it's called a flow directed catheter because it goes from the right atrium to the artery with the floating of the blood. And it has a balloon at the tip of the catheter. So once we float the balloon, the catheter actually floats in the blood. That's why it's called the flow directed catheter. The length of the catheter is around 110 centimeter. This is the simplest variety of the Swan-Ganj catheter, what I'm going to demonstrate. Come to my focus on my hand. Okay, now you can see this is the tip of the catheter. This is a syringe that can give you only 1.5 cc of air, not more than that. If you can give a traction, it won't be able to give much of air. So there is no question of the balloon rupture. So I attached it. Carefully just focus on my hand. I am inflating the balloon. Clearly. So I am releasing it. So my balloon is checked. The second checkpoint, I inflated the balloon and I locked it. Sorry. It kept like this. Once I remove the lock, it will automatically deflate. The basic idea for putting a Swan-Ganj catheter, because we want to go from the right atrium to the right ventricle, from the right ventricle to the pulmonary artery, and by inflating the balloon, we want to wedge or block the pulmonary artery. And once we successfully block it, it gives the pulmonary capillary wedge pressure or left atrial pressure or an indirect predictor of left ventricular end diastolic pressure. Provided this patient does this is the simplest variety that gives you a systole, diastole, and the mean PA pressure, and simultaneously it gives you the end diastolic pressure and the left atrial pressure or the wedge pressure. But on and over and above, whenever we want to increase the variety, we go to the advanced variety of the pulmonary catheter. We can have, this is the right ventricular entire RV cap study. We can do this with a thermodilution catheter, intermittent thermodilution, combo thermodilution, continuous. We have a combo variety of the pulmonary artery catheter. Comboটা আমি তোমাদের একবার দেখিয়ে দেবো, ঠিক আছে? আমরা কি ইউজ করি। So we have another 2 port. This yellow port will be connected to the transducer, and this one you can give any infusion you want to. So now I need to check the integrity of the catheter. So I connected the 3-way. Probably cable change করতে হবে না। যদি দেখ সুন্দর আসছিল কিন্তু suddenly এটা হলো আর কি। হ্যাঁ। Right. Air flush none. Right. So you can see I'm again flushing. খুব ভালো করে দেখো। You can see the catheter here. আমি এটাকে ফ্লাশ করছি, দেখো কোথা থেকে বের হচ্ছে। You can see. This is actually used for a proximal infusion. If you want to give any drugs and other things, you can give. And simultaneously, this is a distal one. So let's have a distal look for this. So the integrity has been checked. Right. Now I need to put the jacket or the sleeve, which is going to cover. শোনা যাচ্ছে না? পারমিতাদি শুনতে পাচ্ছ?
Yes sir, শোনা যাচ্ছে।
হ্যাঁ ঠিক আছে, ওকে ওকে ফাইন, ঠিক আছে, রাইট। So we are putting this sleeve. So now my PA catheter is ready for introduction. রঞ্জনকে আমি বলবো তুমি আমার অপারেটিং জায়গাটাতে ফোকাস করো আবার। Okay, so I will put the yellow to my technician. Now I will connect it with the transducer. Yeah. You got it? Right. It's okay. At least you can have an idea. Okay. So I'll ask Noyon to flush it. Flush the catheter. Noyon, flush it. Okay, flush. Now রঞ্জন তুমি একটু মনিটরে ফোকাস করো, তুমি একটা কাজ করো, তুমি আমার পেছনে চলে এসো, monitor focus করো. You can see the vibrations, so that means the catheter is entirely nicely connected and get ready for introduction, right? Okay. Now, Arjun, now we'll zero the catheter. Monitor focus করো. Zero. Okay. Online. Now the catheter is completely ready. Now you just focus here. এখান থেকে একটু ফোকাস করো. দেখতে পাচ্ছ তুমি? দেখানো যাচ্ছে এই জায়গাটা? Right? Okay. You can take this light off. Fine. দেখা যাচ্ছে বা পরিষ্কার? Okay. You can see 1 mark, 2 mark, 3 mark, 4 mark. Usually, the first these 2 marks we reaches to the right atrium, and we try to negotiate to the tricuspid valve to the right ventricle. And usually, whenever the catheter reaches this, is actually acts as a central venous catheter. তাহলে আমি এটা negotiate করলাম. We started negotiating. Obviously, it has a directions and other. So I'll stop here. I'll ask Arjun to focus on the monitor. এবার মনিটরটা খুব কেয়ারফুলি অবজার্ভ করো, প্রপারলি ফোকাস করো, ঠিক আছে? ওকে. So now I am inserting the balloon. Now I'll try. You can see the trace of the right atrium and another. It's confirmed. দেখা যাচ্ছে anyone ওখান থেকে বোঝা যাচ্ছে? Anyone from the hall? Hello.
Yes sir, দেখা যাচ্ছে.
Anyone from the হ্যাঁ প্লিজ একটু মাঝে মধ্যে কমিউনিকেট করবেন, না তো কিছু
ঠিক আছে
অসুবিধা হয়.
ওকে স্যার.
But one way. Okay, yeah. So inserted the balloon. Now I'll try to go from the right atrium to the right ventricle. You can see the change of the trace. দেখা যাচ্ছে trace চেঞ্জটা. So we are actually from the right atrium to right atrium to right ventricle. So how we will know the patient is catheter is in right ventricle? Because by seeing the diastolic pressure, you can see so much of the low diastolic pressure. We'll try to negotiate from the right ventricle to the pulmonary valve to the pulmonary artery. So we are trying to go. You can see the ectopic. It's actually coiling to the RV because of the high RV pressure. You can see the change of the trace. I cross the pulmonary valve. You see there is a sudden rise of the diastolic blood pressure. If you follow the yellow one, the sudden rise of the diastolic blood pressure means you are actually in the pulmonary artery. You can see the rise of the diastolic blood pressure, right? So now my balloon is already been inflated. So we will actually try to wedge. So if we can wedge it properly, our curve will again change. So we are actually going to the pulmonary artery. You can see the change of the trace. So that's why we actually block the pulmonary artery. So this is actually the pulmonary capillary wedge pressure. So you can see the 16 is almost pulmonary capillary wedge pressure, which is pretty high. That actually predicts this patient is having a bit of poor left ventricular function. So it's actually indirectly reciprocate the pulmonary capillary wedge pressure with the left atrial pressure with the left ventricular end diastolic pressure. Now I am deflating the balloon. You can see I have deflated the balloon. You can see again the change of the trace. So now my catheter is perfectly positioned in pulmonary artery, and right now these patients in under anesthesia in controlled ventilation, the pulmonary artery pressure is 26/12. That is a systole diastole with a mean PA pressure of 17. Ranjan, can you focus on my hand? Yeah. So now I am actually putting the sleeve on the pulmonary artery catheter. I am making it lock. Right. So it's lock. Right. So now I'm actually gradually taking the drippings off. So this is the amount of the blood loss we have for putting a central venous catheter and the pulmonary artery catheter. So now I'll fix it up. because these are the things I am showing you. Just catheter put korle to holo na. You also need to put how to secure it, how to fix it up, and how to maintain it. This is extremely important. So this is, so our technician will fix it up. You can see it's absolutely neat and clean, everything. No soiling, no hematoma, nothing. It's been nicely placed here. Yes. We will do a 3-point fixation. This is number 1. This is number 2. And we'll put something in. This is number 3. Right. Okay. So the final position comes with this. We'll disconnect the ventilation for fraction of seconds. We put the head ring like this. We'll reconnect the ventilation and we'll fix the pulmonary artery like this. Yeah, it's a self-fixation. So you can see the entire area, the central venous catheter with the pulmonary artery catheter is nicely placed. Okay, so we completed our 5th portion. We have another 3 portions left. We are absolutely in time. So exactly 1 hour 4 minutes we took. So we'll go to the next theater for a flow track demonstration for the NAPCO algorithm, right? Okay. কেবলটা একটু দেখুন, প্রবাবলি অসুবিধা হচ্ছে। রঞ্জন চলে এসো এওটিতে। এখানে থাক, এটা রেডি করো। Okay, so you can see right. Ranjan, can you focus on that? Okay, so we'll come to the APCO algorithm. This is APCO algorithm আমার ওয়ার্কস্টেশনে যখন আসবে আমি বুঝিয়ে বলবো। এখন একটু জাস্ট ওভারঅল ইমপ্রেশন নিয়ে রাখো। Here we have put, you can see, we have put 3 transducer. The first transducer, this is a flow track transducer. The next one, it is a femoral arterial line. Femoral arterial line has been connected, and this is with the central venous catheter. Okay, and now we have this radial arterial line. This radial arterial line is been connected with the flow track device. This is actually first patient for today. Okay, so now we have completed the entire connection. This is a Vigilio monitor. This transducer is actually used for using the APCO algorithm. The APCO algorithm we'll discuss in details in our workstation. একটা কথা শুধু মাথায় রাখবে that it's a very basic physiology that we know the stroke volume and the heart rate relationship. So whenever we want to get a cardiac output, the stroke volume and the heart rate, we have a direct proportional relationship. So whenever the APCO algorithm comes, APCO algorithm usually takes place the calculation of the stroke volume as well as in the cardiac output. The stroke volume variations and the pulse pressure variations is actually the crux of analyzing of the cardiac output in APCO algorithm. So whenever using this transducer, we actually connect it with an arterial line, instantly it gives the value of cardiac output, it gives the value of cardiac index, it gives stroke volume index, it gives stroke volume variations and the stroke volume. This stroke volume variation is one of the very important indicator for how the patient's volume status is. And simultaneously, you can see this patient, that's I want to show you now. Actually, from this point, the advanced monitoring comes. আমরা PA দেখলাম swan bed, simultaneously এখানে দেখো রঞ্জনকে আমি বলবো মনিটরটা ফিক্স করতে। মনিটর দেখো, now the blood pressure is 94/36, something like that. And 94/36, we cannot say this is a very good blood pressure and other. But simultaneously, if you focus on the monitor, you can see the stroke volume variation is 19. So we have a plenty of scope to these patients for giving volume, and simultaneously the patient's cardiac output is 5.3, which is pretty within normal limit. So we can easily say this is absolutely not an unstable patient. This is the reason actually the newer advances or the advanced monitoring is actually coming. This monitor, obviously, whenever a monitor calculates on the pulse pressure variations, if we have any abnormality in the pulse, like the patient is having an atrial fibrillation, the patient is having an intra-aortic balloon pump in place, usually this monitor doesn't work. And if we've been able to connect the monitor with a central venous catheter, we can keep the systemic vascular resistance also. ওটা কি করা যাবে? SVR টা করা যাচ্ছে না, ওই wave port monitor. So we can see the cardiac output, cardiac index, stroke volume variation, stroke volume, all these things in one go monitor. So you can see how the entire, again I am revising. Okay, Ajit এসেছে? We can see this is the femoral artery transducer. This is the central venous. This is the flow track transducer. Ranjan, এটাকে একটু focus করো. This is a specialized design transducer. You can see this is how the transducer look like. And here the connection. This connection is actually, if we want, we can put it to the monitor so that we can see the same arterial pressure in the monitor also. And this is the connections has been made from the both the sides. And this is the green to green connection. বোঝার কিছু নেই. It's all color coded. It is directly going to the monitor. Another thing, this monitor is having a red port. This red port is for the oximetry cable. Huh? Exactly. This red port, whenever it's connected, this optical cable will be able to monitor the systemic vascular resistance. So this monitor has a beauty of using basic physiology, number one. Number two, no need to touch the monitor, no need to do anything. And simultaneously, you need to understand this monitor will give you a continuous data. দেখো একটু আগে আমরা দেখাচ্ছিলাম যে পেশেন্টের stroke volume variation was 19. Now the stroke volume variation is 15. তার মানে হার্টটা কিন্তু আরো খালি হয়েছে, এবং খালি হয়েছে বলেই তুমি দেখো কার্ডিয়াক আউটপুট তখন ছিল 5.3, তারপর হলো 6, now the cardiac output is 5.9, because this monitor every 20-second interval it goes on updating the hemodynamic parameters. So that's why you can see now, focus on the monitor, Ranjan. I think this is the best live demonstration we are having. You can see the improvement of the blood pressure. Gradually the central venous pressure is coming down, so the heart is gradually getting empty. The heart is functionally actually improving. So this is the way we actually monitor. We have the basic parameters what we had in our health intensive care. Just by doing and utilizing the physiology, this is one of the second step advanced monitor. Now আমাকে একটু ফোকাস করো. Now we have another two things to show you. কারণ দুটোর এখন একটা 1:17, so I'll try to wind it up in half an hour by 1:45, তাতে কিছুটা আগেই হয়ে যাবে. So we have Pico technology, which is a bit complicated technology. আমাদের পিকোটা অ্যারেঞ্জ করতে একটু সময় লাগবে, যখন অ্যারেঞ্জ হবে আমরা দেখিয়ে দেব। তার আগে some basic views of the transesophageal echocardiography, এই দুটো দিয়ে আমরা শেষ করব। অনেক কিছু আছে, এটা একটা দুদিনের এক্সটেন্সিভ ওয়ার্কশপ, সবগুলো তো দেখানো সম্ভব নয়, so we have selected some of the basic. So we'll hold for 2 to 3 minutes, Ranjan. We'll go to that theater and we'll start with the TOE demonstration. Right. তুমি ততক্ষণে এটাকে একটু ভালো করে দেখিয়ে দাও আরেকবার। পিকো কোথায়? Yeah, every time. And okay, তুই পিকোটাতে কনসেন্ট্রেট কর, আমি এদিকটা রেডি করি। নয়ন কোথায়? রঞ্জন, Mouth guard, T probe. Mouth guard and TE probe. জাস্ট এখানটাতে ফোকাস কর, এই জায়গাটা, ঠিক আছে? Ajit, by the time I'll show them the T and others, I'll take maximum 8 to 10 minutes. You get everything ready. All the transducer connections, monitor connections and everything. Yeah. So I'll put the mouth guard here. So this is an adult transesophageal echocardiography probe. Probably we have a lecture on theory in the morning. First up, the live session. So we can see the basic movements. We'll try to negotiate as easily as possible.
40.
So the T probe in place. Ranjan, can you focus on the monitor, please?
(408258).
Okay. Ranjan, come here. So you can see our transesophageal echocardiographic probe is inside. We'll connect with the monitor. একটু তাড়াতাড়ি করতে হবে। রঞ্জন, তুমি এদিকটাতে চলে এসো, তুমি এই স্ক্রিনটাকে ফোকাস করবে, ঠিক আছে? নয়ন, তুই চঞ্চল এখন ওটাতে কনসেন্ট্রেট কর, এদিকে দরকার নেই। So by the time it comes, any question or anything from the audience sides and other, আমাদের টেবিলে তো আবার দেখা হবে, but still if you have any question you can ask by the time machine gets on. লাইভ ডেমনস্ট্রেশনে সবারই একটু বুঝতেই পারছে একটা অ্যাড্রিনালিন রাশ থাকে। রেকর্ড করে লেকচার দেওয়া লাইভের মধ্যে অনেকটা পার্থক্য থাকে। তো একটা তো অ্যাড্রিনালিন রাশ আছেই ওটির মধ্যে। But we are fortunate, we are absolutely on time. Okay. So you can see the monitor. Ranjan, এইভাবে নিয়ে এসো, তাহলে দেখা যাবে, রাইট, ঠিক আছে, বেটার দেখা যাচ্ছে। So you can see now this is actually the LV cavity. আমি আস্তে আস্তে so we are gradually trying to get the fourth chamber view first. This is the fourth chamber view. You can see it nicely. This is because can you ask anybody what is this? এটা কেউ বলতে পারবে যেটা আমি আঙুল দিয়ে দেখাচ্ছি? Can anybody tell what is this? Okay. So this is actually in a four-chamber view. This is the left atrium. This is the right atrium. This is the left ventricle. This is the right ventricle. We'll show কোনো আমরা complicated ব্যাপারে যাব না. We'll just only show you what are the basic things. যে একটা TOE দিলে তোমরা কি কি দেখতে পারো. Now I'll try to show you. If you can see, we can go to the five-chamber view. Here you will be able to see the aortic valve. So we'll try to show you the aortic valve. You can see the aortic valve. You can see the cuffs of the aortic valve. We are giving a bit of rotation. You can see the cuffs of the aortic valve. I'm trying to make it open a bit more. You can see this. This is the aortic valve. Okay. Right. So now you can easily say this is the mitral valve and this is the left ventricle. So mitral valve, I want to put a bit of color on this. You can just to show you whether there is any mitral regurgitation or anything. Nothing is there. The mitral valve is perfectly functioning. So this is the tricuspid valve. You can see this is a tricuspid valve. Okay. Now I'll try to go to the long axis. Okay. So I'm going to the long axis. Before long axis, I just want to show you the two-chamber view. This is a two-chamber view. This is an excellent view for assessing the mitral valve. Actually, the fourth-chamber view, mid-esophageal fourth-chamber view, mid-esophageal two-chamber view, mid-esophageal long axis view, and these are the deep transgastric view. These are the important view for a mitral valve analysis, because whenever you want to analysis a valve in the TOE is concerned, you need to go for a qualitative analysis as well as a quantitative analysis. So these are the different views where we can give. Suppose the pressure half time, mitral valve square, mitral valve pressure gradient, and simultaneously you need to go for the PISA, that is the proximal isovelocity surface area. These are the different parameters. We actually need to quantify the degree of the damage of the mitral valve, whether it is a replaceable mitral valve, whether it's a repairable mitral valve, or anything you need to do. Suppose couple of cases we found, particularly in a bad heart, where we found a mitral regurgitation is there. It's a functional mitral regurgitation, whether it is getting improved with the coronary bypass surgery, whether giving it an inotropic support, or you need to change anything. So these are the all important information. These are real-time parameters that can give you continuously. So we want to show you, this is the leaflet at the anterior and the posterior mitral leaflet. You can see it's coopting nicely. This is the chorditendony and the mitral valve apparatus. They are apposing nicely. So there is no leak, no restriction, no damage, nothing is there. Even the mitral valve is perfectly normal. If we want to progress a bit, we'll go to the Seagull view. That is, we'll go to the long axis view. You can see we'll go to the Seagull view. Now you can see why it's called Seagull. This is a left atrium with a mitral valve, with a left ventricle, with an aortic valve, with the left ventricular outflow tract. So these are the view that comes with this. You can see I am showing you the aortic valve here. Yeah. Now you can see the aortic valve nicely. Now this is the cast, two casts of the aortic valve. You can see this is the one cast, this is another cast. It's a right coronary cast, this is the non-coronary cast. And in the the five-chamber view, you can see both the three casts, there's the left coronary cast. So these are the three. If we want to give a color on this, you can see the aortic valve, there is no regurgitation, no restriction, no lesion, is nothing. So the aortic valve is perfectly functioning. Okay, so now from this view, we'll go to another important view that is actually important for our volume assessment. Whenever we'll go for the volume challenge in the intensive care, suppose we don't have the advanced monitors and other, whatever the things and others, we need to go for our details of analysis. So now, if I go actually lateral flexion of the TOE probe, I can show you, you can see this is the lateral flexion. And you can see if I increase the image a bit, you can see this is the superior vena cava, this is an inferior vena cava, this is an right atrium, this is an left atrium, and this is this is a right atrium, this is a left atrium, and this is your what you have seen the pulmonary artery catheter. You can see the pulmonary artery catheter, what I have put just some time before. You can see the catheter that is going through this. So now I want to show you one thing. Chanchal, একটু central venous PA saline push করতো. Just push a saline a bit. না এইটাতে okay, so just want to show you one thing. So we are giving a bit of normal saline to the central venous catheter, not to the PA catheter. Hopefully you can see the bubble. You can see the bubble? Yeah. This is one of the yes, thank you. This is one of the tests just to see, suppose we have an unroofed coronary sinus or we have an adverse communications with the left atrium following a surgery or before the surgery. We can easily detect it by a bubble test. Even before that, we can also do the bubble test just to show that whether there is any integrity in the procedure and the systems or not. So I think these are the mid-esophageal 4-chamber view, mid-esophageal 2-chamber view, mid-esophageal bicaval view, and simultaneously the long axis view and the 5-chamber view among the 20 standard view of the transesophageal echo. This is not possible to show you 20 views. It takes a huge amount of time. But as a beginner or as an intensivist, you must focus on these 4 view basically. And lastly, I want to try, because it's a big heart, I don't know whether I'll be able to, I'll try to show you a bit of the LV cavity. It's possible. I'm going to the LV cavity a bit. If I want to make a small rotation over this, I can show you. You can see this is the LV cavity. একটু হলো appreciate করা যাচ্ছে একটু হলো. Yes, you can see the LV cavity. This is the view from where we can actually calculate the M mode. We can calculate the segmental contractility of the all parts of the ventricle. You can see the papillary muscle. Okay, so I think this much from the transesophageal echocardiography, very basic understanding from the intensivist point of view is concerned. Okay, so our Pico is how far? Is ready. Okay, so our last demonstration for today is the Pico technology. This is one of the complicated ones. Battery ki শেষে আসছে? হ্যাঁ, হ্যাঁ, থার্মিস্টরটা দিয়ে দিই। আচ্ছা, আমার ওখান থেকে চার্জারটা নিয়ে আমার ইয়ে থেকে দিয়ে এখানে কানেক্ট করে দেবো। ওটার সাথে এটাকে কানেক্ট করতে উপায় নেই, পেডিয়াট্রিক। So we'll give the Pico technology. Ranjit, এখানে একটু ফোকাস করো, because our see, this is a mind ray monitor regarding this technology demonstration is concerned. Pico technology টেবিলে অনেকটা ডিটেইলস ডিসকাশন করব, জাস্ট এখানে সেটুকুই বলার, ইটস আ ট্রান্সপালমোনারি thermodilution. We will give a bit of cold saline injection to the right heart, and that saline will traverse from the RA to the RV to the PA to the LA to the LV to the systemic aorta, and ultimately the temperature change is being detected by a specialized arterial catheter. This arterial catheter having a thermistor tip inbuilt. So whenever this catheter see the temperature changes after the entire traverse, it gives a hail of a value. It gives this value. This is a specialized catheter. You can see this catheter, this blue catheter is a thermistor tipped catheter, and we'll connect it with this to the monitor, and this Pico monitor, this is with the main monitor, and this is the guide wire. We'll put the catheter, and once it is connected and the procedure is performed regarding the cold saline injection. Ranjan, তুমি এখানে ফোকাস করো। দেখতে পাচ্ছ, we can see একটু জুমে নিয়ে এসো, we can see the EVW or ELW, that is the extra lung water index, global industrial index. These are the exclusively new parameters, because Pico technology is the conglomeration of two simultaneously procedures, that is the pulse contour analysis and technology combined together to form the Pico technology, and that gives us the global endoscopic volume, extravascular lung water, pulse permeability index, intrathoracic blood volume. These are the all important parameters. এই প্যারামিটারস গুলো আমরা টেবিলে সময় পেলে একটু ডিসকাস করব কিভাবে কি হয়। এখন আমরা চেষ্টা করছি যতটা সম্ভব, ইটস আ কমপ্লিকেটেড প্রসিডিওর, ইউ নিড আ রিপিটেড প্র্যাকটিস এন্ড আদার্স। So to do, I'll put this catheter on the patient first, and after putting the catheter, we'll start connecting with this. So Ranjan, we need exactly 5 to 7 minutes break. ততক্ষণে এটাকে চার্জে বসিয়ে নাও। ওকে।
হারিয়ে বসে তাহলে ওই ল্যাপটপটা আনতে গেছিলাম, যেখানে রেখেছিলাম
বাড়ি গেলে দিতে হবে।
কেন বলছি
দিয়েছে
বল না, নিজে কিনেছি বলটা এইসব কেনার কি দরকার, ফালতু জিনিস।
Everybody okay with the presentation?
Yes, ma'am.
Happy?
Yes, ma'am.
Enjoying?
Yes, ma'am.
Not boring?
No, ma'am.
এখনো দুটো ট্রলি ব্যবস্থা করতে হবে, কাউন্সিলিং সুপারভাইজার সহ দুটো ট্রলি ব্যবস্থা করতে হবে, কাউন্সিলিং সুপারভাইজার সহ।
কি যেন নাম, এটার নামটা
কোথায় পাবো?
আচ্ছা, কালকে সন্ধ্যাবেলায় প্রত্যেকটা স্পিকার সবাই কোয়েশ্চেন দিয়েছে, ওকে? একটা পরীক্ষার পাতা দেবো, বেশ কয়েকটা পাতা। তো এখানে যা পড়াচ্ছে তার মধ্যেই আসবে, সেটা চেক করে তোমাদের নম্বর দেওয়া হবে তা না, কিন্তু একে অপরের সঙ্গে পাশের লোক পেপার চেক করবে, জাস্ট টু টেস্ট ইয়োরসেলফ। ঠিক আছে? কাউকে বলার দরকার নেই, কিছু বোঝার দরকার নেই, নিজে কতটা ভালো হলো সেটা নিজেই, ঠিক আছে? আর আর একটু আমাদের স্পিকারদের সম্বন্ধে যদি এই কন্ডাকশন ইত্যাদি এই ফিডব্যাকটা চাইছি, যাতে আমরা আরো ভালো করে নেক্সট টাইম করতে পারি। এটা কালকে লাস্ট সেশন। And when you drop your feedback, do not put your name, okay? But we want genuine feedback. Say suppose you did not like a certain thing, please specify. We are open to all sorts of criticism, but we want this because we need to improve ourselves.
দুটো ট্রলি প্লাস তিনটে ছেলে, একটা তো আছে, দুটো ট্রলি তো লাগবে, দুজনকে শোয়াবে।
ও পেশেন্ট একে একে ছাড়া হবে না,
না এখানে একটা ওখানে একটা দিতে
পাপিয়া দুটো পেশেন্ট ট্রলি নামাও, এরপরেই মানে লাঞ্চের পরে ইকো হবে, ইকো সেশনে পেশেন্ট ট্রলি নামাও, তোমার দুটো হাউসকিপিং লাগবে।
একজনকে তোলা যাবে না তো।
আচ্ছা, তাহলে ট্রলিগুলো নামাতে হবে, যার উপর পড়বে তাকে চাই। আচ্ছা, ভালো ভালো খাবার এসছে, খুব খিদে পেয়েছে। এখন কি দিয়ে দেবো? এখানে দিয়ে দেবো, জলও দেবো?
রঞ্জন অজ্ঞান হয়ে গেছে তো।
রঞ্জন আর পাচ্ছে না, বেচারা নিজের ওজন হচ্ছে 22 কিলো, ফোনের ওজন 1 কিলো, আর কি পারবে। আমরা খাবারগুলো দিই না, খেতে থাক না।
খেতে পারে এখানে, খেতে খেতে বল।
তোমরা আগে খাবার নেবে না আগে ওয়াশরুমে যাবে? আগে ওয়াশরুম, তাহলে লিস্টটা দেখে নিয়ে যাও। হ্যাঁ, কারণ ওটা সাধারণত পাওয়া যায় না, আমরা অনেক কষ্ট করে এলাম। সোনো স্ক্যানের মেশিন আনা হয়েছে, তো ভালো লাগবে। সোনো সাইড তোমরা ট্রায়াল করার জন্য গেলিও আছে, পাংচার করবে, এগুলো সবই আছে। তোমার পাংচার তুমি
ময়টা দিতে হবে তো? হ্যাঁ, রাইট, এখানে চলে এসো। সো for the last phase of the demonstration, we are absolutely in time.
রঞ্জন সাউন্ড ক্লিয়ার নেই, ভিডিও স্টপ।
So we need a blocker. A flush. Syringe. This Pico will take some time. That's why I kept it last. So we completed everything. Yeah. Next step. Fine. Okay, so I am connecting DC. For any monitor connection, one of the another important advice I want to give, that just don't try to twist or anything. It's all pin to pin. You can see there is a slot. Slot, and you can see there is a slot inside. So it's comes slot to slot. Yeah. And done. So the thermistor connection is already established in the monitor. This is step 1 done. Step 2. Fine. We have our champion technicians with us, so we won't have any problem for this. Yeah. So we made a connection with this. So one connection has been built up with the thermistor. Another connection has been with the center. So let's by this time I fix it up. Noyan, you have a switcher with us? Right. Yes. So it's 1:42. We have exactly another 10 minutes left. Yeah. 10 minute. Yeah. Okay, Chanchal, you are ready?
Hello.
30.
হ্যাঁ নিচে আছে হ্যাঁ দুটো থেকে হবে হ্যাঁ ওখানেই হবে আর কোনো জায়গায় ট্রান্সফার হবে
Tell me when you are ready. রঞ্জন, আমরা এবার হেড এন্ডে যাব। এবারে যা কিছু আছে হেড এন্ডে। Yes. A single curve is enough. Single, yeah. Yeah. Just start. Yes. Yeah, the block has been taken. Yes. Okay. So by the time we go to the final step, so our entire established our it can central monitor. Now, John, come here. Yeah, put it and cover the patient. Yeah. Now, see the things very carefully. This is the central venous catheter.
Ranjan, sound not clear. Ranjan. এখানে ওপেন আছে
Dr. Shubhendu, please stop. We cannot hear you.
Yes.
Shubhendu.
Yes.
We couldn't hear you for the last 3 minutes. Please, লিড কর ব্যাপারটা আরেকবার বল। একদম ট্রান্সমিশন আসেনি।
এবার ঠিক আছে?
এবার ঠিক আছে। লাস্ট 3 মিনিট হ্যাঁ, এবার ঠিক আছে।
Can you hear me now?
Yes, we can hear you.
আমি রিপিট করে দিচ্ছি। রঞ্জন, if you can focus, see, this is the venous catheter mount where we have attached the temperature probe, and now we don't have much of time. তাহলে আমাদের মনিটর নালিফাই হয়ে যাবে। Now we are injecting the cold saline. We are injecting the cold saline to the patients. You can see this is the injection of the cold saline to the patients. Ranjan, can you focus to the monitor? You can see there is a yellow bar. The injection fluid. You can see the curve. You can see the curve is rising up. Injection fluid. And my entire circuit has been totally prepared and demonstrated in the you should give inject that regular interval in proper speed, in proper durations, in a proper volume. So machine is actually asking for 15 ml, so we are giving 15 ml. So machine is showing an unstable patient in their calculations. Okay. So now we are giving the machine is showing, please wait. So the machine is not yet ready for the next injection. So please inject 15 ml. Ranjan focus korche machine take. So I am giving the second injection. The machine is sensing. So I gave the second 15 ml cold saline injection to the patient from the central venous catheter for performing the entire Pico analysis. This is one of the finest analysis I have ever seen. If you can do the Pico.
Very
Yeah. Okay. So we'll have to go for the next one, right? So we'll go to the, we'll skip one, we'll calculate. No problem. So this is the third injection. We'll bypass one because of the time crisis. Mohinda is also calling me, so probably he wants me to wind up. Anyway, we also need to work very hard for performing everything. So I'll go into the monitor itself. Okay. Now you can the value. If I just focus, Ranjan, if you can focus the monitor, okay. So you can see the total blood volume. It's showing the index, and simultaneously it will show you the rest of the value. Okay. Fine. Okay. We can stop it. You can see the cardiac index is 1.89. এটাকে একটু ফোকাস করা যাবে বেশি হ্যাঁ ঠিক আছে 5% focus, and simultaneously the 4.8 is the extra lung water index and global endoscopic volume is 597. We need to select technology ta bojalam or we need to wind up Paramita ji and connected. Okay, so you connected. Okay. So now the important thing is I just tried to show you the technology of Pico, how we do it. Because of the time constraint we have to, because till the 3 injections is being given properly and it is analyzed by the machine, it will don't allow you the next phase. But for every injection, it will continuously go on giving you the cardiac index, global endoscopic index, and the extra lung water index, which is one of the precious parameters for any intensive care unit critically ill individuals. So it's now exactly 150. So we are closing our demonstration. So we will on the table. So we'll discuss the rest of the things on table. So I need another exactly 2 minutes time before I sign off from the OT. We showed the transducer, we showed the radial arterial cannulations, femoral cannulations, Pico technology, APCO algorithm, central venous catheterization, pulmonary artery catheterization, and Francis Opegel echocardiography. And lastly, এবার পুরোটা বাংলায় কিরকম যা যা প্রশ্ন আছে সেগুলো তো টেবিলে ডিসকাশন হলো। আমি প্রত্যেকের সাথে একটু পরিচয় করিয়ে দিতে চাই। রূপালী প্লিজ এসো, টাইম ওয়েস্ট করো না, ডাকছি প্লিজ এসো। রূপাল আমাদের কার্ডিওথোরাসিক ওটির ইনচার্জ, অঙ্কিতা আমাদের সিনিয়র মেডিকেল পারফিউশনিস্ট, আত্রিকা নয়ন আমাদের সিনিয়র টেকনিশিয়ান, অজিত ফ্রম মাইন্ডরে, আর মনিটরের পেছনে চঞ্চল আছে, চঞ্চল আমার সাথে কাজ করে বড় তো টু এভরিবডি। থ্যাংক ইউ রঞ্জন এতক্ষণ ধরে রাখার জন্য। আমার মনে হয় আমরা সাকসেসফুলি লাইভ ডেমনস্ট্রেশনটা করতে পেরেছি, এবং বাকি প্রশ্ন আনসার গুলো আছে সেগুলো আমরা স্টেশনে যদি দেখা হয় আমাদের সাথে, আমরা নিশ্চয়ই সেগুলোর আনসার দিতে চেষ্টা করি। ভেরি অ্যান্ড থ্যাংকস ফর বিং উইথ আস। থ্যাংক ইউ ভেরি মাচ।
Dr. Shubhendu, can you hear me?
Yes.
Okay. Thank you, Dr. Shubhendu, for your entire presentation. Ajit Ajitke, thank you. Puro cardiac team ke thank you. It was an excellent presentation, and all our delegates are very happy to see this. Only মাঝখানে একটু কেটে গেছিল লিড করার সময়, তাছাড়া বোধহয় we were successful in thing. So thank you so much. We will proceed for lunch, and after lunch we will start with the eco session. The skill station will start after the lunch. Okay. Thank you so much. We break for lunch for 15 minutes. Lunch time 15 minutes.
Okay. Chalo.
अनम्यूट रख दी साउंड दे साउंड है कौन सा
Welcome to this session on hands-on of echocardiography. We discussed in the morning session that the main purpose of using echo in any patient in our clinical practice, it is basically has to be goal directed. That means whenever you are doing echocardiography, you have some question in your mind, try to get an answer. It's not like that you look at the cardiac contractility, you look at what is the diabetic diet. Without any clinical context, those information is not going to help. So there have to be kind of questions that we try to answer. Mostly when we talk about echocardiography, it is some shock, and we are trying to identify the cause of the shock or try to optimize the treatment of the patient from the perspective of shock. So this is called phase guided flow, which has a small square shaped footprint just to accommodate between the direction. Because ultrasound beams by its nature cannot pass through the bone, it cannot pass through the air. So whenever it's passing through tissue and coming in contact with the bone or air, there is significant change in acoustic impedance. And as a result, 100% of the radiation beams will be reflected or refracted, and nothing can pass. Artifact creates, and in bone there will be a black shell. So our target will be to put that probe in the intercostal space. Now compared to the other ultrasound probes and the assessment, here the pointer is towards the right side of the screen. On the other ultrasound probe you will find because of the scanning it is on the left side of the right side of the screen and left side of the ultrasound probe. Here there is a point you see that goes with the, and now by convention for echocardiography this pointer will remain towards the left shoulder of the patient except parasternal long axis view when the pointer will look towards the right shoulder of the patient. These are by convention. Okay. Even if you don't follow it, what you have to interpret that image every time. You have to read that, you have to assess that image. Once you go by convention, it will create a pattern in your brain. And ultrasound is basically reading a pattern. So you will need less time to pick up abnormalities. You can scan faster if you follow the protocol. There is no other advantage. Okay. So we'll start with apical. I already mentioned 4 view. Apical, parasternal is second, or half, that is axis. Position is parasternal is the left second or third intercostal. Subxiphoid, then below the sternum and suprasternal. Okay, suprasternal is mainly looking at the aorta and the pulmonary. So if there is this thrombus, you may be able to identify when the pulmonary artery is getting bifurcated. Or you may be able to look at the root of the aorta if there is a dissection. But regular practice does not have that much information. So we start with the apical view. Ideally, we should just start with the 15th intercostal space, which is just below and lateral to the nipple. But with certain movement of the probe, you have to get the best possible image. There are times, because of anatomical variation, you may not get the exact image at a certain time. So you have to keep on moving your probe so that you get the best possible image. So these windows or the points that I mentioned is the starting point from where you will start. It's not like you will get the image at that place. So we start with the apical pointed towards the left shoulder of the patient. Pointed left shoulder. Four chamber. Okay. So if you look at this chamber, this is the thickest muscle. Okay. Towards the left side. Huh? So this is the left ventricle. Okay. Our target is to keep the effects of the left ventricle at the same. That's our target. But I'm not getting best imaging. Now there is another chamber which is opening into the left ventricle. Right? So this will be and so the next chamber separated from the left ventricle by a septum will be right ventricle, and chamber that is opening into the right ventricle, right ventricle. So this will be implemented with the septum, right?
Now you go and see the image of
So suppose now I can look at the dimension. So as you mentioned, among the whole left ventricle and the left atrium in the long axis, this will be 2/3, this will be 1/3. Okay. Now this diameter will be again 1/3, equivalent to the long axis diameter of the left atrium, and this will be less than 1/3. This will be this ratio of left ventricle versus right ventricle will be less than 0.6. LV diameter is larger. Right ventricular diameter is smaller. The ratio is less than 0.6. Why it is important? If we start with a dilated LV, dilated LA, probably there is an underlying pathological heart. So we don't know that the compliance resistance ratio, the relation, the volume pressure relation, that is the compliance, probably that will not go as per our routine expectation. That we assume that if this is the pressure, this will be the volume. So when we are resuscitating this patient, we have to be very cautious, very judicious, and we need more intense follow-up. Rather than assume, if suppose for this patient, I know I can give him 1 liter of fluid, patient will not go into a volume valvular failure because the LV function is good, looks normal, muscle thickness looks normal, contractility is good, chamber size is normal. If it is a concentric LVH, the contractility is poor, probably I have to be more cautious. Okay? So,
whenever in any, if right and left ventricle are of equal dimension or rapidity, there is a whichever pre-existing insert, it's a new this is one of the
so you can see the septum, it is convex and towards the right side. So suppose in a situation you find that RV is dilated, septum is flattened, that means RV pressure is high. And as I already discussed, that RV is the only chamber that can get acute dilatation. If there is a pulmonary embolism, it can acutely dilate. Okay. Now what we'll do, we'll look at do some movement. We'll try to open up the left ventricular outflow tract. So this is left ventricular outflow. Okay. You see, this is called the fifth chamber. Now how can we confirm? We can confirm with the color. You can see the blue color going. Okay. So if this is the left ventricular outflow. Now if I want to see that what is the cardiac output of the patient, whether this patient is going to slow the volume, I can put a cursor. This is called velocity time integral. Technically, this is not perfect because ideally the cursor should be in the same line with the blood flow. Because all these measurements depend on the Doppler principle, and that says that to measure a flow, your cursor have to be in the as close as possible with the minimum inclination with the blood flow. If it is 90 degrees, then it will not. It have to be less than 20 to 30 degrees. So it will be less than 10 degrees. Then it will be accurate. So otherwise there will be an underestimation. Suppose here the cardiac output is 60 ml. If I measure, I will probably get 40 ml. Because my cursor is not in the same line with the blood. That's why I put the color, look at the flow and then put my cursor. Here what we do, this is the called velocity time integral. Here we are measuring and the volume of the blood is the area under the curve. Once I measure this area and multiply it with the diameter of the aorta, that will show you how to measure, then we will get the exact cardiac output. So suppose in this situation, this patient is in positive pressure, ventilation, I give more or even spontaneous breathing, I will give a passive leg raising. I find that the VTI, the area under the curve increase of the peak velocity. This point is called peak velocity. It is vertical. So peak velocity. So this is the peak velocity. Okay. So suppose after that I give the passive leg raising, the peak velocity increases by 15%. That means this patient is fluid responsive. You can increase his cardiac output if you give fluid. If it doesn't happen, you probably not fluid responsive. You have to go to the other modalities of hemodynamic optimization. Fluid probably will not. Same thing you can do by the tidal volume challenge. You can give 8 ml per kg of tidal volume, so that the increase in the intrathoracic pressure, so the venous return to the left heart will increase temporarily, and it is expected to increase the cardiac output. So in that situation, the evaluation has to be done by 30 seconds to 1.5 minutes. You cannot delay it much better, because after a certain time, eventually the venous return to the left heart will decrease. Right? Because the main venous return to the right atrium and right ventricle is decreased. Right atrium, right ventricle. So eventually it will decrease the venous return to the blood coming to the left ventricle will decrease. So the assessment has to be done by 30 seconds to 1.5 minutes. Okay? So we see the apical 4 chamber, apical 2 chamber. Another thing, important point you need to remember is that the heart is a 3-dimensional structure. Here we are looking at a 2-dimensional structure. So you have to confirm similar finding from another window. It's like that heart is here, you have to look from here, from here, from here, from here. You have to get a 3-dimensional image in your head. Here we can see only the lateral one and the septum. We don't know about the anterior and the posterior. There may be hypokinesia. So you have to look at the heart from the other angles also. So the next, along with the apical 4th chamber, what we can do, we can rotate the probe and try to get a, this is called apical 2 chamber. So left ventricle and left atrium. You can see the mitral. Okay. So this is the anterior valve, this is the posterior valve. So I know that all the 4 valves are moving normally. Done here. So next, as we discussed, we have to confirm our finding from another window. Next important is the parasternal window. Parasternal window, as we discussed, the pointer will be on the right shoulder of the patient. Second intercostal. Second or third intercostal. I am not getting anything because of the last. Again, you can look at the thick muscular structure. So this is the left ventricle. This is septum. This is inferior of the left ventricle. This chamber is opening into the left ventricle. So this is left atrium. Left ventricle is emptying into this space. This is the aorta, and this is the right ventricle. Right ventricle. Okay. This is interventricular septum. So here also I can see that the contractility is reasonably okay. So once I review the heart from multiple window, I'm sure that the contractility is good. Okay. Here what we can do, we can look for you can measure the ejection fraction. So suppose to do that, I have to put a M. And this measurement has to be vertical to the muscle and at the tip of the mitral valve. Okay. Now I have to filter M. This is the minimum, this is the systole, this is the diastole. Okay? This vertical distance, diastole, this vertical distance is systole. Okay? So you can check what is the fractional shortening of the myocardium. So if it is 30%, that is normal. Ejection fraction is double of the fractional shortening. There are other implications of that I'm not doing. From here you can see. You also can look at the whether the left ventricle is empty or not. How much? See the two endocardiums are nearly coming very close. So probably this patient still is empty in the chamber. If he is hypotension, urine is low, probably I will give him some more fluid. Okay? After that, putting the probe in the same position, I will rotate it. And the pointer from the right shoulder will go to the left shoulder. This is parasternal long axis, because you can see the atrium and ventricle both. And short axis, you can only see the ventricle. Okay. So now this is the parasternal short axis. Okay. Here we have to see the whole heart starting from the aortic root up to the apex. Okay. Then otherwise, suppose this area, this is at the level of the papillary muscle. So now this at this level contractility is good. That doesn't mean the apex is moving fine or base is moving fine. So we have to review the whole area. So we start from the upper and look at the base. So this is the aorta. You can appreciate that aortic valve from Mercedes Benz side. It's opening like this. Huh? And this is the right ventricle opening into the pulmonary artery. This is the pulmonary valve. Okay. So now what I am doing, suddenly my probe direction is toward the catheter, and now I am making it a little bit corner. Now this is the mitral valve. You can see the fish mouth opening and closing, right? Then I am going further caudal. This is called, head end is called cephaloid, root end is called caudal. I am going further down. Now this is at the level of the papillary muscle. Okay? I go further down, this is the apex. So now I can look at the whole heart and I can say that all the areas of the left ventricle is moving fine. Regarding the, this is the septum, inferior septum, inferior, inferior-lateral, anterolateral, anterior, anterior septum. So every area is supplied by specific artery. So if we get a hypokinesia, suppose I get hypokinesia here, I need to describe it, right? So that's why this division has been made. And you can see the septum is deviated towards the right ventricle, and right ventricle is crescentic. It's empty, crescentic. Fine? Okay. One thing I have not shown in the fourth chamber is the right ventricle. So for the right ventricle, fee wall, this is the fee wall of the right ventricle, which contributes minimum to the cardiac output, 15 to 20%. Main is by this movement, this annular movement. So RV pump like this. Okay, this. So this movement is most important to predict the cardiac RV systolic function. Okay, so this movement. So what I will do, I will put the bone, put the cursor at the root of the annulus. Okay. So this is called tricuspid annular plane systolic excursion. From this much measure. So this 2.3. Normal cutoff is 1.3, some literature 1.6. More than 1.6 is satisfactory. So the early contractility is good. this, from here up to here. This is the skull capsule. So this is apical, parasternal long axis, short axis. So next will be subsequent. Subsequent is helpful if the patient has an infexious lung or a pneumothorax. Probably you will not going to get any window from it. You may get something from the subsequent. Okay. The another difference is that here you are holding the probe like this. In subsequent, you have to hold the probe like this. Because the angulation from 45 degree will change to 10 to 15 degree from this. Okay. Heart is here, so our point of direction will be like this. You can see the contractility is good. This is liver, just below my probe. Okay, because you have the tissue, so ultrasound can pass very well. Next chamber is the right ventricle. Then this is the right atrium that's emptying into right ventricle. Next left ventricle, left atrium. Okay. Now if I rotate my probe like this, pointed towards the cephaloid direction, I will get the IVC. And this is the hepatic vein that is there. So I have to measure just distal to the hepatic vein. Why? Because this root, this is the intrathoracic part. This is intra-abdominal part. You are supposed to measure the intra-abdominal part of IVC, not intrathoracic. So you have to measure just distal to the opening of the hepatic vein. Here you can see, now for this patient, it is very difficult to comment just on the basis of IVC. There is only 1.5 centimeter reasonable collapsibility for spontaneously within the patient. It's difficult to comment. So just from IVC, I cannot make it. I have to incorporate all the information that I have gathered from my routine echo, and then have to take a clinical. Okay? Anything that I have mentioned I have not shown. So again, second or third intercostal space is pointed towards the left shoulder. So this is the mitral. I will start with the root. This is the aortic root. You can see the aortic valve. Not to this bedside. This is the right ventricle. This is the pulmonary trunk. This is the pulmonary valve. Okay. Now suppose, and now I am looking at the cephaloid direction. First will come the mitral valve. This is the mitral valve. See the fish mouth opening and closing? Huh? I go further caudal. This is the papillary view. Further go down. This is the apical. Okay. So let's start doing hands on. Target is to get a window. That's all. Divide prime, I don't know what it is. So let's do one right. Target is to get window. Apical 4 chamber, apical 2 chamber plus minus, parasternal short axis, long axis, subsequent. Okay. If you get a window, next step is much easier. Window is more difficult. You have to do that.
So you learn about the parasternal long axis, short axis, apical 4 chamber tube, and the subsequent tube. Subsequent tube is very useful for seeing the IVC, and you are not able to get a 4 chamber tube or any view, other views are important. Sometimes the subsequent tube shows the entire heart very nicely.
It's a little difficult for me.
But it suffices. So these 4 and 5 tubes which are there. There are a lot of other tubes that are doctor arranging. I mean, you can actually have a today workshop. But at least these tubes should be
Just one.
So I deliberately did not tell you the ejection fraction. But by seeing the overall mortality, you can assess whether the ejection fraction is high. You can also assess the qualitative ejection fraction of what I do. The EVS. Time and how secondary ejection fraction. For this patient,
Just keep it at that. Then once you keep turning the patient little bit towards this side, the heart will become more on the surface. In the lung shadow, this is disturbing us. It will go up. See at that. The parasternal, apical, 4 chamber, 2 chamber, 5 chamber. Okay.
So how is it done? usually the
One hand will be on the machine. So you can see clearly see the left atrium, left ventricle, LV of the artery. That's your turn. That's all. No.
Place the cursor here. You have to place the cursor just distant to the microphone.
There are some small movements that you have to do.
Now you place the
So it
cursor
gets the
just
discord.
distant to the
Always remember these points are the initial starting point. After that you have to place the
spine. Now you have to press the This is the parasympathetic cortex. Remember everybody? There you see the right ventricle and left ventricle.
It's a coaching. 15 feet a bit this side. Still open the coaching.
This will give you some idea, right?
Sir, 5 minutes.
So this will give you some idea. Before it gives you an idea, if the cursor is cut from top to bottom, it gives you an idea about the right ventricle, the interventricular septum, the leaky catheter. Okay? This I think is the microphone, the right ventricle. But here at the level of the microphone, this is the leaky catheter. So you can see these are the gastrin and this is the systole. So you can calculate the volume in gastrin as
Most important is the point. Start with the right position with the right direction. Okay, then you rotate it. Pointer from here to here. Initially you are looking at the root of the base of the gun. Now this is at the point of the. If you go further, you will get capillary. Further quarter, you get epithelial. Walk in the same fashion, you will get it. If your point of interest is the same. Always point of interest at the same purpose. There is a lot of things. Because angulation up to 15 times 15. You have to insinuate it in the subject. Injection. Shoulder. Pointer, different.
নিয়ে গেছে কিনা জিজ্ঞেস করি, যাই না সিস্টেম নিয়ে গেছে কিনা। সিস্টেমকে আনতে এসে তার জানি না।
আমরা দেখবেন এরকম দেখছেন সেখানে দেখতে ইউটিউবটা
Can you take a call from IBC? No, we cannot. I will not suggest you to measure. Just for the technical, if you take an elbow, like daily practice करना পুরো টিপটা আমি বুঝতে পারছি থেকে এটা তো ইজি করাটা ইজি septum is not moving, apical septum, lateral valve is not moving. You know this septum. কোন পেশেন্টে কতটা লাগবে কেউ জানে এগুলো করে ডিনার টাইমস হতো আমার জুনিয়র উইন্ডো পেলাম আমি পেলাম ডিনার টাইমস আমি উইন্ডো পেলাম না কার্ডিওলজিস্ট পেলাম সে আমার থেকে 10 মিনিট বেশি ওটা কোনো লিনিয়াম কিন্তু সবটা ইজি না ও উইন্ডো পেতে অসুবিধা হচ্ছে হ্যাঁ জানো তো আমি অনেক কিছু এক্সপার্ট ডিব্রিফ করছি সেটা এখানে পাচ্ছি নর্মালি মধ্যে এখানে পাচ্ছি ওগুলো কোনো অসুবিধা না পাওয়াকে আমরা কাজ করি ইমেজটা আনতে সবচেয়ে হেল্প করে ইজিলি ইন্টারপ্রিট করে এগুলো ভাবতে হবে কোন দিকে আছে কোন উইন্ডো এটা ভাবাটা চলে যাবে aortic disc. উপর দিয়ে ধরে শুরু করা, উপর দিয়ে ধরে পশ্চিম যে মেজারমেন্ট সব এখানে করতে হবে, অনলি প্রবলেম হলো অ্যাঙ্গুলেশন। আমি তো কার্সেট এখানে তো পাবো, এই অঙ্গলটা আমি হয়তো নিচে নাও পেতে পারি, এটা প্রবলেম হতে পারে, পেশেন্ট পেতে পারে সব জায়গায়। যখন তুমি মেজারমেন্ট করতে হবে ফ্লো রিলেটেড, আমরা মনে রাখতে হবে আপনার প্রিন্সিপালি ফ্লোয়ের সাথে যত কম ইনক্লিনেশন আমি থাকবো তত এক্সাক্ট মেজারমেন্ট, দ্যাট ইজ দ্য টার্গেট। আমি যদি ফ্লো এদিকে যাচ্ছে, আমি যদি 40 ডিগ্রিতে ফ্লো আশা নিই, তাহলে মেজারমেন্ট ঠিক আছে, ভেতরে আমাদের টার্গেট এক্সাক্ট মেজারমেন্টটা টার্গেট, সেটা আমাদের মনে রাখতে হবে। না সাবজিকল নিচ্ছে না, হাতটা তো এখানে আছে, এরকম করলে তলা দিয়ে চলে যাবে, দেখতেই পাবো না, আমাকে আমি একটা খাবার তলারই দেখতে পাবো। হ্যাঁ এই বিষয়টা এই মুভমেন্টগুলো নিয়ে যাবে, সেখানে যদি কতটা চলে যাবে। focal point is I'm that's for all ultrasound.
Hello everyone.
পাসওয়ার্ড শো করাবে না, পাসওয়ার্ডটা শো করাবে, শো করবে।
Already we are running behind time.
না না করি
এই জিনিসপত্রগুলো বার করতে হবে, ব্যাগে যে জিনিসপত্র আছে ওগুলো একটা ট্রলিতে খালি করতে হবে। বিকাশ আর্টেল লাইন ওগুলো একটা ট্রলিতে রাখ।
এখানে
কি হলো? হলো না? এদের তো দেওয়া দেবী এগুলো করি না,
গুগল ড্রাইভটা
ওগুলো ইয়েটা করে
ম্যাম ডাউনলোড করে
ডেস্কটপে।
হ্যাঁ না 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 ডাউনলোড করে না ম্যাম এটা লগ আউট করে একটা হচ্ছে এই তো হয়ে গেছে ম্যাম ভাই হ্যাঁ আমি লগ আউট করবো
ये की स्पीड ये सब की এইগুলো নেবে না ওইগুলো না কত টাকা লাগছে
We would like to call on stage Dr. Vinita. Dr. Vinita is the head of the department critical care Ruby Hospital, Anevar, and we would like to give a token of love from our department. Thank you. I have been actually torturing Sudipta from the morning and I haven't given him a token of love. So it would be very unfair to him since he's so good. Sudipta, please be on stage. Good, lovely having you around. Thank you so much.
এটা এখানে দেখা যাবে কিছু করার নেই এইটা নামছেন এটা নামছেন এইটা অ্যান্সার করে দিচ্ছে এই দুটোকে দেখা যাবে এইটা আর এইটা এই দুটো এখানে প্লে করতে হবে ভুলে রাখছি কাজের জিনিসটা এইরকম এত স্লো কেন কি এটা তো রেজিউম করি কি হচ্ছে এত 20 কেবি স্পিড
লাইভ বন্ধ করে দিচ্ছি
না দাঁড়ান স্পিড হচ্ছে দাঁড়ান হয়ে এই তো হয়ে গেছে ভেরি গুড
সেই জন্য
আমাকে দেখাচ্ছে আমার দেখার দরকার নেই ভিডিওটাকে বন্ধ করি ইমিনেন্ট পার্সেন্ট নয় এইখানে হচ্ছে কোথায় ডাউনলোড এই যে এইটা এইটি 3-5টা হ্যাঁ এটাকে কি তোমরা রেখেছো জানি না এটা থেকে চালিয়ে ম্যামকে জিজ্ঞেস করে নেবে কোনটা চালাবো চপ
ডেস্কটপে সব করে দিয়েছি
এটা ডিফারেন্সটা হচ্ছে যে স্টক
We break up now. Madam, time over. We break up now.
আর্টারিয়াল লাইন প্রথমে আর্টারিয়াল লাইন আর্টারিয়াল এখানটা
স্ক্রিন শেয়ার করতে হবে।
কি করতে হবে?
স্ক্রিন শেয়ার করে দেবে, স্ক্রিন শেয়ার করে দিন সব কথা। স্ক্রিন শেয়ার না করলে কিন্তু দেখতে হবে না। এখান থেকে এখানে অনলাইনে যারা আছে তারা কিন্তু
We are running behind schedule. Eastern Railway was online. You made us late. Come on. Thank you so much. Thank you.
আর পারছে না, ওদের ভুলে গেছে লাস্ট টাইম পেইনকিলার খেতে হবে। দিয়ে যাও।
Please be seated. We are running behind time. আমাদের তো থাকবে। I would like to call on. Are we seated? We next move on to the session of arterial line, the PA catheter, the CVP waves. Hello, silence please. Can I have some silence? Enjoyed? Liked it? So now I would like to call on stage Dr. Shoptoshi Bhattacharya. Our topic for the day, since we are a small group, we'll all do it together, is the arterial line, the venous cannulations, which will be either a CVP or a pulmonary artery catheter. So we have seen today, Dr. Sharkar has shown us the radial cannulation and the femoral cannulation. So what we have in store is very similar. We will discuss the above. Once again, just to keep in mind, can anybody tell me what are the waveforms that you see here? So right now, we see the systolic upstroke. This is the dichrotic notch. From here is the systolic part, and this is the diastolic part. So now we have a correlation of the ECG along with the arterial trace. Could anybody tell me which comes first, the arterial trace or the ECG? Right. The electrical conduction comes first, which is followed by the mechanical contraction of the heart. So what happens is, first the AV valve opens. This is the systolic upstroke. There is a peak systolic pressure, that is the systolic blood pressure. Along with that, the next comes the systole, right? Now what happens? Why do you have a dichrotic notch? Can somebody tell me? Right. So there is a systolic decline, and from that you have the AV valve which closes. As soon as the AV valve closes, there is the dichrotic notch. So from there on starts the diastole. To my right hand is the diastole, and to my left hand is the systole. So the diastolic runoff is here. So once you have a diagnosis that the diastolic pressure is less for a certain patient and you have a diaphoretic notch here, you would like to see the arterial waveform. Simply seeing a numeric which is a low diastolic blood pressure, go and zero your arterial line once again and look at the waveform of your arterial pressures. So now you see where the diastolic runoff comes and the area under the curve which would correspond to your diastolic blood pressure. So in septic shock, when you see that your diastolic pressure is less, you would like to have a look in this arterial waveforms. So what is the pulse pressure? How do we define pulse pressure? Right. So can somebody tell me what are the diseases where we have a wide pulse pressure? Yeah? I couldn't hear you? Right. And what happens in aortic stenosis? In aortic regurgitation, we have a wide pulse pressure, right? So when you look at the arterial line, it also tells you whether the patient has an AI. You would have an idea. All right. So what happens in AS? This is your cardiac output monitor. You connect the arterial line along to this and you know you can monitor your cardiac output. What is cardiac output? Stroke volume into heart rate. From the arterial line itself, you can go and calculate your stroke volume as well as your heart rate. So you can actually take out your cardiac output. So what would be the stroke volume in this patient? How does the machine calculate the stroke volume? The whole area under this curve is the stroke volume. Into the heart rate would give you the cardiac output. So after this, if we have a certain question regarding the distal pulse application, the more distal the pressure, the more the reading increases of the systolic blood pressure. I think Dr. Todi talked about it in the morning, right? So this is my aortic pressure. This is how an arterial line in the aorta would look like. Now this is the brachial artery. See, this is much more flatter. This is the brachial artery. Where is the notch? The radial artery will have a better diaphoretic notch. And the more distal you go, femoral, it will have even better but lower down diaphoretic notch. If you put artery pressure, like in neurosurgery, they do the dorsalis pedis artery, the arterial notch is even further down. But you can see this peak is going higher and higher as you go down. The more closer to the artery, the more flatter it will be. The more closer to the aorta, the bigger the vessel, the more flatter it is. The narrower the artery, the more peak comes. Right? So, usually neurosurgery OT will have a dorsalis pedis cannulation because the surgeon, they are a bit megalomaniac. They occupy the whole head end. So they don't give you anywhere near you can't stand. So you go to the leg end, they do the dorsalis pedis. So you walk into the OT and you see a special like this, you are very happy. But in the same patient will have an arterial cannulation to the aorta like this, which is flat and that doesn't look okay. But both of them are normal. The further you go away from the heart, the higher is your systolic pressure measurement. The narrower the artery, it is the same systolic pressure, but it looks like that, right? And the diaphoretic notch keeps on coming down. Okay, so what else can we see? Can you tell me, can I cannulate or you put can you put an arterial line in the carotid artery? Why not? I can't hear you. If I can put an arterial line in a radial artery or a ulnar artery or a brachial artery, why can't I put it in a carotid artery? It's an artery. And we have two carotid arteries. So I'll put in one. Any takers for the question? Okay. Today you have 10 minutes. बोलो ना बोलबे बोलबे ना okay today Dr. Shubhendra Sarkar has given you an idea of this transducer, right? So this is the back. What is the pressure he mentioned? So this is how you inflate, right? And there is a pressure here which tells you how much pressure this will go down. So when the rate is up, then you stop. So how much heparin would you give in this half a liter of normal saline? So if this is inflated to the proper pressure, how much ml of fluid does go in a minute? 0.5 ml. 0.5 ml per hour. Okay? So very small amount. So we would not cause a hemodilution due to this system. Okay. If I replace, this is a PM line, monitoring line. If I replace with a board of this one, which is a wider board, if I replace this one with this, what would happen? Or your 10 centimeter extension. If I connect to the arterial line, how would my pressure show? Right, damped. Right. So Dr. Saptoshi Bhattacharya will carry on damping and overdamping.
The damping. Anyone damping to this? No idea? বেসিক্যালি যে কোনো অসিলেটরি সিস্টেম যখন থাকে আমরা পেন্ডুলাম সবাই দেখেছি পেন্ডুলাম কি হয় যখন পেন্ডুলামটাকে আমরা নাড়িয়ে দিই পেন্ডুলামটা রেস্টিং পজিশন থেকে একটা নির্দিষ্ট পজিশনে যায় আবার সেটা ব্যাক করে ওটা কি ও আগে থেকে ফিরে না ফিরে ওখানে ফিরে আবার আরেক দিকে চলে যায় যদি কোনো আমরা ধরে নিই যে ওই জায়গাটা কোনো কিছু নেই কোনো ফ্রিকশন ফোর্স নেই বা কিছু নেই তাহলে পেন্ডুলাম চলতেই থাকে কিন্তু সেটা তো তোলে না একটা সময় পর ওটা একটা জায়গায় থেমে যায় এমন একটা ফোর্স আছে যেটা ওকে কাজ করছে যেটা ওকে আটকে দিচ্ছে যেমন এখানে এয়ারের ফ্রিকশনাল ফোর্স এই যে ফোর্সটাকে আটকে দিচ্ছে এইটা হলো ড্যাম্পিং ঠিক আছে এইখানে যখন আর্টেরিয়াল লাইন আমরা করছি আর্টেরিয়াল লাইনে কি হয় আর্টেরিয়াল লাইনে আমরা যে আর্টারির মধ্যে আমরা একটা ক্যানুলা ঢুকিয়েছি সেই ক্যানুলাটা দিয়ে ওইখান দিয়ে কি হচ্ছে একটা প্রেসার আছে যে প্রথমে কি করতে প্রথমে হলো আমরা যখন একটা এই জিনিসটাকে রেডি করলাম এই জিনিসটাকে রেডি করার পর এইটাকে আমরা যে প্রেসারটা মাপছি বেসিক্যালি প্রেসারটা হলো অ্যাটমসফেরিক প্রেসারের উপর কত প্রেসার আমরা আমাদের এইটা করার পর আমাদের ভিডিওগুলো দেখাই জিরোইং আমরা করলাম
পিএ ক্যাথেটার
কিভাবে করে
পিএ ক্যাথেটার
এইবারে আমরা যে আর্টারিয়াল মধ্যে আমরা একটা ক্যানুলা ঢোকালাম সেই ক্যানুলাটার সঙ্গে আমরা এই জিনিসটাকে লাগাবো এবার কি হচ্ছে ওই যে আর্টারির যে প্রেসারটা সেই প্রেসারটা এখান থেকে এসে আমার ট্রান্সডিউসারে ধাক্কা মারছে ট্রান্সডিউসারের একটা ডায়াফ্রাম থাকে ডায়াফ্রামটার মধ্যে এসে প্রেসারটা ধাক্কা মারে ডায়াফ্রামের সঙ্গে একটা কি থাকে স্প্রিং গজ থাকে সেই গজটার এবার যেই ও ধাক্কা মারছে স্প্রিং গজটার রেজিস্ট্যান্সে চেঞ্জ হয় রেজিস্ট্যান্সের চেঞ্জটাকে কি করছে ও একটা
দুটো পাশাপাশি দেখা যায়
তারপরে সেটা কাপলারের মাধ্যমে মনিটরে যাচ্ছে ওখানে মাইক্রো প্রসেসর থাকে সেটা কি করছে অ্যামপ্লিফিকেশন করছে অ্যানালিসিস করছে এবং ওয়েবটা দেখাচ্ছে এই অ্যানালিসিসটাকে কি বলে ফুরিয়ার অ্যানালিসিস চেক করে নিচ্ছে এবার ড্যাম্পিং এখানে যখন এই যে আমার এখানে যে প্রেসারটা এখানে দিয়ে আসছে এই প্রেসারটা আসার পথে কতগুলো জিনিস আছে যেগুলো ওই প্রেসারটাকে মানে যাতে মুভ করছে সেটা কি কি জিনিস আটকাতে পারে, এই যে সিস্টেমটা আছে, এই সিস্টেমটার মধ্যে এই টিউবিং থাকে, তারপর স্টপ পাম্প থাকে, এই জিনিসগুলোতে ও ধাক্কা পায় এবং ওই ওয়েটটা একটা নির্দিষ্ট ডিস্টেন্সে গিয়ে এবার যদি ওভার ড্যাম্পিং আর আন্ডার ড্যাম্পিং যদি সেই বাধাটা কম হয় তাহলে ওয়েটটা এরকম বড় বড় করে আসবে, সেটা হলো আন্ডার ড্যাম্পিং। আর যদি বাধাটা বেশি থাকে তাহলে ছোট আসবে, সেটা ওভার ড্যাম্পিং। ওভার ড্যাম্পিং তাহলে কি কি কারণে হতে পারে? যদি এখানে রেজিস্ট্যান্স বেশি থাকে, প্রেসারটা বেশি হতে যাচ্ছে, কি কি কারণে হতে পারে? যদি এটা খুব শক্ত, এমনি শক্ত থাকে আরো শক্ত, যদি কোনো ব্লাড ক্লট থাকে, যদি কিং থাকে, যদি এয়ার থাকে, তাহলে ওটা আটকে যাবে এবং ওইখানে কিন্তু এই যে প্রেসার ওঠা, যেটা প্রেসার ওঠা মানে যতটা ওঠা উচিত ছিল ততটা উঠবে না। সেটা কি কি থাকবে? যেমন নর্মালি একটা এরিয়া একটা নর্মালি আর্টেরিয়াল ওয়েভফর্মের যে ট্রেসিং থাকে সেটা কি থাকে? সিস্টোলিক আপস্ট্রোক, ডায়াস্টোলিক নজ, ডায়াস্টোলিক রানঅফ। এবার যদি ওভার ড্যাম্প হচ্ছে, ওভার ড্যাম্প মানে কি? ওইটার মধ্যে কোনো ক্লট কিনছে, তাহলে কি হবে? ওভার ড্যাম্প মানে চেপে দিচ্ছে, প্রেশারটা বেশি, তাহলে আমার এই জিনিসটা নিচে নেমে আসবে আর এইটাও উপরে চলে আসবে, মানে জিনিসটা এরকম একটা সাইন ওয়েভের মতো এরকম। এবার যদি আন্ডার ড্যাম্প হয়, আন্ডার ড্যাম্প কিসে কিসে হতে পারে? যদি আমরা এই জায়গায় এই যে পিএম লাইনটা দিচ্ছি এটা শক্ত, এই জায়গায় যদি আমরা একটা আইভিসির মতো পাতলা লাইন দিয়ে মানে কোনো কারণে রেজিস্ট্যান্স কম হয়ে যায়, সেই কারণে সেই সব জায়গায় পাতলা লাইনটা সেখানে আন্ডার ড্যাম্পিং। আন্ডার ড্যাম্পিং হলে কি হবে? এই যে সিস্টোলিক আপস্ট্রোকটা এইটা উপর দিকে উঠে যাবে, মানে ন্যারো হয়ে যাবে জিনিসটা। আর ডায়াস্টোলটা এখানে কিন্তু দুটোর মধ্যে কিন্তু আলটিমেটলি আমার কি হবে? এই যে যদি ওভার ড্যাম্পিংই হোক বা আন্ডার ড্যাম্পিংই হোক বা নর্মালি হোক, মিন আর্টেরিয়াল প্রেসার কিন্তু সবসময় সেম থাকবে। কিন্তু মিন আর্টেরিয়াল প্রেসারে কিন্তু কোনো চেঞ্জ হবে না, কিন্তু আমরা দেখবো এই ক্ষেত্রে সিস্টোলিকটাও নেমে যাচ্ছে, ডায়াস্টোলিকটা উঠে যাচ্ছে, আর এই ক্ষেত্রে তো এইটা হলো গিয়ে ড্যাম্পিং। আর আচ্ছা আরে আরেকটা জিনিস বলে দিই, এই যে এইখানে আমরা যে জিনিসগুলো আছে এখানে আমরা কি কি জানতে পারি? এটা যে আমরা তো যখন একটা ট্রেস দেখতে পাই আর্টেরিয়াল প্রেসারের ওয়েভফর্মে, এক নম্বর হলো আমার এটা সিস্টোলিক আপস্ট্রোক। এখানে আমার কি হচ্ছে? এখানে অ্যাওর্টিক ভালভটা খুলছে, খুললো, তারপরে এখানে আমরা সিস্টোলিক ব্লাড প্রেসার পেলাম, মানে এটা আমার পি, ঠিক আছে? এইখান থেকে নামছে, এইখানে এসে আমার অ্যাওর্টিক ভালভ, এইখান থেকে আমার ডায়াস্টোল শুরু হলো, ঠিক আছে? এইটা দ্বারা আমরা সিস্টোলিক ব্লাড প্রেসার জানতে পারছি। সিস্টোলিক ব্লাড প্রেসার কি ডিনোট করে? এমনি আফটারলোড। ডায়াস্টোলিক প্রেসার জানতে পারছি, ডায়াস্টোলিক প্রেসার কি ডিনোট করে? যেমন এসবিএস সিস্টেম মানে রেজিস্ট্যান্স কিরকম আছে, এসবিআর। এটা যদি ডায়াস্টোলিক প্রেসার যেরকম যে কারণগুলোতে আমার ভেসোডাইলেটেশন হয়, যেমন সেপ্টিক শক ইত্যাদি, এইগুলোতে আমার ডায়াস্টোলিক প্রেসারটা কম হয়। আফটারলোড যদি বাড়ে আমার সিস্টোলিক প্রেসার বেশি থাকে। আর সিস্টোলিক প্রেসার আর ডায়াস্টোলিক প্রেসারের ডিফারেন্সটা কি বলা হয়? পালস প্রেসার। পালস প্রেসারের উপর কি ডিপেন্ড করে? কার্ডিয়াক আউটপুট। তাহলে পালস প্রেসার যদি কম থাকে তাহলে কার্ডিয়াক আউটপুট কম হবে, পালস প্রেসার বেশি থাকলে কার্ডিয়াক আউটপুট বেশি হবে। এই জিনিসগুলো মোটামুটি আমরা জানতে পারি। আর এবার সেন্ট্রাল ভেনাস লাইন, সেন্ট্রাল লাইন আমরা সবাই করতে জানি। কোন কোন ভেনে আমরা মিনি করি? সাবক্লাভিয়াল ভেনে করা হয়, ইন্টারনাল জুগুলার ভেনে করা হয়, ফিমোরাল ভেনে করা হয়। এর মধ্যে আমরা প্রেফারেবল কোনটা? জুগুলার। কেন? হ্যাঁ, জেনারেলি আমরা অ্যানাটমিক ল্যান্ডমার্কস ভালো। যদি আমাদের কোনো আর্টারি পাংচার হয় বা ব্লিডিং হয়, হেমাটোমা হয়, আমরা কমপ্রেস করতে পারবো। ইনফেকশন রেট ফিমোরালের তুলনায় কম, সবথেকে কম হলো জেনারেলি সাবক্লাভিয়াল। সাবক্লাভিয়ালের দুটো সমস্যা, একটা হলো যে আমরা যদি ব্লিডিং হয় আমরা কমপ্রেস করতে পারবো না, যদি নিউমোথোরাক্স হওয়ার চান্সটা অনেক বেশি। সেন্ট্রাল ভেনাস লাইন আমরা কিভাবে করতে হয় আমরা তো দেখেছি ওই এর সময়। এবার সেন্ট্রাল ভেনাস লাইন যখন আমরা করলাম, সেন্ট্রাল আগে তো আমরা সেন্ট্রাল ভেনাস লাইন যে করতাম, সেন্ট্রাল ভেনাস প্রেসার দেখতাম, ওই দেখে আমরা ফ্লুইডটা দিতাম। এখন কি আর করা হয়? করা হয় না। তাহলে কেন করা হয় না? বেসিক্যালি যখন আমরা সেন্ট্রাল ভেনাস প্রেসার দেখি, একটা পেশেন্টের সেন্ট্রাল ভেনাস প্রেসারটা ওটা কি ডিনোট করে? বেসিক্যালি আমরা যখন ফ্লুইড দিতাম আগে, আমরা ভাবতাম যে সেন্ট্রাল ভেনাস প্রেসারটা দেখে আমরা কি, ওটা তো একটা সার্ভেইট মার্কার, ভলিউম স্ট্যাটাস। কোন ভলিউমটা আমরা মাপতে চাই? না, আমরা মাপতে চাই বেসিক্যালি এর ভেন্ট্রিকুলার এন্ডাস্টোলিক ভলিউম। এখান থেকে কত দূর? প্রথমে সেন্ট্রাল ভেন, রাইট অ্যাট্রিয়াম, রাইট ভেন্ট্রিকেল, পালমোনারি আর্টারি হয়ে ওইদিকে পালমোনারি ভেন হয়ে লেফট অ্যাট্রিয়াম, তারপরে গিয়ে আমরা লেফট ভেন্ট্রিকেল। তাহলে এই প্রত্যেকটা জিনিস যদি ঠিক থাকে তবে গিয়ে আমি জিনিসটা ঠিকঠাক পাবো। যদি হার্টের কমপ্লায়েন্স খারাপ থাকে, মাইট্রাল রিগার্জিটেশন থাকে, এদিকে ট্রাইকাসপিড রিগার্জিটেশন থাকে, কোনো কিছু হলেই আমরা কিন্তু ওটা পাবো না। কাজেই আমার সেন্ট্রাল ভেনাস প্রেসার দিয়ে আমরা ভলিউম অ্যাসেস করতে পারবো। তাহলে সেন্ট্রাল লাইন করার ইন্ডিকেশন কি কি? এক হলো জেনারেলি আমরা করি যদি কোনো পেশেন্টের শকে আছে, আমাদের বেসিক প্রেসার দিতে হবে, বা কোনো যে ড্রাগগুলো সেন্ট্রাল লাইনটা দেয় না, পেরেন্টাল নিউট্রিশন, অ্যামিওলার ইত্যাদি ড্রাগ দেওয়ার জন্য, বা কোনো পেশেন্টের যার অনেক দিন ধরে ভর্তি আছে, আমরা কোনো অ্যাক্সেস পাচ্ছি না, তার জন্য আমরা লাইন করি। প্রেসার দেখার ইন্ডিকেশন কি? প্রেসার দেখে আমরা কয়েকটা জিনিস বুঝতে পারি। যদি সেন্ট্রাল ভেনাস প্রেসারটা দেখে আমরা অ্যাসেস করতে পারবো না, কিন্তু সেন্ট্রাল ভেনাস প্রেসারের যে চেঞ্জেসটা সেইটা দেখে আমরা পেশেন্টটা ভলিউম রেসপন্সিভ কিনা, যদি হার্টটা নরমাল থাকে তাহলে আমরা অনেক সময় অ্যাসেস করা যায়। এবার সেন্ট্রাল ভেনাস প্রেসারের যে কার্ভটা থাকে সেটা কিরকম আছে আমরা সবাই জানি, যে যখনই আমরা ওটা লাগাবো একটা কার্ভ আসবে, যেটা এইরকম এসে এই দিয়ে আবার এই কটা ওয়েভ থাকে, এখানে দুটো ডিসেন্ট থাকে, তিনটে ওয়েভ থাকে। কি ওয়েভ থাকে? এটা এ ওয়েভ থাকে, একটা সি ওয়েভ থাকে, একটা ভি ওয়েভ থাকে, আর দুটো ডিসেন্ট থাকে, একটা এক্স ডিসেন্ট, একটা ওয়াই ডিসেন্ট। এবার এ ওয়েভটা কেন হয়? এট্রিয়াল কন্ট্রাকশনের। সি ওয়েভটা আর ভি ওয়েভটা ভেন্ট্রিকুলার ফিলিং, এই অ্যাট্রিয়াল ফিলিং। আচ্ছা, এই এক্স ডিসেন্ট রিল্যাক্সেশনের জন্য। আচ্ছা, এইবারে সেন্ট্রাল, তাহলে আমরা সেন্ট্রাল ভেনাস প্রেসার থেকে আমরা মোটামুটি এখন আমরা সেন্ট্রাল ভেনাস প্রেসার খুব একটা ইউজ করা হয় না। সিটিভিএস ওটিতে কিন্তু সেন্ট্রাল ভেনাস প্রেসারটা ইউজ করা হয়। ওখানে যে আমরা যে মানে ফ্লুইডটা দেওয়া হয় সেই ফ্লুইডের চেঞ্জেসটা দেখে সেটা লাগে। এবার চেঞ্জ হলেই কি সবসময় ফ্লুইড রেসপন্সিভ হবে? আমরা সকালে কি করেছি, ফ্যান স্টার্লিং কার্ভের যদি ফ্ল্যাট পার্টটায় থাকে তাহলে কিন্তু চেঞ্জ হলে ওখানে লাভ হবে। এরপরে আমাদের নেক্সট হলো পালমোনারি আর্টারি ক্যাথেটার।
আচ্ছা, সকালে আমরা স্প্যানগ্যান্স ক্যাথেটার দেখেছি, পড়েছি, ইন্ট্রোডাকশন দেখেছি, ইন্টারপ্রিটেশন দেখেছি। ওকে, সো আমরা একটা চেস্ট টেক্সটে দেখছি যেখানে উই আর চেকিং ওয়েদার দ্য পালমোনারি আর্টারি ক্যাথেটার ইজ ইন পজিশন। আমাকে ট্রেস করতে পারবে কিরকম? তো এইখান থেকে আমি তো শীট, এটা তো পালমোনারি আর্টারি ক্যাথেটারের শীট, শীটের মধ্যে দিয়ে গেছে পালমোনারি আর্টারি, এইখানে ঢুকলো রাইট এট্রিয়াম, রাইট ভেন্ট্রিকল, ট্রাভার্স করে কোথায় গেল? আচ্ছা, এটা কি পেশেন্ট? কেন বলছি? এতগুলো ওয়্যার আছে, এক্সটার্নাল ওয়্যার আছে। তাহলে এইখান থেকে গিয়ে এইখানে করে এইখানে পালমোনারি আর্টারিতে গেল, রাইট? এবার আমি কি করে জানবো যে কতটা ওয়েজ হলো? এটা ওয়েজে আছে, কি করে বুঝলে ওয়েজে নেই? ওকে, এবার আমরা আসি। তার মধ্যে কিছু আমরা তারতম্য খুঁজবো, যে ইন্ট্রোডিউসার শীট দেখলে, টিপ অফ শীট দেখতে পেলে, টিপ অফ শীট রাইট এট্রিয়ামে আছে, এটা দেখা খুব দরকার। এই শীট আর কি কাজে লাগে? ধরো আমি পালমোনারি, আমি ভাই সিএবিজি করাতে বসিনি, আমি নিজে কার্ডিয়াক অ্যানেস্থেটিস্ট, আমি এখন ইন্টেন্সিভ কেয়ার করি, আমার স্প্যানগ্যান্স দেওয়ার তো দরকার নেই। স্প্যানগ্যান্স ইজ আউট অফ রেপিউট নাও, রাইট? তাহলে আমি শীটটা আর কিসে ইউজ করতে পারি? দিস ইজ দ্য internal diameter of the PA sheet is the highest. যে কোনো ট্রমা পেশেন্ট বা লিভার ট্রান্সপ্লান্ট পেশেন্ট বা যেখানে ম্যাসিভ ট্রান্সফিউশন ইন আ ভেরি শর্ট টাইম লাগবে, এই শীত তোমাকে অনেক হেল্প করবে। ওকে, যেখানে টাইম কম আর ভলিউম বেশি রিপ্লেস করতে হবে, কারণ ইন্টারনাল ডায়ামিটার এর সবচেয়ে বেশি। ওকে, তাহলে এবার শীত অবধি এলাম, তারপরে কোথায় যাব? এটা কোথায়? পালমোনারি আর্টারি, এটা ক্যাথেটার, তো এটা আরভি, আরভি কি না? এটা আরএই। এইবার কোথায় গেল? রাইট, উত্তরগুলো পাচ্ছ? হ্যালো, স্ক্রিন স্ক্রিন স্ক্রিন। ওকে, তাহলে আমরা এইবার দেখছি যে এইবার পালমোনারি আর্টারি যেটা আমরা ক্যাথেটারটা ফ্লোট করেছি সেটা কত অবধি গেছে, রাইট? সুতরাং ওয়েন ইউ আর গিভিং মানে ক্যাথেটার পজিশন পোস্ট অপারেটিভলি চেক করা উচিত, অ্যান্ড উইদিন 48 hours ইউ শুড টেক আউট দ্য সোয়ানগ্যান্স ক্যাথেটার অ্যাজ ওয়েল। ধরো বের করতে গিয়ে তুমি দেখছো আমাদের এরকম হয়েছে কার্ডিয়াক সার্জারিতে যে তোমার টাক আসছে, তুমি বের করতে পারছো না, কি করবে? অনেক সময় পিএ রিপেয়ার করার সময় সার্জনরা ওটা বেঁধে ফেলে, তখন তোমাকে আবার বাইপাসে গিয়ে খুলে বের করতে হবে। সো বি ভেরি কেয়ারফুল যে ওটা নড়ানড়ি করে, আদারওয়াইজ কিন্তু অ্যান্ড হোয়াট হ্যাপেন্স ইফ ইউ লেট দ্য ওয়েজ করে তুমি ছেড়ে দিলে, ভুলে গেছো, নাও হোয়াট উইল হ্যাপেন টু দ্য পেশেন্ট? So you understand, you can also harm the patient by doing that. Okay, এবার কতক্ষণ ওয়েজ করতে পারি? আমি ওয়েজ করে কতক্ষণ রাখতে পারি? আমি তো এলএ প্রেশারটা মাপছি, বেসিক্যালি তো আমি এলএ প্রেশার মাপছি বলেই আমি সোয়ানগ্যান্স দিয়েছি, তাহলে আমি কতক্ষণ রাখতে পারি? এটা যাচ্ছে না। Not more than 30 seconds, which should wedge position you cannot leave more than 30 seconds. তুমি ছেড়ে দিয়ে আবার করো, কিন্তু at a time তুমি এরকম ছেড়ে দিতে পারবে না। ওকে, তো ওকে, এই চেস্ট এক্সরেতে একটা জিনিস খুব মজার ব্যাপার আছে, একটা আর্টিফ্যাক্ট দেখা যাচ্ছে। হ্যাঁ, এই আর্টিফ্যাক্টটা কি? আচ্ছা, আমাদের আবার ভালো ভালো খাবার এসছে, গরম গরম সিঙ্গারা, আমরা খেতে খেতে পড়বো, তার সঙ্গে গরম চাও আসছে যাতে ঘুম না পাই। আজকে খাবারটা ভালো ছিল, ডিফারেন্ট। ওকে, কালকে কিন্তু আমরা বাঙালি মাংস ভাত খাবো। ওকে, সো না না, ফুলকপিও আছে, যারা ভেজিটেরিয়ান তারাও ভালো ভালো খাবে। ওকে, এটা কি হতে পারে? দেখো, লাস্ট অবধি নিয়ে যাচ্ছি। ওকে, একটা সাইড দেখালাম, আর্টেরিয়াল ওয়েভফর্মটা দেখাবো। সো হোয়াট দ্য টেক হোম মেসেজ ইজ, সোয়ানগ্যান্স ক্যাথেটার is no longer preferred today, like the CVP is no longer preferred today. This আমরা measurement করি না, we use the triple lumen to give certain drugs, right? We often use triple lumen to give blood, but actually blood should be going in the peripheral line, right? And if you have to transfuse a lot of volume over a very short span of time, you can use certain other devices as we have shown. Okay, now we will go to a very interesting part. একটা আর্টেরিয়াল লাইন দেখালে অন্য, হ্যাঁ হ্যাঁ, কমন আর্টেরিয়াল লাইন। আচ্ছা, এই যে আমরা আজকে আর্টেরিয়াল লাইনটা পড়লাম, তার সঙ্গে কিছু ওয়েভ ফর্মের মজা পড়বো। হ্যাঁ, কি বলবো, এটাই তো দেখাবো। ওকে, সো আমরা আজকে পড়লাম যে যখন আমরা আর্টেরিয়াল লাইন দেখছি, ফার্স্টে ইসিজি দেখবো, তারপরে আমরা আর্টেরিয়াল লাইন ওয়েভ ফর্ম উইল ফলো। ওকে, নাও দিস ইজ আ corresponding ECG with a corresponding arterial line. What do we know about atrial fibrillation? Irregularly irregular. So when we see the ECG যেরকম তার সঙ্গে তারপরে আর্টেরিয়াল ট্রেস আসছে এবং দেখো দুটো ইসিজির ইকুয়ালিটি একেবারেই নেই, কোনোটার সঙ্গে কোনোটা ডিসিমিলার, প্রত্যেকটা ডিসিমিলার। আর্টেরিয়াল ওয়েভ ফর্মও ডিসিমিলার।
এইটা যেরকম বড় আছে এই জায়গাটা গিয়ে ছোট হয়ে গেছে, কেন?
ডায়াস্টলিক ফিলিং কম হয়েছে, সুতরাং সেটার জন্য আমার আউটপুটটাও সেভাবে কম হয়েছে। Now how much does the atria contribute to the cardiac output? 10 to 20%. So a patient in atrial fibrillation, the cardiac output will come down automatically by 10 to 20%. Okay? তার মানে এই যে ইরেগুলারিটিটা দেখলে তাতে বুঝলে যে কার্ডিয়াক আউটপুট কিছুটা হলেও কম হয়েছে। Okay. So why is this? This is a result of decreased filling time. Okay. Now we come to another dysrhythmia. This is called supraventricular tachycardia. এটা ইসিজিতে বোঝা যাচ্ছে, কিন্তু আর্টেরিয়াল ওয়েভ ফর্মটা দেখো বড় থেকে ছোট হতে 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 আরো ছোট হচ্ছে। সো সুপ্রাভেন্ট্রিকুলার ট্যাকিকার্ডিয়া এসভিটি আমরা খুব মানে অতটা অ্যালার্মড হই না যতটা ভিটিতে অ্যালার্মড হই, বাট ইফ ইউ লুক at what is happening to the cardiac output or the arterial line, you will make out that এটাকেও ট্রিট করা আমাদের খুব দরকার, right? Why this is not a ventricular tachycardia? Narrow complex. Why this is not an atrial fibrillation? Right. So SVT commonest cause ki? Okay, some of the causes of SVT. Okay, what is the commonest cause of sinus tachycardia? Pain, batha. Okay, all right. So what is the commonest cause of supraventricular tachycardia? Right. সুতরাং when we look at the monitor, when we are invasively monitoring the arterial line, we can correspond the ECG along with the arterial trace and have an idea of what the heart is up to. You might not always get a cardiac output monitor in your ICU. You will get it in a cardiac OT but not in your ICU. But looking at the arterial trace, you can make out a lot of things. Actually, the arterial trace will give you an idea of how much is the stroke volume. The area under the curve is very, very important. Okay, now you have a relatively stable rate for this SVT. The rate is not too high, but yet there is a decrease in cardiac output and you need to treat this patient, right? Okay, so this is a PVC. So you can all see this is a broad complex. So this is a ventricular. This is not atrial. And look at what happens to the arterial line which follows the PVC. So this is your ECG and the arterial the output that comes from it. So that is lower than the normal. Okay. So even if there is a PVC, that amount of blood that is ejected with that contraction is less. So the beat originates in the ventricle. We are sure there is no atrial kick or a preload, and there is a slower contraction. Okay. So what happens is a lower cardiac output. Okay. Now, why this is a bigeminy? নিচের ইসিজিটা দেখো, একটা ব্রড কমপ্লেক্স, সেটা তো ভেন্ট্রিকুলার সবাই বুঝতে পারছে। তার আগেরটা কি? ওটাতে তো পি ওয়েভ আছে। বাইজেমিনি কখন হয়? আমাকে মিস্টার নাগ খুব বড় বড় চোখ করছে, বলছে টাইম আপ, তাড়াতাড়ি বলতে হবে। আমি কিন্তু সিঙ্গারা খাইয়ে দিয়েছি, এবার চা দেবো, তাড়াতাড়ি বলো। ওকে, তাহলে বাইজেমিনিতে দেখছো যে হোয়াট ইজ দ্য ডিফারেন্স বিটুইন আ বাইজেমিনি এন্ড পালসাস অল্টারনেন্স? আচ্ছা, আমাদের খাবারটা না ডিসানেরই, সো নট অনলি দ্যাট উই টিচ ওয়েল, উই অলসো কুক ওয়েল। ওকে, তো না রোজ রোজ ভালো খাই না, মাঝে মাঝে খাই। তো আমি কখন এটাকে পালসাস অল্টারনেন্স বলবো, কখন বাইজেমিনি বলবো? গুড। এই যে মরফোলজি চেঞ্জ, সেটার মানে হচ্ছে কি? এই যে মরফোলজি বললে ইসিজি মাঝে মাঝে এট্রিয়াল হবে, মাঝে মাঝে ভেন্ট্রিকুলার হবে, রাইট? ওকে, সো দিজ আর দ্য চেঞ্জেস ইন দ্য বাইজেমিনি, রাইট? এবার পিএসি দেখো, এটাতে দেখো আউটপুটে কিন্তু খুব একটা চেঞ্জ হচ্ছে না। প্যারক্সিসমাল এট্রিয়াল কন্ট্রাকশন, আউটপুটে খুব একটা চেঞ্জ নেই। ওকে, আচ্ছা, অনেক ফুটবল খেলা চলছে, ভালো হচ্ছে, ক্রিকেট টিম ভালো। ইরেগুলার ডিউ টু প্রিম্যাচিওর বিট, ঠিক আছে, কিন্তু এটা মানে আমার আউটপুট খুব একটা প্রবলেম করছে না। So this has a good preload and a strong contraction. So still have atrial beat preceding QRS. ঠিক আছে? Okay. এই যে এইখানে আমাদের দেখা খুব দরকার যে পি ওয়েভটা আছে কিনা। যখন আমি দেখছি পি ওয়েভ আছে, এর আউটপুট এক, সেজন্য ইরেগুলার হলেও এটা আমার কার্ডিয়াক আউটপুটে প্রবলেম করছে না। Okay, what is this? এটা আমরা প্রায় পাই সেপটিক শকে ইত্যাদি। এটা কি জিনিস? পালস প্রেশার ভেরিয়েশন। এটাতে সেনসিটিভ টু ভলিউম, তো এটাতে আমরা ভলিউম দেব। আচ্ছা, এই ভেরিয়েশনটা আসে কেন? ইন্ট্রাথোরাসিক প্রেশার রেসপিরেটরি সাইকেলে যে চেঞ্জ হয় তার সঙ্গে আর্টেরিয়াল ওয়েভ ফর্মে তুমি চেঞ্জ পাবে, রাইট? তাহলে যখন আমাদের এই চেঞ্জটা আসছে তখন আমরা কি বলছি? এসভিভি বলছি। তার মানে কি বলছি? স্ট্রোক ভলিউম ভেরিয়েশন ও পালস প্রেশার ভেরিয়েশন। সো ইফ দিস ইজ মোর দ্যান 10, তাহলে কিন্তু আমরা একটা পালসাস প্যারাডক্সাস ভাবতে পারি। পালসাস প্যারাডক্সাসের কমনেস্ট কজ হচ্ছে ট্যাম্পোনার, পেরিকার্ডাইটিস, অ্যাজমা, সিওপিডি ইত্যাদি, এই পেশেন্টগুলো। সো দেখো, তার সঙ্গে তোমার যখন মনিটর দেখবে, নিচে রেসপিরেটরি ড্রাইভটা পাবে একই সঙ্গে। তুমি যেখানে আর্টেরিয়াল ওয়েভ ফর্ম দেখছো, দেখো নিচে রেসপিরেশন আছে, এবং সেটাও দেখবে, তখন ওটাও ভেরি করবে। স্পন্টেনিয়াস ব্রিদিং পেশেন্টের এরকম আসবে, ঠিক আছে, নিচেরটা ভেন্টিলেটেড পেশেন্ট। ক্লিয়ার? ভেরিয়েশনটা যেহেতু রেসপিরেশনের সঙ্গে, সেই জন্য যখন স্ট্রোক ভলিউম ভেরিয়েশন দেখবে, সেটা কোরিলেট করতে হবে রেসপিরেশনের সঙ্গে। ওকে, এইবার আমরা আরেকটা নতুন জায়গায় যাব, যেটা পালসাস অল্টারনেন্স, ঠিক আছে? অল্টারনেটিং লার্জার আর স্মলার, এটা বাইজেমিনির সঙ্গে ডিফারেন্সিয়েট করা দরকার আছে। ইসিজি ঠিক আছে? তাহলে পিভিসি নেই ইসিজিতে। রেজাল্ট এটা কেন হচ্ছে? পালসাস অল্টারনেন্স, এলভি ডিসফাংশন, এওরটিক স্টেনোসিস, হার্ট ফেলিয়ার, আর ডিপ অ্যানেস্থেসিয়া দিলে অনেক সময় হবে। একটা স্ট্রঙ্গার, একটা উইকার, রাইট? আচ্ছা, ডাবল সিস্টোলিক পি কিসে হয়? এটা একদম এয়ার। গুড। সিভিয়ার এওরটিক রিগার্গিটেশনে আর কি হবে? এইটাই যখন আমরা ফিমোরাল আর্টারিতে হাত দেবো, তখন এআইএ আমরা কি পাবো? রাইট। আর আরেকটা জায়গায় পালসাস ডিসফারেন্স পেতে পারি, সেটা হচ্ছে হাইপারট্রফি কার্ডিওমায়োপ্যাথি। এটা আমরা সবাই জানি, জাস্ট আমরা আরেকবার রিভাইজ করে নিচ্ছি। ওকে, ডায়াস্টলিক ব্লাড প্রেশারটা এআইএ কমে কেন? এআইএ এওরটিক ইনসাফিসিয়েন্সিতে তো ডায়াস্টলিক ব্লাড প্রেশার কমে কেন? এওরটিক ভ্যালভটা কি হচ্ছে, খুলে যাচ্ছে, তো প্রেশারটা তো নিতে পারছে না, তো ডায়াস্টল রান অফটা তো ওর কমে, উল্টো দিকে ব্লাড চলে আসছে, সেই জন্য ডায়াস্টলিক ব্লাড প্রেশার এআইএ কম দেখাবে। এওরটিক স্টেনোসিসে দেখো ডায়াক্রোটিক নচটাই পাবে না। তোমার কিরকম মনে হচ্ছে? এটা ড্যাম্পের মতো মনে হবে, কিন্তু এটা ড্যাম্প নয়, এটা এওরটিক স্টেনোসিসের। কেন? এওরটিক ভ্যালভ নট ফুললি ফাংশনিং, রেস্ট্রিক্টিভ ফ্লো। ঠিক আছে, নচ নেই। তাহলে এটা যে নচ নেই সেটা জানতে গেলে আমাকে আরেকবার জিরো করতে হবে এবং সেটা কোয়ান্টিফাই করতে হবে। ঠিক আছে, থ্যাংক ইউ সো মাচ। So I thank my colleague Dr. Saptarshi, without which we wouldn't have been able to do the conference today. Our boss Dr. Mohit Tharbanda has been a little unable to sit, so he wasn't around. We thank him, and with his blessings we have gone forward. So Team Critical Care, I thank Desun for giving us an opportunity to serve. Dr. Shubhendu Sharma.
Yes, da. Because da.
আচ্ছা, ডক্টর শুভেন্দু সরকারকে অল্প স্বল্প লোক দেখিয়েছি, বলেছি যে সিনারাটা গরম আছে, চলে এসো, ওটি চলছে। অ্যাকচুয়ালি আনফরচুনেটলি পেশেন্টকে অফ না করলে তো আসতে পারছে না, তো 5 মিনিট ব্রেক, টি ব্রেক, টিটা সার্ভ করো প্লিজ। অ্যাকচুয়ালি পেশেন্টটা আছে তো ছেড়ে আসছে। We will start now.
At the
আচ্ছা, কালকে we will start short by 9. Thank you for coming at 9 o'clock today. What is everybody else taking time? And today, tomorrow we will end with an MCQ quiz. Okay? Each one what we taught today, we will ask you tomorrow. Tomorrow you have a very interesting session of Pico, and the stalwart of Pico, Dr. Ormond and Dr. The machine has come, so you will have a guide demonstration of this thing, and you will have the circuit running, etc. So feed your ego today. You will have several, that's a new subject, so you will have several questions tomorrow. Take your time, be thorough with it, and have a nice knowledge before you leave this tomorrow. Okay, so it will be a new topic, and everybody should remdesivir was not actually made for COVID. We extrapolated the drug. So actually this echo concept was extrapolated from cardiac anesthesia to COVID. It is, I had used it once on my colleague who had a bronchopleural fistula, just to give the lungs a rest. Right? And she is still alive now. So that's what I'm saying, that I mean, this is something where we can do something to change somebody else's life, and we should be actually going with the motion tomorrow. To do that, you need to do a little bit more. Right? We have Dr. Our medical superintendent with us, Dr. Rajesh Chatterjee along with us, and he has been to us through all this so that he helped us a lot to conduct this program. Tomorrow, one definite session that you would also like, Dr. Kharvata will be up there with us. Okay? And we will be going through very common topics like allotropes, vasopressors, which we all use, but Dr. Shushru Bandhavada will tell us something different about it. Right? And can you tell me which of the following allotropes raise your lactate? Lactate, ABG? Not adrenal. Oxygenation adrenaline. That is why adrenaline went out of favor to be used as a allotrope. When we started cardiac anesthesia, usually we started with adrenaline. By time, adrenaline went out of favor and noradrenaline came in. Initially, the concept was noradrenaline causes vasoconstriction. So if it causes vasoconstriction, why would you use it on a CABG patient when you are doing the vacuum? In lower doses, it would cause rather a coronary vasodilation because it would definitely raise your mean arterial pressure. So the concept over time actually changes. Right? So today we rarely use adrenaline. We do use it, but in a lower fashion. And okay, so we welcome on stage Dino.
এটা কি জুমে করতে হবে? আমার ল্যাপটপটা ইউজ করা যাবে না? রঞ্জনের এখানে স্প্রিন্ট লাগানোর মতো অবস্থা হয়েছিল। কই ওই যা যা বললে আসে ডাকো। তাহলে আমারটা কি করে ইউজ করব? আমার এইচপি প্রেজেন্টেশন ভিডিওটা অলমোস্ট 12 GB, মানে জাস্ট সব তো দেখানো যাবে না, বিকেলবেলা কি অত দেখানো মোটামুটি। ওকে, সো
TV.
আমার ডেস্কটপ খুললাম এইটা ডেস্কটপ খুলবেন হ্যাঁ ডেস্কটপ ঠিক আছে এটা কানেক্ট করলে এখানে সাইডে ঠিক আছে তাহলে একটু ঘুরে নিয়ে মাইক অন রাখবে ওর আওয়াজ সব বন্ধ করে দিচ্ছি এখানে কি মাইক বাড়িয়ে ফলো বাড়িয়ে Okay, so I hope I interacted with you on the live workshop. বেশি বিকেলবেলায় এতটা ডোজ দেওয়া ঠিক হবে Okay, so probably you have gone through some co-importance in intensive care. This is one done. I'm not going to the details of the hemodynamic calculation because even if I have to go for a hemodynamic calculation, we actually need a 3D mapping. Without the 3D mapping, we cannot come to a confirmed conclusion regarding the EF is concerned because these Simpson's formulas and other it's almost not of that much of existence. So before we go to because it's now 4:40. Probably I try to wind it up in 5 or 5:10 maximum. That is unnecessary over torture because I know that torturing people are testing from the morning. Speaker so anyway, exactly. It's true about yeah. So এখন ওই টর্চারটা পেরিয়ে এসেছি তো অনেক দিন এখন আর সেগুলো হয় না কিন্তু আমি খেয়াল রাখি সবসময় যে উত্তর দিকে যারা বসে আছে তারাও মানুষ তো এবারে প্রশ্নটা হচ্ছে যে while we are actually standing right now, that's the most important. See, you have in one hand you have an echo, in one hand you have some fancy monitoring system, you have some basic monitoring system, you have some probably we have an interaction about an artificial intelligence যেটা নিয়ে এখন কাজ করছি এই যে galaxies of entire monitoring system, the first thing you have to know where you are actually standing. কারণ যে কোনো জিনিসের আমরা জানি যে পেলে ভালো হয়. Suppose I am telling you a patient has admitted having a history of the bad heart, came with some medical problems, admitted in intensive care, and the first day I want a flow track, I want an arterial catheter, and I have to do this. Simply not done. So one thing, you need to keep yourself in a position where the things is actually viable for that particular situation. কতটুকু করতে পারি, কতটুকু করা যায়, this is extremely important. কিন্তু জেনে রাখতে হবে যে কতটুকু হতে পারে, right? Before I start my presentation, our presentation is majority technical presentation. So the first thing you need to know where you are actually standing. So সারাদিনের আজকে যে প্রেজেন্টেশনটা হয়েছে তার মধ্যে probably by this time you know the basics of an arterial line and what are the waves interpretation, what are the, that's why I started transducer settings and other, at least কি হয় জিনিসটা ধরো তোমরা এলে বলে যে সিস্টারকে সিস্টার আমি একটা arterial line, আর বিশাল বড় বস তুই এসে বলে আর্টিরিয়াল লাইন দেবে, সিস্টাররা কাঁপতে কাঁপতে একটা বিশাল করলো কিছু একটা, ঠিক আছে, একটা বিশাল ভাব নিয়ে বেরিয়ে গেলে, তুমি কিছু জানো না সেটা আমিও জানি তুমিও জানো, কিন্তু আমি ডিসপ্লেস করছি এখানে গল্পটা। প্রশ্নটা হচ্ছে যেমন ধরো আমি কার্ডিয়াক ক্রিটিক্যাল কেয়ারে কাজ করছি 19 বছর, তো মোটামুটি অন অ্যান্ড probably not almost I have conducted almost 13,000 plus cardiac surgery until now. I have given almost 3,000 plus pulmonary artery catheter almost already. কালকে তোমাদের সিস্টেম কম্বোটা দেখিয়ে দেবো, ওটা রয়েছে, ওটা তোমাদের দেখানো হলো না। তো প্রশ্নটা হচ্ছে যে it's not only the question of experience, আজকে যেটা তুমি দেখলে যে এত ইজিলি প্রত্যেকটা ওয়েভস দেখতে দেখতে যাচ্ছ ডিফারেন্ট চেম্বারস অফ দ্য হার্ট, ইটস নাথিং বাট আ প্র্যাকটিস। এবারে কোনটা ভালো কোনটা খারাপ সেই কন্ট্রোভার্সিতে আমি যাচ্ছি, তাহলে 10 দিন ধরে ওয়ার্কশপ করব, এটা সেম। So we have enough of things. So right now you have completed the basic monitoring system, you have completed, understood what are the indications and what are the available in the clinical practice, কোথায় ইকোনমিক্যালি ভায়াবল হবে, হসপিটাল বা তোমার সেই সিচুয়েশন তোমার পারমিট করবে কিনা, কমফোর্টেবল তো বাংলায়। আমার আবার এই 20 মিনিটের লেকচারটা ইংরেজিটা পেশেন্ট একটু আবার রিপিট নিয়ে বলে যে আমারে দিয়ে গেল আজকে আমার বাংলা বুঝতে পারে সব, টোটাল বাংলা তো। তো ব্যাপারটা হচ্ছে যে আগে মানেই বলছে আর রিপিট সিটি হয়েছে এখানেই কাজ করো না। The most important thing is ওইদিন কারেন্ট ছিল না 2 ঘন্টা, ওই দিন একটু রেসপন্স করছিল, কারেন্ট ছিল না 2 ঘন্টা, এখন আবার রেসপন্স এখন হ্যাঁ ওই সময় ছিল, ধরা পড়েছে আমার সময় হতে হয় বাস এগুলো সিএসএফ কালচারে কিছু ধরা পড়েনি স্যার। আপনারা আপনাদের দিক থেকে মিউট করে দিন, এক্সকিউজ মি, আপনারা মিউট কিছু রিপিট হচ্ছে, আপনারা মিউট করে দিন প্লিজ। রাইট ও হয় বড় বড় জায়গায় চলে যেতে। তো ব্যাপারটা হচ্ছে যে now my portion in coming 20 to 25 minutes maximum will totally concern about the different types of monitoring that exists, যেগুলো ইউজ হয়, যেগুলো আছে যার মধ্যে কোনো হাইপোথেটিক্যাল ব্যাপার নেই। এবারে usually আমাদের যে মনিটরিং সিস্টেম what we are existing, we are actually divide them on the basic and advanced, invasive, minimal invasive and non-invasive. So this putting an arterial catheter, putting an pulmonary artery catheter, যেগুলো তোমাদের মুখ থেকে আমি দেখলাম, these are all comes under the heading of an invasive monitoring. I am again telling I am not going to the advanced or basics and other. See, even if you say an echocardiography ejection fraction is a basic one. If you want to treat a patient properly, we simply don't look at the age. We see the history of the patient, we see the cardiac dynamics, we see the ventricular septal thickening, we see the diastolic dimension of the heart, then we come to a conclusion whether this is a good or a bad. So the days are actually changing because you have so many values just to corroborate, and everything has come with a basic caption line. The days you are entered is an evidence-based era. You cannot do anything without justifying that this is actually important for the patient and this is rationally justified. So even if we have the monitor to that level, as well Pico and other things that are देखी तो बैठ पड़े, to the level, अरे ऑडिट वाला भी चले गए, ओके Pico monitor का नाम क्या है इसमें, चले गए, तो एक काल को Pico स्टेशन है एक बार, ओके, so कोई तो रहे আরে বিকাশ ওই যে মনিটরটা একটু আনতে পারবো ওই আইসনের সবুজ স্লাইড উপর ওটি থেকে পাঠিয়েছেন ডেফিনেটলি আমি পাঠিয়ে দিয়েছি ইভেন ফ্লো ট্র্যাকটা আমি নিয়ে করতে পারি এক সেকেন্ড সময় চলে যাচ্ছে তোমরা এরপর বলবে এক সেকেন্ড প্রোগ্রামটা নাম করলে ওরাও আমার সবথেকে খারাপ লাগে কালকে সিমুলেশনটা ওরা এত বিষয় হ্যাঁ বলছিলাম যে ফ্লো ট্র্যাকের মনিটরটা একটু দিয়ে যাবে ইনভেস্টমেন্ট অডিটোরিয়াম বা কাউকে দিয়ে পাঠিয়ে হ্যাঁ 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 জাস্ট দিয়ে যান okay so we are actually dividing the entire monitoring thing in invasive, basic invasive or the minimal invasive and the non-invasive one. Non-invasive one I am not discussing. অত সময় নেই we have a galaxies of the monitor নামগুলো একবার বলে দেব যদি কোনো দিন নিউজ সাইট ব্যবহার হয় সে তখন দেখা আবার যখন করব তখন সেগুলো নিয়ে so we are actually going our phase of discussion invasive that you have shown directly from the OT part of the non-invasive minimal invasive also. So here we discuss a bit of details of the non-minimal invasive one. Okay. So second portion, the role of artificial intelligence. কালকে আমি পারবিতা discuss থেকে 15 সময় চাইছি we'll discuss now. বোঝার কিছু নেই আমি কিন্তু আবার বলছি যে তোমার আমাদের উদ্দেশ্যটা হচ্ছে যে এক্সিস্টিং টেকনোলজি গুলোকে জানো যাতে ভবিষ্যতে আকাশ থেকে না পড়ো আর যদি পাও তখন at least prepare a platform whether we can use it or not because there are lots of peripherals চাইলেই যে সব সময় ইউজ করা যায় তা রাইট এই যে তোমাদের পিকো টেকনোলজিটা দেখালাম এই ক্যাথেটারটা খুব সস্তা এই ক্যাথেটারটার দাম হচ্ছে 8000 টাকা ওই ছোট চিপ আর যে ট্রান্সমিশনে যেটা লাগানো ছিল ওইটা আরো সস্তা ওটার দাম 28000 ঠিক আছে তো বুঝতেই পারছো তো তুমি ধরো 36000 টাকার একটা ডিভাইস লাগিয়ে তোমার উপরে জল দেওয়া এটা তো একটা অন্যরকম এক্সপ্লেনেশন আসতেই পারে তো যাক চলে গেল লোকটা আচ্ছা যাই হোক সো this is the first monitor I can say this on my first slide কখনো ভুলবে না although might some consider the electronic devices is the only cardiovascular monitor but for a fundamental basis of circulatory monitoring it's the eyes hand and ears of anesthesiologist এটা লিডারের সেকেন্ড ইয়েতে 6th এডিশনে যখন হচ্ছে তখন এটা লেখা হয়েছিল এখন যেহেতু নামটা পেরি অপারেটিভ ফিজিশিয়ান এবং ইন্টেনসিভিস্ট ঢুকে গেছে সুতরাং anesthesiologist অথবা ইন্টেনসিভিস্ট বসানো so never in your life ignore these things eyes ears and hands of your anesthesiologist মানে ইন্টেনসিভিস্ট তারপরে কিন্তু তার মনিটরকে কোনোদিন লাইফের প্রেফারেন্স দিয়ে মাথা দেবো ঠিক আছে okay so we started our journey for putting the finger on the pulse and this is one of the finest slide I want to show you because I like this slide very much আমি প্রেজেন্টেশনটা কালকে একটু চেঞ্জ করেছি কারণ আমি যখন শুনলাম যে কি ধরনের মানে কারা আসছে সেই হিসাবে if we divide the entire cardiac physiology it actually the cardiac cycle Number 2 is the pressure volume flow. Number 3 is the coronary circulation. Number 4 is the conduction arrhythmia, and number 5 is the cardiac output. So if we can manage these 5 pillars together, one after another, taking care and giving them a proper importance, actually the entire dynamics is actually normal. And now you can easily understand we are dealing with this 5th pillar, and among this 5th pillar, we are dealing with only a very smallest portion that is called minimal invasive cardiac output. So this was my introduction. কারণ সবার আগে তোমাদের জানা দরকার যে লোকটা এখানে দাঁড়িয়ে আগামী 2 মিনিট তোমাদের বোর্ড করছে সে কি করছে, where you actually stands at the end of the entire day. You are stand in one of the smallest pillar of the 5th major pillar of entire cardiac. Right? Fine. Okay. So if we start with the optimization of a cardiac output. So usually the optimization of cardiac output is totally encompassed with a preload and contraction. আমার এই স্লাইডস গুলো একটু ফিজিওলজি ভাষা, তা না হলে তোমরা কোনো ইন্টারেস্ট পাবে না। আমি এসে দুটো গ্যালাক্সি টার্ম বলে ছবি দিচ্ছি, ঠিক আছে? তারপরে এই সিঙ্গারার যা স্বাদ তোমার আমার মানে ঠান্ডা লাগো, কিন্তু আমার মনে হয় একটু ডেপথে ঢোকা ভালো, যাতে কালকের আমি যে লেকচারটা আর্টিফিশিয়াল ইন্টেলিজেন্সের উপর দেব সেটা তোমরা বুঝতে পারবে, একেবারে আকাশ থেকে না। Right. So if this preload and contractility is together, that comes to the Frank-Starling mechanism. Right? আমাদের এখানে পোস্ট ডক্টরেট স্টুডেন্ট আছে ক্রিটিক্যাল কেয়ার মেডিসিন, ওদের পড়িয়েছিলাম এটা হ্যাঁ ওরা ভাই বলাটাই রয়েছে। ফ্র্যাঙ্ক স্টার্লিং ল মোটামুটি সবার জানা, যারা এমসিকিউ দেবে তাদেরও জানা, যারা এমসিকিউ পেরিয়ে এসেছে তারাও জানা। এই একটা পার্টিকুলারলি ভলিউম দেওয়ার পরে usually the cardiac output increases, but it's up to a particular level. After that, if you chase volume, the cardiac output comes down. Right? So this you see the very nice animations. We have given a volume like a V, we're getting a straight stroke volume of this. We are chasing more volume to the patients, and we are getting less stroke volume. We are chasing more volume, the cardiac output has come down. And based on that, we create a target area. This target area is the most optimized and safest for that particular individual. আমাদের সবসময় টার্গেট থাকবে ভলিউম ওয়াইজ বা আয়নোট্রপ ওয়াইজ, we want to keep ourselves in that particular target area. Now see, if I go for a bad heart, we are giving the same volume, you can see the stroke volume is much less decreased. We are giving the same volume, the stroke volume even much less. So the target area is very narrow. So that's the reason a poor contractile heart fails very fast in chase volume. So if we make it a reverse one, for a high contractility, if we are giving the same volume, we are chasing more stroke volume, we are giving the same volume, getting a more stroke volume, and target area has increased. So that's the reason if a patient comes with a good heart in a bad condition, if you accidentally chase a liter of the fluid, patient have nothing. The heart actually acclimatized because you have a wider target. Now you can easily ask me why I have discussed so much about this Frank-Starling mechanism. Because this is one of the integral part of all advanced monitoring. তোমাদের যে মনিটরিং এর ছবিগুলো দেখাবো তাদের প্রত্যেক কটাতে দেখবে স্টার্লিং কার্ভ দেওয়া আছে। এটা আমি যদি সিমুলেশনটা করাতে পারতাম তাহলে তোমাদের আরো ইন্টারেস্ট হতো যে তোমরা ফ্র্যাঙ্ক স্টার্লিং কার্ভ ধরে ধরে ফ্লুইড অপটিমাইজ করতে। So we are going up to that level, right? Okay. So we have discussed invasive and less invasive PA catheter you have seen, GOE you have seen. Esophageal Doppler তোমাদের দেখাতে পারি, this is one of the monitor that actually gives a very nice, it actually works in a principle of the GOE, but it has a bit of diaphragm interference. If the patient have a slightest of the movement, esophageal Doppler doesn't work. So it's actually a more of a use in the Western world rather than that. Western world and patient it's not like that. The more important thing, how you are more habituated. It's they are more in towards the phase of the general anesthesia by mobilization of the patients and other. So they are very much fond of this esophageal drops. Thoracic impedance and bioimpedance will discuss if we get time. And lastly, Pico and Litco, আমরা কিছু ছবি দেখিয়ে দেব আগে কিছুটা তো তোমরা Pico দেখেছো। So PA catheter আমি এটা নিয়ে আর কোনো রকম কিছু যাচ্ছি না কারণ ওকে নাও PA catheter তোমাদের 4-5 মিনিট একটু ছোট্ট করে আমি বুঝিয়ে দিই জিনিসটা সেটাতেই হবে। Trying my level best to make it as simple as possible. You have seen the simple variety of the PA catheter. The next variety of the PA catheter that actually gives us a galaxies of the hemodynamic parameter. For example, we have thermodilution PA catheter, the next step. There are two types of the thermodilution PA catheter. One is intermittent thermodilution, another is a continuous thermodilution. What's the funda behind this? You are giving an injection or you are giving a thermic charge which is called a therm. That goes to the right atrium. This therm is getting diluted. That's the term thermodilution. And the change of the temperature is being detected by a thermistor placed at the tip of the pulmonary artery. Whenever we are chasing this volume intermittently, we have to give 3 injections for intermittent thermodilution cardiac output. Sounds clear? So every injection will give you a shape like this. The shape has some importance. For example, we give an injection, it will give a curve like this. You give an injection, it comes like this. Even by seeing the curve, you can say if the patient is having a high cardiac output, so the cold saline injection will go very fast from the RA to the RB to the PA. So it's giving a curve like this. Area under the curve is small. And if it is large, it takes more amount of time. So by even seeing the curve structure, you can say whether the patient is low cardiac output or high cardiac output. I'm not going to the value. This is our observation. And you have to give an injection for 3 times. And these all machines usually starts with the height and body weight, so it actually calculates the BSF, and it's just like a buy one get one free concept. If you get a cardiac output, you will get an index, you will get an SBR, you will get an index for this. So it's nothing galaxy. The machine is simply just multiplying with the BSF and give the next value. So with this 3 injection, you need to select nearest of the 2, and the machine will give you the cardiac output and index. Now, this intermittent thermodilution catheter have a lot of fallacies. The fallacies are something like that. Now, Ami are monitor, right? Patient. Can anyone give a guarantee that Amba Kujone Jodi 3 injection B will give in a same pressure, same force, same time, and same interval? Even I do by myself the same thing. Can I give the guarantee of the same that every time I will give a same pressure, same force, same time, and same duration? Not possible. So there are a lot of observer variability, and simultaneously there is a chance of excessive amount of the volume overload for a bad heart. So the intermittent thermodilution PA catheter is obsolete. Even annals আমার আর্টিকেল যদি দেখো তোমরা আমরা যেটা ডায়াস্টোলিক ডিসফাংশনের উপর পড়েছি যেটা এখন দুটো জায়গায় ইউরোপিয়ান জার্নালে সাইটেড হয়েছে I did the entire thing in intermittent thermodilution তারপরে জিনিসটা অবসোলেট হয়ে যায়. We then went to we then went to the continuous thermodilution PA catheter. You can see this is the catheter. So a catheter ki hoy, you can see a thermic filament. So this thermic filament at a regular interval discharges things. So no fluid, nothing. Again the principle is same, so it's discharging actually. That's why it is a continuous thermodilution pulmonary artery catheter. And এখানে দেখো thermistor ছাড়া একটা thermocouple থাকে because thermistor is for taking the heat change, what is the temperature change, and thermocouple we need for the discharge of it. Okay, so আমি চেষ্টা করছি তো কারণ এটা যারা কার্ডিয়াক ক্রিটিক্যাল কেয়ার করে তাদের ক্ষেত্রে আমাকে অন্যভাবে বলতে হয়। আমার মনে হয় এই গ্যাদারিং এ এভাবে বললেই তোমাদের পক্ষে সুবিধা হবে ব্যাপারটা, রাইট? সো whenever you have got a cardiac output and cardiac index, you need to fill up another 5 parameters. তুই চাপ নিস না পূর্বাস, অসুস্থ হয়ে পড়বি, কালকে ডিউটি আছে, ছেড়ে দে, এগুলো অত নিস না। তো তো ব্যাপারটা হচ্ছে, what are the 5 parameters you need to feed from the monitor? Heart rate available in the monitor, mean arterial blood pressure মনিটরে পেয়েছো, mean pulmonary artery pressure পেয়েছো, সেন্ট্রাল ভিনাস প্রেসার তোমরা দেখতে পাওনি কিন্তু আমাদের থ্রি ওয়ে কানেকশন পুরো সময় করা ছিল, তোমরা পেয়েছো। These are the values you need to feed it up. যেই তুমি ফিড করলে, it will give you cardiac output, cardiac index, stroke systemic vascular resistance index, pulmonary vascular resistance index, left ventricular stroke wall index, right ventricular stroke wall index, stroke volume variations, and lastly the right ventricular stroke wall index. And if we go to the combo catheter, it will give you simultaneously the facilities of the patient. Right? So these are the things we are using. I'll show you the combo catheter. Why we use this catheter? Because see, we probably, I must say, me, Dr. Kapusa, we have a first experience rather of putting an VAD in Eastern India when I was in Maryland. So as a clinical director, so the thing is, almost 36 hours I did this thermodilation PA catheter just to analyze the pulmonary vascular resistance and its reversibility with the anodialysis. Right now the levosimendan is not available. It was one of the finest drug I have ever seen in the cardiac critical care. I don't know why we didn't stop. We are chasing for the mid-renonance and other things. We chase that particular patients with levosimendan. So these are the drugs. We need to see the reversibility, and simultaneously with the reversibility, we coin whether this particular patient is a fit recipient for a heart transplant. This person is fit recipient for getting an LVAD or an RVAD or a BiVAD. Apart from that, it has its own role in the cardiac critical care. Right. Okay. So we won't spend much of our time. আমি সেই যা যা স্লাইড আছে এগুলোকে একসাথে মুখে বলে দেব, বারবার ছবি দেখে টাইম ওয়েস্ট করার কোনো মানে হয় না। ছবিগুলো দেখতে পাচ্ছ এখানে, দিস আর দ্য মনিটর হাউ ইট কামস, দিস আর দ্য গ্যালাক্সিস অফ দ্য প্যারামিটারস। এখানে দেখছো যেগুলো স্টার মার্ক দেওয়া আছে সেগুলো মনিটর থেকে পিক আপ করছে, যেগুলো নেই সেগুলোকে আমাকে ফিট করতে হয়, তখনও বাকি ভ্যালুগুলো দিতে থাকে। নাও ট্রান্সএসোফেজিয়াল ইকো আমি আর যাচ্ছি না, শুধু these are the one of the important mapping what I use particularly in 3D that gives an actually estimations of your ejection fraction. This is a 3D mapping. Okay. So the static and the dynamic I am not going. Okay, we'll go to the APCO algorithm. So the next one is an APCO algorithm. APCO algorithm হচ্ছে এইটা, যেটা তোমরা ফ্লো ট্র্যাক দেখেছিলে আজকে দেখেছি। Flow track এর APCO algorithm কিছুই নয়। APCO algorithm is an arterial pulse control algorithm. This is the oldest monitor, right? এখন যেটা চলে এসেছে সেটা হচ্ছে হিমোস্ফিয়ার। হিমোস্ফিয়ারটাও আমার ওখানে আছে, আপনি হিমোস্ফিয়ারটা দেখাও, মনে করে দিও আমাকে। তোমাদের তাহলে অনেকগুলো দেখানো বাকি থাকবে, কালকে হিমোস্ফিয়ারটা তোমাদের দেখি। সো দেখো স্লাইডটা খুব সিম্পল ওয়েতে বানানো, মন দিয়ে পড়ো, কোনো রকম বুঝতে অসুবিধা হবে না। Stroke volume is directly proportional to the pulse pressure. Number 2, from this we can see pulse pressure is SBP minus diastolic blood pressure. So there is an increase in the stroke volume will be shown by an increase in the pulse pressure. So there is an intricate relationship, stroke volume and pulse pressure. And that gives the stroke volume variation and pulse pressure variation. And that's actually the build-up of artificial intelligence. Starting. So we also see the compliance. Now compliance কি আমি আজকে কিছু বলছি না, compliance আর elastance বলার জন্য সকালবেলায় এর মাঝরাতে না, ঠিক আছে? So this is how the stroke volume variation is get calculated. We continuously see the SVV, তোমরা মনিটরে হয়তো দেখেছো যখন লাইভ তোমাদের দেখাচ্ছিলাম ওটি থেকে, ঠিক আছে? This is the pulse pressure variations. And now this is actually VGU is a brand name. This is nothing. এই যে মনিটরের ছবিটা দেখছো, যে মনিটরটা তোমাদের সামনে রয়েছে, এটা is an oldest monitor. So nothing. Arterial and the venous transducer ছাড়া we need to put a separate transducer to replace that, and that's called the flow tract. And this flow tract is actually impregnated with this APCO algorithm, and this APCO algorithm had some fallacy but not now. This is how the things come. This is the transducer picture. Now, how it comes, this APCO algorithm, when it calculates or computes the stroke volume and the pulse pressure variations, it usually takes the compliance. একটা কথা বলা আছে compliance. Now, what the compliance example is? ধরো একজন 70 বছরের লোকের আর্টেরিয়াল কমপ্লায়েন্স একজন 30 বছরের লোকের কমপ্লায়েন্স এক হতে পারে না। ঠিক আছে? ম্যাডাম অসুস্থ নয় তো? আচ্ছা, ঠিক আছে। আর কিছুক্ষণ, বেশিক্ষণ না। আচ্ছা, তো আমি বুঝতে পারছি। Anyway, compliance টা এক নয়। But now the thing has come, whenever you are actually planning to use this particular machine, তোমার একটা প্রশ্ন আসতেই পারে, তাহলে আপনি দুটো পেশেন্টে বা দুটো এজ গ্রুপের লোকের আর্টেরিয়াল কমপ্লায়েন্স এক কি করে করছেন, যেখানে আপনি পালস প্রেসার ভেরিয়েশন মেনটেন করছেন। So there must be some fallacy. কিন্তু দুটোকে এক করতে পারো না, অথচ প্রিন্সিপাল ইউ আর কিপিং দ্য পালস প্রেসার ভেরিয়েশন, তার সাথে স্ট্রোক ভলিউম ভেরিয়েশন ইজ অ্যান অ্যাপ্লাইড ক্যালকুলেশন, ইটস নট আ ডাইরেক্ট ক্যালকুলেশন, ইটস স্টার্টিং উইথ পালস প্রেসার ভেরিয়েশন। এবার তুমি বুঝতে পারছো আর্টিফিশিয়াল ইন্টেলিজেন্স এগুলোকেই আস্তে আস্তে কম্পেনসেট করেছে। সেটা কালকে বলবো, তখন আরেকটু সুবিধা হবে বুঝতে, কারণ এটা তো জানা থাকছে। So that now the thing is that next generation PC, which is called an EV1000 platform, they have actually internally compensated this compliance issue. And that's why now, irrespective of age and other things, you can use this flow track for getting an APCO algorithm, forgetting about the compliance issue. Every 20 seconds interval it updates. সুতরাং একটা পেশেন্টের এক্সিস্টিং আর্টেরিয়াল এন্ড দ্য সেন্ট্রাল ভিনাস ক্যাথেটার তো আজকাল মানে যে কোনো সময় হতে পারে, পেরিফেরাল লাইনের থেকে কম, একটু ভালো জায়গায় ইন্টেনসিভ কেয়ারে যারা কাজ করে, রাইট? সেখানে যদি আমরা একটা ফ্লো ট্র্যাক দিতে পারি, তাহলে সেটা কিন্তু এভরি 20 সেকেন্ডসে যদি আমাকে একটা কার্ডিয়াক আউটপুট, তোমাদের মনে আছে আমি খুব ভালো করে আজকে ডেমনস্ট্রেট করছিলাম, you are seeing the 90 blood pressure but you are seeing a 5.3 cardiac output. So actually you should not chase anything, but your stroke volume variations is continuously saying, that's a Sterling curve, is continuously saying that you need to give volume. We started blood to the particular patients, you are seeing the CVP has come down. Have you ever seen your life that you are chasing volume, the central venous pressure is coming down? It shows. That's the evidence-based practice. You need to understand and you need to coin yourself. আজকে সারাদিন বাদে কোথায় দাঁড়িয়ে আছে এক্স্যাক্ট। আর একটা লেকচার ঢুকতেই পারে মাথায়, কিন্তু আমার বারে বারে মনে হয়েছে শিডিউলটা দেখে তোমাদের একটু সামারাইজ করে দেওয়া দরকার লাস্টে, মানে at least কিছু পেয়েছো সেটা ভাবে বাড়িতে যাও। So that's why we started chasing the volumes and other patient. We stopped inotrop, we chase volume, just go upstairs and see the patient right now. Patient is having 145 blood pressure, only GTN support. Nothing is there. The patient has got 1 unit of blood, only the fluid therapy is fantastic, and the CVP is only 4 millimeter of mercury. এবারে প্রশ্নটা হচ্ছে, তাহলে কি ফ্লো ট্র্যাক ছাড়া কিছু করতে পারবো না? এইটা বাস্তব প্রশ্ন। তাহলে তো স্যার সবগুলোই মিসম্যানেজ হচ্ছে। আমরা তো পরিষ্কার কথা ভাই, সিভিপি 1 দেখে জল দাও, 6 দেখে দিও না, ঠিক আছে? But somewhere you need to accept যে প্র্যাকটিসটা প্রিভেন্টিভ, কারণ এই অ্যালগরিদম গুলো অনেক দিন ধরে আস্তে 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 একটা জায়গায় এসেছে। So now you are getting, that's why I showed you, that's why even this machines has a persistent disadvantages, as because it takes care of a pulse pressure variation as a built-in block. So obviously a patient is having atrial fibrillation, a patient is having on intra-aortic balloon pump, having some VPCs more than 6 per 1 strip, usually this patient doesn't work. And it's the finest of pictures, whenever he starts getting AF and other, the machine is actually become a black and white from color. So you can understand all the features and others get suddenly black and white. It's not picking up. Again, it's come to the sinus rhythm. Again, it's comes. And it's one of the very favorable. Your nursing staff or any other bedside staff only touch the monitor. It every 20 seconds gives you an update. So that's why is because of the 20 seconds তোমরা অতটা ভালোভাবে বুঝতে পারলে the CVP টা 4 থেকে 2 দিয়ে এলো fluid দেওয়ার পরে and suddenly the BP has comes up and ultimately the heart rate has comes down. Right, okay. So this is how the flow track is been getting assembled. তোমরা শুধু এই অ্যাসেম্বলটা দেখতে পারো, তার কারণ হচ্ছে আমাদের ক্রস কেবলিং এর প্রবলেম ছিল, সেই জন্য আমরা দেখাতে পারিনি। এই কেবলটা দিলে we could have show you the systemic vascular resistance also. Right, okay. So this is the next generation. When in this monitor the entire compliance issue has been internally compensated. Okay, so you can see the cardiac output index SVR and SVR. You need to feed all the values and other. তোমাদের একটা ছোট্ট ভিডিও আমি দেখিয়ে দেব পরে এভাবে আসে জিনিসগুলো। So once you connect it with an arterial catheter, you can see these three values is automatically starts coming. And whenever we completed the entire thing, we can see this arterial and the central venous catheter has been connected. I zeroed them. You can see this is a live. এটার মধ্যে কিন্তু আমার কিন্তু কোনো ছবি এডিটেড নয়, সবগুলো আমার নিজের করা, আমি নিজে করছি এবং ডাইরেক্ট তোলা আছে। Right. So arterial line gets 0. Okay, so monitor picked it up. So you go to the home screen. We'll wait for a few seconds. That's something. So every 20-second intervals, it goes on updating. Right. So the last portion today, সময় আমার অলরেডি পেরিয়ে গেছে 2 মিনিট এক্সট্রা, আমি আর 5-7 মিনিটের মধ্যে ছেড়ে দেব পিকো দিয়ে আমি শেষ করব। পিকোর ক্ষেত্রে জিনিসটা তোমাদের বলে দিই, ফান্ডাটা কিছুটা তোমাদের ওখানে বলেছি। It's again the thermodynamics. Right, it's again the thermodynamics, but here we usually put a catheter that changes the temperature in an arterial case. মেশিন সব সময় অনেকগুলো সাইড দেখায় যে তুমি ব্রেকিয়ালে দিচ্ছ কিনা, তুমি রেডিয়ালে দিচ্ছ কিনা, তুমি ফিমোরালে দিচ্ছ কিনা, but for a proper assessment we actually need to put a femoral case. Right, এবং এটাও কিন্তু এখন আমাদের পুরো স্টাডির মধ্যে আছে, কারণ আমাদের আর্টিফিশিয়াল ইন্টেলিজেন্সে আমাদের ট্রেনিং হয় একটা, দ্যাটস আ ভার্চুয়াল ল্যাব ট্রেনিং। ভার্চুয়াল ল্যাব ট্রেনিং এর জিনিসটা কি হয় আমি বলছি, কালকে তোমাদের যদি পারি ছবি দেখাবো। We are being shown with a 200 ml of fluid challenge in an electron microscope how much the gut mucosa has inflected. So starting from a gut mucosa to your arterial blood pressure, I'm just not artery the non-invasive blood pressure. Okay, so you can see the pathway of the trunks, and that shows how millions of permutation combination is required from getting an electron microscopic blood flow analyzer to the level of arterial blood pressure what you see in this carefully. So it's a long path. কত মাথা কামাতে হবে, it's just the peripheral things যা হয় সেটা বোঝানোর জন্য। Okay, so the transpulmonary thermodynamic Barber contracts. Pico technology is nothing. We put a central venous catheter. We need to put a specialized arterial catheter, and this arterial catheter is thermistor tape. What the catheter I put? It was a thermistor tape. তোমাদের পুরো ভ্যালুটা আমি কেন দেখাতে পারিনি তার কারণ হচ্ছে it's a very technical issue. It was actually a pediatric catheter. So that's why we had to give a huge amount of saline just to reach to that level of the thermodynamic. So that's why it's continuously showing after the first data it's an invalid. That was the only technical glitch. Okay, because these catheters are very difficult to get arranged and other, particularly make in India হওয়ার পরে খুব মুশকিল আমাদের এগুলোকে প্রকিউর করা। Right, so ফান্ডাটা হচ্ছে you give a cold saline injection, it goes from the RA to the RB to the PA to the LA to the LB to the aorta to the tip of the catheter. So against the thermodynamic, as because it is traversing the pulmonary bed, it is called transpulmonary thermodynamic. So there is no confusion about the terminology and now onwards. Okay, we'll wind up with some of the photographs and others. So this Pico technology usually a combination of the pulse contour analysis and simultaneously a transpulmonary thermodilution together. And why we are more in towards inclination of this type of things, because এতক্ষণ যে ভ্যালুগুলো দেখলে যেগুলো বললাম সেটা মোটামুটি অন্তত 16 থেকে 18টা হিমোডাইনামিক প্যারামিটার দেয়, এটা তোমাকে আরো 10টা দেয়। Intrathoracic blood volume, total blood volume, extrathoracic blood volume, extravascular lung water index, and PVPI, that is a pulmonary vascular permeability. এগুলো মুখস্থ করতে আমার সময় লাগে। সদাশিব সেই ওয়ার্কশপ করে বেড়াচ্ছি প্রায় 12 বছর হলো, সুতরাং এগুলো হয়ে যায়, তোমরাও ঘাটতে হয়ে যাবে। And why we are so much inclined on that? Because extravascular lung water is one of the very important predictor in intensive care, particularly to identify between an cardiogenic and non-cardiogenic pulmonary edema. And this pulmonary vascular permeability index shows you if you chase 100 ml of fluid or 200 ml of fluid in a poor heart or in an ARDS patient, whether it's creating a cardiogenic edema or it's creating a non-cardiogenic edema. Rather to guide you the choice of the fluid therapy, what type of fluid chosen for that particular individual. Right. So this is how the things look like. This is the volume view. It also brand name. It is Edwards the brand name volume view. It is also hemo view. Mind. So je ja pare ne. Ami kulle Surendra view rakho. Acha. This is actually how the thermistor gate catheter looks like. Right? This is how the connection. কিছুটা মনে পড়ছে আজকের মতোই কানেকশনটা ছিল। আচ্ছা, this is the entire mount. এখানে কিন্তু আমার সোয়ানো দেওয়া আছে, তার কারণ হচ্ছে এটা পার্টিকুলার কয়েকটা কেসে আমি স্টাডি করেছিলাম between the pulmonary artery catheter data with simultaneously the Pico, just to compare in particular 4 ejection fraction. The low cardiac output, which data is more having the predictive value. This is how the connection has been built up. Okay. তো আমি একসাথে সবকটা ভিডিও অন করে দিই, ইন্ডিভিজুয়ালি দেখানোর কোনো মানে হয় না। Okay, for every saline injection you will have a cup like this. যেটা আজকে দেখেছিলে একটা কাপ দেখতে পেয়েছিলে, এবং যেই তুমি কাপটাকে দেখতে পেলে you need to give 4 injections. Intermittently you have 3, but here 4. On that particular machine used to take the nearest, and you have to do the nearest. সেটা তুমি চয়েস করে তোমার যেটা মনে হয় সেই যেই তুমি নিলে। দেখো, কার্ডিয়াক ইন্ডেক্স, গ্লোবাল ইন্ডাস্ট্রিক ইন্ডেক্স, এক্সট্রা লাং ওয়াটার, গ্লোবাল ইনজেকশন ফ্র্যাকশন, স্ট্রোক ভলিউম, ইন্ট্রাথোরাসিক ব্লাড ভলিউম, সিস্টেমিক ভাস্কুলার রেজিস্ট্যান্স, পালমোনারি ভাস্কুলার পারমিশন. So these are the real values from the Pico technology that comes. ঠিক আছে, এবার বুঝতেই পারছো ইন্ডিকেশন, কন্ট্রাইন্ডিকেশনস এগুলো নিয়ে তো বই পড়িয়ে পড়ানোর কোনো মানে হয় না, সেটা 200 স্লাইড তৈরি করা যায়। আমার ইন্টেনশনটা ছিল টেকনোলজিটা তোমাদের বুঝিয়ে দেওয়া, পরে যদি আবার তোমাদের সাথে আলাপ হয় তখন এক একটা ইন্ডিভিজুয়াল জিনিস নিয়ে নিশ্চয়ই আলোচনা করবে, কেন না? রাইট? সো this is Acumen Hypotension Prediction Index software, the beginning of artificial intelligence. আমি আজকে আমার লেকচারটা এখানেই শেষ করছি, কালকে তোমাদের সাথে দেখা হবে 20 minutes. We'll describe something about AI. Thanks for listening. 7 minute extra. Discount on the এই ট্রলিটা এই জায়গাটা কিসে আমি একটা কথা বলবো, এটাকে একদম করে এই দুটোকে চাপিয়ে করে দাও, আমার কালকে টেবিলটা হয়ে গেলে তখন। আচ্ছা, কালকে প্রবাবলি টেবিলে মনে হয় আমার তো মনে হয় আইবিপি দেওয়া আছে নাকি? কি আছে বলতো? হ্যাঁ
কালকে স্যার আইএমপি আছে, হ্যাঁ আইএমপি আছে, মোটা আছে অসুবিধা বেসিক আইডিয়া
কখন আসবো কালকে
কালকে তাহলে